बुला दो ना. So, very good morning, all. I think it's all just warming up. People are arriving and having their coffee, and they're not allowing coffee inside the hall, so people are waiting. So, I just tried to sort out the matter, but I think it's important for us to start because we are all here. So, very warm good morning to everybody here. Thanks so much for coming. It gives me an immense pleasure to welcome you all to this important scientific session on complementary and alternative medicine in maternal and child health. I extend a very warm welcome to the esteemed speakers, the distinguished guests, and all the participants to share and expand our collective understanding. So the reason today we are together, we are all aware of the strengths of each system of medicine, and we have we probably during the course of our treating a patient are in the habit of also referring, sometimes telling them, why don't you try this therapy. But we as professionals find it difficult to get together to work in one forum, and that is the aim of today's agenda. So we have the speakers, four pathies who are experts in their fields, extremely accomplished, and I think it's going to give us immense pleasure to listen to them and to be able to take this entire discussion forward. So the agenda, other than listening to the speakers, is also to have a discussion as to how we can work together. So from Ayurveda to acupuncture and from homeopathy to mind-body interventions, many of these practices continue to hold cultural resonance and therapeutic potential. And so therefore, like I said, it is important, especially for maternal and child health, to be amalgamating these the systems of medicine. So whether it's addressing hyperemesis gravidarum, managing stress in pregnancy, improving lactation, and providing non-pharmacological pain relief measures during labor. The CAM modalities are increasingly being explored, and not as just adjuncts but also sometimes as the preferred options themselves. So we should be in a position, so it's already taken up in the Western countries where women are offered other therapies. It's not happening in our country, while we have the biggest strength, I think. So that is why today we need to find this common ground. And it is also with a word of caution that our enthusiasm must be balanced by rigor. The need of the hour is robust evidence, critical appraisal, and ethical incorporation of these interventions into the mainstream. And this session aims to bridge the traditional knowledge with modern scientific inquiry to explore what works, for whom, and under what conditions and why. So let's learn, challenge, and collaborate so that we may create a maternal and child health system that are inclusive, respectful, and responsive to the diverse needs of our communities. And once again, it gives me great pleasure to welcome everybody, and we look forward to an engaging, productive, and enlightening session. So thank you all. So thank you so much again, once again, for being here. So we start the session, and it is my with great privilege and honor to have Dr. Basu here. Dr. S.N. Basu is the uh, Principal Director and Head of the Department of Obs and Gynae at Max Super Speciality Hospital. And as you can see, she is extremely accomplished. And the reason for having her here as a special invitee is because our wavelengths totally match, especially in this field of thought. So I think your presence, ma'am, is of immense importance to us. I'm sorry we couldn't, the initial program doesn't have Dr. Basu's name there. And despite all my efforts, it could not be done. But your presence is so important and vital to us, and we look forward to hearing from you uh, to take the future sessions forward. Over to you, ma'am.
Good morning, everybody. At the outset, I must first thank Radhika for having given me this opportunity to speak at this gathering. I must thank the organizers of the World Health Summit and the people concerned, the organizers. I must say the organization has been very good, has been excellent, and we hope that we can probably come to some sort of a conclusion or a deliberation at the end of this, session, and even going forward, so many things. Dr. Radhika quite often and I discuss these things, and we have, as she mentioned, that we seem to be talking on similar grounds all the time. So, honored guests, esteemed colleagues and friends, I am truly grateful for the opportunity to speak today about a subject that is actually transforming healthcare, and that is integrative medicine. Just imagine there is a world where healthcare doesn't just treat symptoms, but nurtures the whole person, mind, body, and spirit. For decades, modern medicine has made extraordinary strides in diagnosis, treatment, and technology. However, we often find ourselves treating diseases rather than patients, focusing on symptoms rather than the root cause. Integrative medicine challenges us to think beyond conventional methods, embracing a holistic approach that combines the best of modern science with time honored tradition and wisdom. At its core, integrative medicine is about balance. It brings together conventional treatments with complementary therapies such as nutrition, mindfulness, yoga, acupuncture, herbal medicine, recognizing that healing is not just about the body but also the mind and spirit. It encourages us towards preventive care rather than reactive treatment, which is what allopathy usually focuses on. But now, of course, preventive medicine has been there, part of our curriculum, but not in a holistic way. Have you ever wondered why stress affects recovery? We all know, don't take stress, just relax, common statement we are making in the OPDs. But how to go about it is what is we need to teach in a structured and a formal manner. So the approach is not philosophical, it is backed now by science, so-called science. We also had science before. Studies show that integrative practices improve patient outcomes, reduce stress, and enhance recovery. They empower individuals to take charge of their health, making informed choices, and this is where we have to work. We had a session on communication, and what we said that, and we was discussing with Dr. Kapoor as well a little earlier, that we need to give patients all options. It is for the concept from a paternalistic form of medicine where the doctor says, okay, this is your treatment and the patient follows are gone. Now it is a patient-centered concept of treatment. And therefore, we must talk about all the options to the patients. It is for the patient to decide which form of therapy they would like to go for. The individual's healing is about balance, not just treating disease and caring for the whole patient. Integration is just not about treatment. It is about people coming together. Physicians, researchers, traditional healers, and patients must bridge the disciplines, creating a compassionate, effective, and sustainable healthcare system. As we stand at this crossroads, let us ask ourselves, Are we merely treating diseases or are we truly healing people? The future of medicine lies not in isolated interventions, but in a unified care. Care that respects tradition, embraces innovation, and prioritizes the whole person. Let's pause and reflect. What kind of healthcare future do we want? Answer lies in unified care, care that respects tradition and embraces innovation. From Ayurveda to acupuncture, from nutrition to mindfulness, cultures worldwide have long understood the power of holistic care. Integrative medicine revives that wisdom, combining traditional therapies with evidence based modern medicine. This approach matters because it prioritizes well being over disease management, creating a more sustainable and compassionate healthcare system. Today, let us take a pledge and let us embark on this journey together, shaping a future where healing is not just about cure but about care. As I stand here today, I urge all of us to rethink the way we approach healing. Let us not just treat people, let us truly heal people. Thank you very much. Thank you.
Thank you, ma'am. Those were truly words of wisdom, and I think the best take-home message in today's world. People are slowly moving away from that humane way of having people, healed. So we move on to the first session of the day today. So it's my proud privilege to invite. Can we have the slides here? Dr. Kaustubh Upadhyay, he is the advisor of Ayurveda in the Ministry of Ayush, Government of India. He has a pivotal role in shaping policies and strategies to promote and regulate Ayurveda and other traditional systems of medicine in India. And his key contributions have been in the place of pharmacovigilance initiatives by the development of National Portal for Pharmacovigilance in Indian Systems of Medicine. He has an important role to play in international collaboration to promote India's traditional medicine system and emphasizing the relevance in global healthcare. And he also has a place in the regulatory framework as an expert guidance on the integration of Ayush systems into the national health framework, ensuring quality standards and effective implementation of policies. So, warm welcome to you, sir. I am also happy to invite Dr. A. Raghu, who is a Deputy Director General of Ayush, Ministry of Health and Family Welfare. He is a senior policy maker and regulatory expert, actively involved in formulating national standards, policy guidelines, interministerial collaborations, and research strategies for strengthening the traditional system of medicine. His key contributions include development and implementation of Ayush Grid and digital health missions, strengthening evidence-based approaches in Ayush through collaborative research, establishment of Ayush clinical protocols under public health programs like Anemia Mukt Bharat and maternal and child health initiatives, and promotion of India's Ayush sector globally through bilateral and multilateral health diplomacies. So, warm welcome to you, sir. And would you like to be here? Because you can also see the screen. So, would you like to sit here? So, I invite you to introduce the speaker, sir.
The speaker, Dr. Deepak Londe, is the Ayush graduate who has been landed by Ministry of Ayush to Ministry of Women and Child Development, and he is doing wonderful job in integrating Ayush interventions for welfare of women and child. And he is a graduate from Government Ayurveda College, Darsav, Maharashtra. He is postgraduate in Ayurveda Pediatrics at National Institute of Ayurveda, Jaipur. He has worked with various research interests including adolescent healthcare, pediatric malnutrition, anemia, health policy, etc. He is member of different committees, and he is one of the key person who was involved in from the inception of the concept to implementation of Poshan Abhiyan, which he will present today to all of us. Mainly, integration comes from the integration of mind. Science is a systematic investigation of things. That's not, Madam has already told, it is not a recent invention. It is there since past many years. Integration happens when you look at any event without any bias. So removal of bias is the key for any investigation or any research. We say in Ayurveda, Rajastamo Bhyam Nirmukta. There should not be bias. Raja and Tama, they are the intervention in acquiring the knowledge. And then Tapodnana Balenaye. You should have a constant efforts to verify and see whether your work it is as per the, and all are not in your control. Especially in biomedical research, it is influenced by so many factors. And we tend to make it convenient to suit that control is as per our requirement. But actually, we are misconception. So many factors are influencing the same event, but conveniently we will segregate these are the controls and remove others. So that's one of the main problem with biomedical research. Then Nanabana. So you have to see various aspects also to decide what is the outcome. So if we do these things, whether it is Ayurveda or whatever the name you call, modern medicine or homeopathy, whatever, it is the same event. We are doing intervention on the same people, same person, they are same. How it differs, that we have to understand. So if we have openness in our attitude, I think we will achieve this integration. I can say, just I will give what happened about 20 years back. We had a reproductive child health event we have taken from the health ministry only. We had designed very good protocol with both the systems, doctors sitting together, very well designed protocol, procedures, program, everything happened. And training of trainers has to be initiated. That also everything has been checked out and it was initiated also. Before completing that, procurement started. Medicines were purchased. All over the country, medicines were sent to the particular health authorities, and they don't know what to do with that. Because I'm a modern system person, I can't use, where is the guidance? So everybody kept, because it has already sent from the government, it was kept with the authorities in the state. And 3 years, this training was also not completed. ANMs and others are not trained. Just before expiry, they have dumped those things in the Ayush Wellness Centers. Now, at that time, it was called dispensaries in all the states. And it was just, entire thing was wasted. So this opportunity, government money, public money was invested. It is because we lack integration in minds. If we are open enough, let's see, these medicines have come, we'll interact with our Ayush directorates, Ayush personals, and with their intervention, if the authorities have taken some initiative to use that medicines for the public for which it was supplied, then something would have come as the outcome. But everybody is compartmentalized. It is not my part of work, so that will waste. So this openness, and our key motive is to give benefit to the public. Now, as on today, almost 20% of gynecologists use systems of Ayush medicines also, even though not officially, personally, because they feel it is in the interest of my patient. And regarding this reproductive health, I will want to share with whether you agree or not, my observation. In all over the country, there are some practices, especially post-delivery care. It is traditionally practiced in the society. And wherever this practice is followed as on today, the reproductive health and post-delivery health of the woman up to the menopause stage will be very good. वो पतला दुबला ही रहते हैं. किधर ये फॉलो नहीं हो रहा है. जैसे शादी हो गया, मैं बहुत मजाक करता था जब दिल्ली में 98 में आया था. इधर तो लड़के लोग बहुत पतले दुबले होते हैं, लड़की लोग शादी के पहले, और लड़के लोग बहुत मोटे रहते हैं. जैसे शादी हो जाता है ये अदल बदल हो जाते हैं. ये मेरा ऑब्जर्वेशन है, मजाक भी करता था. इसका मेन कारण मैंने ये ढूंढा है, मेनली पोस्ट डिलीवरी के. वही हरियाणा का लोग देखिए, रूरल इंटीरियर, दे विल बी लीन एंड थिन इवन आफ्टर मैरिज, आफ्टर डिलीवरी. बट सिटीज में ऐसे नहीं होता है. और यही मैंने ट्रेंड बाद में बाकी शहर में भी ऑब्जर्व करने लगा हूँ, क्योंकि कहीं भी मेरा ऑब्जर्वेशन यही है, कहीं भी ये ट्रेडिशनल प्रैक्टिस वॉट एवर इट्स नॉट इन प्रैक्टिस, this changes in woman's body is taking place, and we are ignoring because lack of knowledge. So this things has to be explored. I request Dr. To initiate Lokesh to start his session. Thank you.
So where is the PPT, ma'am?
ये वाला है.
WHS PPT. Very good morning to all. Thank you, Kaustubh sir, for wonderful introduction. Esteemed panelists, chairpersons, and audience, very good morning to all. I am privileged to present before you on a very important topic of which is a public health concern, that is anemia. Myself, Dr. Deepak Londe, a research officer from CCRS, working in Ministry of Women and Child Development under Poshan Abhiyan. So to begin, I would like to put forth a very important and well-known fact about the iron requirement across the different age groups. So you can see here that, for example, infant of 6 to 12 months need 11 milligram of iron daily. And similarly, kids of 1 to 8 years and adult males of 14 plus years, you can see almost average 8 milligram of iron is daily required to meet the needs. Whereas the adolescent girls of 14 to 18 and women of reproductive age require 18 milligram of iron per day. And in pregnancy, it increases to the triple, that is around 27 of milligram of iron is required daily. I just want to ask a question. So wherever in the country, does anyone know any female or adolescent girls in the family who eat extra portion to require her daily need? Is any adolescent girls who eat extra portion than man? I think the answer is big no. And that's why we are facing a biggest challenge of iron deficiency anemia in the country. What happens is the opposite of that. Actually, women in the family eat lesser than the male, and in the last, so they get the less portion of anemia, and that's why we are facing this major challenge of anemia in this age group. So anemia is not only the problem in India, it's a major worldwide problem. I think globally more than 25% of population is suffering from anemia, and specifically South African countries and Southeast Asia, including India, is having a major contribution to this problem. And again, as you have seen in the last part, it only doesn't affect the typical particular age group, it affects all the age group, but particularly it is a major problem in women of reproductive age and adolescent girls. If you see what problem with anemia is that, see, for example, there is a iron deficiency or anemia in the pregnancy, it leads to, it is a major contribution of a complication during pregnancy and childbirth. Suppose a pregnant lady is having a poor store or less store of iron, so poor storage is observed in the children, which leads to the poor mental growth or development of a child. Again, if a person is suffering from anemia, is susceptible to infection. So these are all are evidences from the research study that anemia is resulting not only in some symptoms, but it affects the individual productivity and costing $1 million to the country. So Due to its long-term and short-term consequences, iron deficiency anemia is a grave concern even today. So if you see the history of programs which are being conducted or which are being run by the government of India for control and prevention of anemia, so it was started in 1970 with the National Nutrition Anemia Prophylaxis Program, wherein focus was supplementation of IFA to the pregnant women, lactating mothers, and children of age group 1 to 5 years age. So in 1997, the RCH program was started, wherein there was some changes to the program, which was integrated under the maternal and child health program. They have introduced screening of anemia and treatment of moderate and severe anemia. Again in 2005, NRHM was introduced, wherein emphasis was given to focus on the system delivery, service delivery of the health services, including ASHA was included in the program for supplementation of IFA. Again in 2012, weekly iron folic acid program was introduced, where it was started mandatory supplementation of IFA for adolescent girls. In 2013, NIPI, what we call as National Iron Plus Initiative, was started, whereas the intervention has been expanded to the life cycle approach. That means they have started supplying IFA from the beginning of the birth, that means from children up to the age of 5 years, then 10 years, then adolescent girls, women of reproductive age. So they have introduced these 6 beneficiaries in this program. And very recently, after launch of Poshan Abhiyan in 2018, Ministry of Women and Health Family Welfare started Anemia Mukt Bharat program, where is the strategy is 6x6x strategies, where are 6 types of interventions provided to the 6 types of beneficiaries through the 6 types of institutional mechanism. So this is the big history of program for anemia prevention, which has been run by the government of India. But what happens? As we have seen that IFA supplementation to the all types of beneficiary was part of a program. However, the progress is very poor to reduce the burden of malnutrition, particularly the anemia. And what you can see that recent NFHS 5 as compared with the NFHS 4, there has been an increase in the prevalence of anemia in particularly children, pregnant women, and women of 14 and 15, women of reproductive age. So there must be a problem that existing programs, and there is the scope for Ayush systems of medicine. Apart from that, as you all know that anemia is a prevention of anemia is a key nutrition, global nutrition target, and it is also indicator of sustainable development 2.2. So there is renewed strategies to meet these global nutrition targets and sustainable global development. Government is working to prevent and control the anemia. Apart from that, there is a National Health Policy of 2017, which laid emphasis on this micronutrient deficiency and also emphasized upon the interventions to prevent this anemia. And the same policy says that the Ayush systems of medicine should be integrated for the prevention of this global health issue or public health issue by conducting rigorous clinical trials or generation of the evidences. But we have seen that there is another scope for Ayush systems of medicine, because poor uptake of iron folic acid and adherence to this IFA supplementation is the biggest challenge in existing public health system. Apart from that, studies have also shown that there are significant side effects of IFA tablets like gastritis, metallic taste, or what you can say constipation. So these significant side effects of IFA results in the poor uptake. These are the gaps in the existing system. Now I will come to what are the strengths. So first, there is a rich history of Ayush systems of medicine, particularly in India, and ample presence of Ayush systems of medicine public health sector, including infrastructures, makes it imperative to use this system for prevention of anemia. But I want to say that there are more than 750 educational institutes which are imparting education and health services to the people. Apart from that, there are more than 12,500 health and wellness centers or Ayushman Arogya Mandis, which are imparting clinical services of Ayush services to the people. And apart from that, more than 30,000 dispensaries of state governments and 4,500 Ayush hospitals and research institutes. So this is the infrastructures and manpower which of Ayush system present in the public health sector apart from the private sector. So there is an ample presence which we can utilize for prevention or manage this issue of iron deficiency anemia. So this slide is typically for not for Ayush persons, but yes, in Ayurveda, there is a mention of a clinical entity which typically resembles with the anemia called as Pandu, and there are different reasons has been mentioned for this disease, and it is typically a pitta dosha. In Ayurveda, there are a concept of three dosha, vata, pitta, kapha. Anemia is typically caused due to the vitiation of a pitta dosha. And there has been mention of the different causes and the treatment for uh, anemia in Ayush systems of medicine. So, coming to the uh, evidences generated by the Ministry of Ayush, different institutes of the Ministry of Ayush for the this anemia prevention or management of anemia. So, Central Council of Research Research in Ayurveda Science is a apex body under Ministry of Ayush, which is responsible for formulation, development, and integration and development of evidences on scientific line in systems of Ayurveda, and it has contributed immensely. Typically in the systems of evidence generation for evidence generation through its clinical research or drug research, literary research, and fundamental research. And various drugs you can see that has been validated by the Ministry of CCRS for its efficacy and safety in the management of anemia. Typically, you can see that Dhatri Loha and then Punarnavade Mandur, or you can say Navaya Churna, Drakshalaya, many sort of medicines have been clinically tested by CCRS through its research projects through intramural research and extramural research. Similarly, the things have not stopped here. Ministry of ICMR under Ministry of Health and CCRS under Ministry of Ayush, they are working in convergence to generate evidences on the issues of public health concerns. And very recently, I think in 2024 or 2023, they have signed an agreement wherein a multilateral or multi-center clinical trial to evaluate the efficacy and safety of Punanavadi Mandur, and alone and in combination with Drakshaleva compared with the iron folic acid in the treatment of moderate and mild cases of anemia among non-pregnant women is started. It is being conducted at 8 centers of medical institute like MJIMS Wardha, Jodhpur, Bangalore. So under this clinical protocol is developed by the jointly by Ministry of ICMR scientists and CCRS scientists, and it is being implemented through these 8 institutes. So you can see initially CCRS has studied on small sample size, then now it is being taken to the next level, that is at the multi-central research trials through integration, or you can say the in convergence with the ICMR. Coming to the next level, there is one scheme of Ministry of Ayush. Initially it was called as PHI, now it is an Ayurswastha. So Ayurswastha is a public health intervention scheme under which different interventions are being tested under the public health scenario. And till date more than 57 projects are being sanctioned by the Ministry of Ayush under these schemes, and out of these you can see there are 5 of typically related with the prevention and management of anemia. And these projects are being run over the more than sample of 5,000. Suppose there is a creating sustainable solution to address anemia in school children. So the first project was completed in 2020, and it was conducted among the school-going children of more than 5,000 children were enrolled in this study. So you can see that starting with the 30 patients of CCRS study, then taking to the 500 trials of ICMR joint trials, then coming to the Ayurswastha programs, wherein more than 5,000 of children are involved for this study. And all these studies, either of CCRS, of ICMR, or the Public Health Initiative, have shown larger safety and efficacy of Ayush drugs for prevention and management of anemia. Taking these clues from all these study, very recently, Ministry of Ayush and Ministry of Women and Child Development entered an agreement, and they have started a large-scale implementation program under Mission Utkarsh. So Mission Utkarsh is a program of Prime Minister's office wherein every ministry has mandated to identify worst performing districts in their area. For example, Ministry of Women and Child Development identified 10 poor performing districts who has the poorest indicators in the nutritional deficiency anemia. And they are supposed to work, they are only 2 minutes. They are supposed to work that we have to improve this Mission Utkarsh district to make them at par state level in 1 year, and at par at the national level in the 2 years. And now we are working in the 5 Mission Utkarsh district through Ayurveda intervention, wherein Ayurveda intervention is provided to the more than 80,000 adolescent girls. This Ayush intervention is for prevention and control of anemia is provided to the more than 80,000 adolescent girls for 3 months, and interim analysis of 32,000 adolescent girls has been completed. It shows significantly improvement for this anemia. So in the last, I think what Basu ma'am has said, if we want to heal the patients, Ayurveda is not only the prescribing medicines. Here the part is about what you eat, how you eat, and how you take what is your lifestyle. So it's not just supplying medicine. It's a holistic approach which I think everyone can look into and consider in their practice, or even government can think to include these Ayush systems of medicine where we can work for the larger benefit of the society. Thank you.
Thank you so much, Dr. Deepak. I invite Dr. Raghu to give his comments, please.
Good morning, all. Thank you, Dr. Radhika ma'am, and my co-chair, Dr. Upadhyaya, and advisors and other distinguished speakers, as well as the participants. It is an overwhelming that we have a parallel session here specifically for the traditional medicine, and I hope in future we have different aspects of Ayush will be discussed in such conferences. Specifically now we are actually emphasizing on the maternal health. And Dr. Deepak has already beautifully capitalized what the specifically the Ministry of Ayush, as well as in collaboration with the line ministries, as well as ICMR, and even the standalone research work which is done by the CCRIS is actually undertaking in the field. So the integration into this healthcare system is not a new concept actually, but somehow it has been now taken upfront in the recently for the last we can say to 10 years, and we have created an Ayush vertical in the Directorate General of Health Services to undertake all these actually activities specifically. So how the integration can go forward? Specifically, there is a initiation from the curriculum, from there the service provision, particularly by conducting the studies, specifically very focused studies. In that direction, this Mission Utkarsh study, which is having a large number of population size, is highly relevant, because there are very clearly there is a initial leads are already obtained, whether the study is conducted in the Gadchiroli district of the Maharashtra, or even the KLE, these institutions under the Belgaum. So they have clearly laid down what is the direction in which these kinds of studies are to be undertaken. Based on that, these Mission Utkarsh also, Ministry of Ayush and WCD has come together, and it is not like that only in one stages of adolescent health these Ayush interventions are applicable, and throughout the entire reproductive cycle of a female actually there is a need to appropriately converge the Ayush practices. Then only we can have that kind of the holistic approach to the medical systems, and accordingly the appropriate outcome will be emerging out of that. For example, we from the pre-conception to the conception stage, then to the during the delivery period, and then after the post delivery period also, there are certain interventions which we try to integrate into our national Ayush mission actually. This is one of the centrally sponsored scheme which the Ministry of Ayush implement through the states and UTs. We call it that component as a Supraja. Supraja is a concept wherein it is idealized like that. For example, a female from her reproductive cycle starting, there initially the appropriate dietary advices, how to have a better marriage life, even for the pre-conception, what are the specific requirements, everything has been actually indicated in that in addition to that, whenever a lady gets pregnancy at that time, what are the monthly regimens, and everything has been clearly indicated. And many of the state governments actually now adopted. For example, I can say about the Madhya Pradesh, all the teaching hospitals, earlier there was only 1 or 2 deliveries happening in these institutions. Now it has been enhanced into more than 30, 40 in their Ayush teaching institution itself by this adoption of the Supraja component. So what I want to say that these kinds of research studies will give an impetus to the entire, not only for the Ayush sector, even for the public health system per se. And I think we have to think about the rigor in which already the mentioned in the initially, there should be a very clear-cut rigor to be all these kinds of interventions, whatever studies we are going to undertake, and there should be clear peer review, and it should be published in high impact journals. Then only we can foreshow specifically into the international front, because WHO now we are coming with TCIM, traditional, complementary and integrative medicine. The traditional medicine strategy is going to be changed into integrative medicine as a very clear-cut component. So we understand that India has a definite role to play under that context. And I hope that whatever discussions we are now doing here actually will make a beginning, even a very clear-cut directions. It will show how to go the integration. So thank you all.
Thank you very much for those words of wisdom. And this has been a very informative session. Thank you very much. So I invite you to please felicitate the speaker. Come, Deepak. I invite both the chairpersons. Please go there. And I invite Dr. Basu to please felicitate the chairpersons. We're extremely fortunate to have the head of the WHS meeting here, Dr. Axel. A warm welcome to you. So it's a pleasure to have you here. So we go over to the next session. This is on the role of homeopathy. Can we have the slides, please? So this is on the role of homeopathy for women and child disorders, excerpts of evidence. So I'm delighted to invite on the podium. Can we have the next slide, please? Dr. Sangeeta Duggal, she's the advisor homeopathy in the Ministry of Ayush. She has completed her graduation from NHMC New Delhi and MD from Baxen Homeopathy Medical College at Noida. She started her career as JRF and SRF at the Regional Research Institute in Delhi and later worked as a medical officer at NDMC and further at CGHS. She's an active member of various scientific committees, including Special Committee for Clinical Research, Scientific Advisory Board at CCRH, Governing Body and Institute Finance Committee for both CCRH and NIH. And a warm welcome to you, madam. I would request you to please come here. So as we can see, you are extremely accomplished and awarded. Would you like to do that? It would be better for you to introduce the speaker if you could come there. Yeah. So we are also very happy to have Dr. Renuka Taneja, who is an experienced, accomplished clinician in homeopathy. She's a joint director of Ayush at CGHS in Ministry of Health and Family Welfare with over 31 years of experience in the field of homeopathy. Her leadership and strategic approach have contributed significantly to the promotion of Ayush practices in the healthcare settings. So she is been awarded international fellowships, the WHO Overseas Fellowship Program at the Royal Tropical Institute, Netherlands, and the Knowledge Co-Creation Program with the Government of Japan, and has also awards and recognitions to her credit, Dr. Diwan Harish Chand Award and Special Appreciation Award conferred by the Board of Homeopathic System of Medicine and Delhi Homeopathy Parishad. So welcome to you, Dr. Renuka. I would invite you to join us here. So I invite the chairpersons to please introduce the speaker.
A very good morning to everyone. So, Dr. Varanasi Rosa, she is a dedicated homeopathic researcher with a strong focus on clinical research, particularly non-communicable diseases. And she holds her BHMS and MD degree from Dr. Abhin Chandra Homeopathic Medical College and Hospital in Bhubaneswar, and is currently pursuing her PhD in public health at MIT University. She has made a significant contribution to the field of homeopathy, having served as co-nodal officer for integrated NPCDCS Ayush project, a collaborative effort between the Central Council for Research in Homeopathy and Ministry of Health and Family Welfare, Government of India. And her work also includes development of standard treatment guidelines in homeopathy created by both CCRH and Ayush vertical of Directorate General of Health Services. Dr. Varanasi's contributions also extend to the development of standard treatment guidelines for the insurance sector, a crucial development in integrating homeopathy into mainstream healthcare. She has authored influential monographs on diabetes mellitus, filariasis, lymphatic filariasis, and homeopathic materia medica of Indian origin, and all these are published by CCRH. She has presented over 30 scientific papers at national and international conferences and has more than 60 publications to her credit. She is also she has co-authored a book on update on bowel nosodes. She serves as an associate professor or editor for Indian Journal of Research in Homeopathy, the official journal of CCRH, as well as complementary medicine research published by Kaga Publishers. Her continued contributions to homeopathy, particularly in integrative healthcare and evidence-based practices, had made Dr. Varanasi a prominent figure in her field. Thank you. So, without wasting any time, I'll invite Dr. Varanasi Rosa. Yeah.
Thank you, madam, for your humble introduction about me. And I am heartful gratitude to the organizers for inviting me as a speaker to this important session on complementary and traditional medicine. My topic is to impress upon all of you about homeopathy for women and child disorders, except from evidence. We all know women, the entire family revolves around a woman. From womb to tomb, from mother to wife, to a beloved, everyone has a key role to play. The woman has a key role to play. Although the role is there, but there are all challenges, like different health conditions, different mental health issues. So here we are here to discuss the strengths of homeopathy and how homeopathy can be immensely helpful, because homeopathy is a tested therapeutic system of medicine and is established across the world for more than 200 years, and also in India It has deep-rooted existence with the government patronage. The benefits of homeopathy, if I showcase here, it is developed, invented in Germany, and came across to India through different stalwarts and through different mainstream personals who thought homeopathy is immensely helpful because of its similars principles, law of similars, like cures like dynamized ultra-diluted medicines, which are safe, cost-effective, can be easily administered to all age groups from child to old. So this is how homeopathy having its strengths and benefits. Now, evolution of homeopathy, this is a slide which I want to show on you. And it is across India rooted through different systems of healthcare delivery system, through dispensaries, through colleges. It has vast manufacturing units. It has more than 300 million practitioners, patients. There is good number of OPD and IPD outputs and healthcare infrastructure. Now coming to CCRH. CCRH is apex body for Central Council for Research in Homeopathy. It has 27 institute units across the country with 7 homeopathic treatment centers, one at Lady Hardinge Medical College, Safdarjung Hospital also. And it is the apex body for research in homeopathy with all responsibilities to create evidence, to prove, to improve, to support the government, to support the public for health issues with healing through homeopathy. As a therapeutic system, it is effective for all age groups, for women, for child health, for integrative healthcare. It is safe and cost-effective. And there are different levels of evidence exist, from anecdotal evidence, expert opinion, to systematic reviews and randomized control trials. Existing practices in India, if I say during pregnancy, for neonates and infants, it is also useful equally for different health issues. Similarly for childhood infections, because we know under 5 children mortality is high in India, and if homeopathy is given since childhood, this can also play immense role in reducing the infant mortality to some extent. So these are the various, as I told, the evidence, level of evidence. This is some of the evidences based on which we have developed some literature, existing literature, from not only from India, and also not only from India, but also from the Western world. Now, I would like to impress upon you the different conditions in which homeopathy works as a primary care setting, as a standalone, or as an integrative care on musculoskeletal disease, later complications like pneumonia, like death. So these initial stage, if it is handled properly, carefully, we can save a lot of antimicrobial resistance, which is really a burden not only in India but across the globe. So that upper respiratory infections, acute otitis media, because it is like eating chocolates for every household, for the parents, because they are also fearful and they are also worried for their child. So for any little condition, OTC antibiotics are now being taken up very much and in a large manner. So if Ayush systems and homeopathy are added, definitely this burden can be also reduced. Acute diarrhea in children, the meta-analysis shows that yes, the homeopathic intervention can reduce the number of diarrhea, loose stools, if given in early intervention. We have done an acute encephalitis study at BRD Medical College, Gorakhpur, where we gave an integrative tertiary care setting, homeopathy add-on with standard care. And we could see through observational studies, to RCTs, and to retrospective comparative studies from documentation, there is 15% reduction in death rate, and also improvement in morbidity also in the patients who were given homeopathic, children especially, who were given homeopathic treatment. Like attention deficit hyperactive disorder, if the children are given, there can be increase in IQ levels, stability in the child, and there is also feedback from the teachers, from the parents, that if homeopathy is added, the state of mind, the state of improvement in the child is seen very positively. Now, neonate and health. Recently, a study was published in collaboration between CCRH and Israel, Saradek Medical Institute, where we have conducted the study at Hyderabad, and it is seen that after giving homeopathy, there is sick days the sick number of ailments have drastically reduced for children 0 to 24 months. And this is a slide which I want to show. It was done on mother and child health. From 2007 to 2012, we had a huge campaign across the country, nation, state, and district. There were different materials developed for parliamentarians, policymakers, homeopathy doctors, allopathic doctors, general public. And we have series of publications like training modules for mother and child healthcare. And these modules for obstetrics, pediatrics covers wide range of topics where it can be used at the desktop guide in the clinics, in the hospital settings, and also a person who was keen interested to learn something about homeopathy. And this was held through workshops, sensitization meets, training programs, care clinics at district levels, and homeopathy medical colleges. So this is the another program which was implemented since 2015 to 2020 because of the kind nature of Honorable Prime Minister of India, who also insisted in the year 2014 that homeopathy needs to be given adequate attention. In particular, specific medical conditions like teething in children, etc., need to be identified, where homeopathic medicines can give relief without any side effects. So based on this, CCRH extended this program to around 7 states of India with a wide coverage, and a kit was developed. If you see, the kit is there shown in the picture, which contains common homeopathic medicines. And from this, through this program, the ASHAs were trained, the AWs were trained, around 15,000 ASHAs, AWs were trained, sensitizations was done, and in this way, the program was successfully implemented and papers was published. This is the paper which I want to focus, recently being published. Homeopathy using conventional medicine as a safety backdrop was more effective than conventional treatment in preventing sick days, sickness episodes, and respiratory illnesses in the first 24 months of life. And definitely for a gynecologist, for an obstetrician, for a pediatrician, if this is being implemented at grassroots level, at different levels of healthcare, then the burden of taking the medicines can safely be reduced, and the immunity, the child's wellness will be enhanced very much positively. So these are the last few slides if I want to focus by Fontana Rosa. She told, there is no alternative medicine. There is only scientifically proven evidence-based medicine supported by solid data or unproven medicine for which scientific evidence is lacking. Whether a therapeutic practice is Eastern or Western, is unconventional or mainstream, or involves mind-body techniques or molecular genetics, is largely irrelevant except for historic purposes and cultural interests. Lastly, as believers in science and evidence, we must focus on fundamental issues, namely the patient, the target disease condition, the proposed or practiced treatment, and the need for convincing data on safety and therapeutic efficacy. As told by Madam Basu, that integration in the mind, not in the, so it should be in the functional level, not in the theoretical level, but it should be the functional and the mind of level, so that all come together to take care of the population of India at large, and having India as a hub for medical pluralism and medical travels from abroad. So takeaway message, homeopathy can be supportive, preventive healthcare at primary level. It can be complementary early diagnosis and treatment of common diseases to reduce the burden on a higher level of healthcare facilities. And at tertiary care level, in chronic, complex, and palliative care settings, homeopathy offers a supportive therapy to enhance quality of life alongside conventional treatments. By embracing homeopathy at the policy level, we move closer to a future where healthcare is truly integrative, nurturing the body, mind, and the community alike. Homeopathy is a pathway to holistic and universal health. Thank you very much for your patient listening.
Thank you, Roja. So I invite Dr. Renuka to share her thoughts. So you can be seated there and use the mic there.
Good morning, everybody. Thank you, Dr. Rosa. First of all, I would like to tell everybody that me and Dr. Radhika were together for the WHO fellowship. So I've known her from the last so many years. In 2011, we went. We were together for around 3 weeks, and I know the way we used to communicate. And she only approached us because she wanted this topic to be taken up in such a big platform. Thanks for that. I'm really obliged.
No, welcome.
Secondly, I have just last 1 year I've joined as Joint Director Ayush in CGHS, which is a parallel wing which looks after the Ayush care in CGHS. All our Delhiites, mostly people know about what CGHS is, so I'll not expand. But most important is, Dr. Radhika, important thing is, what is being shown here, the first slide, the second slide, we as clinicians sitting in dispensaries and the private sector doctors are not interested in reading those literatures, right? So something has to be developed on a root level where the doctor who is sitting in either in a clinical setup, in a private setup or a government setup needs to note these research and integrate. Ma'am, you are in Max, right? So Max, such a big setup they have, if you can help us out with a kind of a setup where Ayush, little centers can be opened up, because you have like these big hospitals, they have a bigger patient outflow.
Renuka, now in government hospitals, in majority of the hospitals now,
This is what
there
I'm
are-
saying. Government hospitals have. What I'm saying is,
We agree, and we are working towards it, trying to.
that's really great, ma'am. We really want that. What I'm saying is,
Yeah.
I worked for 34 years, 31 years in a government setup where we would be coming to the dispensaries. We have a co-located Ayush units and independent wellness centers also in CGHS. I think same would be in Delhi administration and MCD for Delhi setup. But ma'am, private practitioners, whatever they are treating, there are only few who would come up and like meet someone in CCRH or a central council to tell us, ki, look, I have done this research, and so much of formalities, nobody is interested to go ahead and help in publishing. So we lack that data, because, and the maximum results that we get is in the smaller setups. We have, every allopathic setup has in CGHS has an ANC setup. Whether it is a CGHS patient or a non-CGHS patient, that is allowed. I mean, it's not that only CGHS patients will come. For antenatal care, it is allowed. Many a times those patients and the regular CGHS patients, they do come to us and we give treatments. There are many allopathic doctors, ma'am. I mean, I would say, because I am a homeopath, I would proudly say that when their children are affected, when their grandchilds are affected, they would contact us, because they know the side effects and the other limitations of the pathies of theirs, which they are practicing. If we keep on talking on this, I can talk.
I think
for hours.
Renuka,
Yeah.
it's we.
Just one takeaway message that I would like to give is, not on a theoretical platform, we need to work together.
Absolutely.
Private and government sector sit together and work as to how we can actually integrate Ayush with the mainstream.
So the other point is capacity building, so that the rigor of development, like you spoke,
That is true.
I think, so that it is transparent and people find it easy to take that up.
And the the last thing, the other smaller like the private practitioners, I mean,
Absolutely.
they have to be integrated, because they are also looking after the
Yeah.
patient. They are also claiming that they have done so much, but there is no proof of it.
Absolutely.
Yeah.
So I think with that, and on that note, we can conclude the session. Ma'am, would you like to also add a word? Yeah.
Hello, I just want to add one thing. For private practitioners or anybody who has solved a case can enter their case in ACCR portal of CCRH. They have, and even Ayush has. Okay. So that can be done.
Okay.
And it's accessible to all.
Right.
You just have to register yourself and then you can enter.
Sure. Thank you so very much.
Yeah, thank
so we invite you to please felicitate the speaker. Come, Roja, there. And I invite Dr. Basu again to felicitate the chairpersons, please. So now I think we will have to adhere to the time and be a little careful about the. We did start a little late, but then I think the next session would be there, so we need to be careful about the time, please. Thank you. Thank you very much. Yeah, yeah. So we move on to the third session. Uh, so this is on acupuncture, acupuncture in the treatment of insufficient lactation. So we have with us a team. A team, I say that because they are a husband and wife team, and very unique, I would say, because you don't find such people in, at least in our country. I haven't really seen what happens in the world. So extremely accomplished, extremely, what should I say, humane and very grounded. So I am very, very happy to invite Dr. Raman Kapoor, who is incidentally the husband of Dr. Sunita Kapoor, who is going to be the speaker. So, Dr. Raman Kapoor is the director of the institute. Dr. Raman, if you'd please join us on the podium here. He's the Institute of Acupuncture and Natural Medicine director. He's a renowned medical acupuncturist recognized for his contributions for scientific acupuncture in India. He's a recipient of Padma Shri in 2008, making him the first acupuncturist to receive this honor. He began his practice in 1982 and has since achieved significant successes in treating conditions like spondylitis, arthritis, asthma, skin diseases, gynecological disorders, and optic nerve atrophy. And his other positions include President of the Indian Society of Medical Acupuncture, Chairperson of the Department of Acupuncture at Gangaram Hospital, and he has authored 3 books on acupuncture, A Guide to Acupuncture and Tissue Cleansing System, Soft Lasers in Medical Practice, and Acupuncture for the Cure of Common Diseases. Warm welcome to you, Dr. Raman. And incidentally, I've learned acupuncture from both of them. So, yes, they've been my teachers. So, Taruna, for some personal reason, has not been able to join us. So, I invite you to, I welcome you to invite Dr. Sunita. Yes. You could be doing that from there. I don't think you really need any slides for that.
First of all, I must thank Dr. Radhika for organizing this setup wherein the ICMR coordinating the whole thing. And you know, the history of acupuncture in India is not very old. I started practicing acupuncture 43 years ago. And being a Western medical doctor, being an allopath, shifting towards acupuncture was a big decision. I took it at that time. A lot of people still ask me, how were you able to take it? And I have only pursued acupuncture thereafter. I only use my scientific knowledge of Western medicine in diagnostics and in therapeutics, but by and large, we don't practice any Western medicine in our practice at all. I'm proud to say that Dr. Sunita is also following the same path, and she initially joined me unwillingly, and later on, once she was impressed with the scientific data and the scientific results which we got with acupuncture, she is now running the entire show of teaching. I am not a teacher, she is a teacher, because you need a lot of patience with doctors, because we only teach medical doctors acupuncture, because the mandate of the government of India is it is to be only taught to medical doctors, allopaths and Ayush practitioners, and now we have added dentists and physiotherapists also to the list. The big achievement which I have been working for since 2008 when I got the Padma Shri was to somehow get acupuncture recognized as a mainstream medicine in India, and from 2008 to now 2025, it's took me 17 years of hard work with the ministry, and you'll be all happy to know that we formed an apex committee on acupuncture where Dr. Sangeeta Duggal was a member there, and she's here with us today. And she was also a part of the apex committee, which was headed by Dr. Katoch from the ICMR, and I was the vice chairman of that committee. And the committee finally sent this recommendation to the government of India, which said that acupuncture should be included under Ayush. Somehow, the Ayush was not very keen to the idea. I'm very clear about it. And so we finally landed up with the National Commission of Allied and Healthcare Professionals. But I'm very happy, because at the end of the day, I know the science works, and that is what is going to take the science forward. It doesn't make a difference to me at all whether you put me into that category or this category. I know the system is scientific, it is WHO recognized. 103 countries out of the 195 countries in the world have accepted acupuncture as an independent system of healthcare. So we are actually going backseat if we are not doing it. It has to be a part of the integrative healthcare program, and it is a part of the integrative healthcare program globally. And not only that, the amount of research studies available today on PubMed are so many on acupuncture that it is amazing. So Dr. Sunita doesn't need much introduction. She's a Western medicine doctor. She's an allopath herself. She's done many presentations on acupuncture, and yeah, so there it is. She has trained over 500 doctors across India. Every year we get about 20-25 doctors who come to learning. It's a one-year course. And she did a presentation in Taiwan on acupuncture for back problems. In the US, she did on infertility in the AAMA symposium. She does a lot of work in failed IVF and IUI cases with very good results with acupuncture. And she is, in 2015 and 2017, 2 national conferences in India where she presented papers on role of acupuncture in infertility. A newer technique called prickling nerve stimulation technique developed by a Japanese neurosurgeon was learned by us in Japan itself. Both of us went there, and she presented it at the ICMAT 2024 conference in South Korea just in February this year. She's a co-author with me on the 2 books which Dr. Radhika told just now. And she is also treating cerebral palsy patients and post-polio children at the Mother Teresa homes all over India. I give over the mic now to Dr. Sunita.
Thank you, Dr. Kapoor. And a very good morning to all my learned colleagues. And I thank Dr. Radhika especially for inviting me on this forum, and the wonderful arrangements done by the World Health Summit. Thank you so much. Can I have the slide, please? First slide. As you all know what acupuncture is, it's the therapeutic intervention involving insertion of very fine, sterile, disposable needles into specific anatomical sites to elicit physiological responses, aiming at alleviating symptoms and promoting healing. This practice is grounded in principles of anatomy, neurophysiology, evidence-based medicine, distinguishing it from its traditional conceptualization within the Eastern medical system. There are various mechanisms which have been told according to the modern medicine of how acupuncture works. The most important are the neurotransmitters and the hormonal release. It stimulates the release of endorphins, the body's natural painkillers, to reduce pain. It influences the levels of serotonin and dopamine, improving the mood and reducing depression or anxiety symptoms. Activation of nervous system is also a very important mechanism which signals through the peripheral nerves to the spinal cord and brain, which can alter pain perception, influence the autonomic nervous system, and modulate the areas of the brain involved in pain and emotion, such as limbic system and hypothalamus. It has got an anti-inflammatory effect by downregulating the pro-inflammatory cytokines and promoting the anti-inflammatory cytokines. This effect can help in conditions like arthritis and other autoimmune diseases. It improves the blood flow and the local tissue response, thereby promotes healing. And it draws white blood cells to the areas to support repair of the tissues. It also modulates the fascia and the connective tissue, and thereby influences the mechanical and biochemical signals throughout the body. Important is its role in the gate control theory of pain. It closes the gate by stimulating the substantia nigra so that all the pain inputs going into the T cells are blocked. The comparison between acupuncture and Western medicine is very easy to make. As the origin is different, because the acupuncture dates way back to 2,500 years ago, and modern medicine is recent. Philosophical basis of acupuncture is its energetic flow, balancing the flow through the meridians. It's based on the special diagnostic methods like tongue and pulse diagnosis, syndrome differentiations from a number of questionnaires that we make the patients undergo. And the treatment approach is also different in acupuncture, as we use very fine needles to restore the energy balance. And the mechanism of action, which I just told, is through the nerves by the release of neurotransmitters and improving the local circulation of blood. The scientific evidence, of course, in acupuncture is limited, or it is mixed. There is some evidence they support the use of pain, nausea, anxiety. There are many more RCTs which have been done on the role of acupuncture in various fields. But of course, in Western medicine, we have strong evidence-based support by peer-reviewed clinical trials. So the research rigor in acupuncture is at a very fewer scale. Large-scale randomized controlled trials are required still, which are extensive in our modern medicine. The regulation is different according to the region, often licensed as complementary medicine in many of the Western world countries. And while the modern medicine, we have the strict global regulation by FDA, WHO, and EMA, and many more such fields. And the side effects are very, very minor. You know, they are mostly soreness, bruising, because it is done by the experts. So we don't have any major side effects, which we often come across with Western medicines. They can be mild to severe depending upon the treatment. So in the healthcare, the role of acupuncture is mostly complementary, alternative, and now that I hear integrative, which I feel this should be the the future of healthcare. As we know, that modern medicine, of course, does most of the work, but yes, we should not rule out the benefits of acupuncture. Although it originates from the traditional Eastern medicine, many of the benefits have been seen through a lot of scientific research, like in pain relief, whether it is acute or chronic. Both NIH and WHO recognize acupuncture is very effective for chronic pain, back pain, neck pain, osteoarthritis, headaches, and a lot of meta-analysis have been done in many of the accomplished journals to prove this. Like in 2018, the meta-analysis in the Journal of Pain found acupuncture more effective than placebo for chronic pain condition by stimulating endogenous opioids, serotonin, and other neurochemicals which are involved in the pain regulation. Migraine, again, the Cochrane review shows acupuncture can reduce frequency and intensity of migraine and tension headaches, reduces anxiety and depression, and clinical trials show acupuncture can be effective as cognitive behavioral therapy or SSRIs for mild to moderate depression by regulating the hypothalamic pituitary adrenal axis and lowering the cortisol levels. It is very helpful in insomnia and sleep by increasing the melatonin production. It is used for post-operative and chemotherapy-induced nausea and vomiting, endorsed by the American Journal of Clinical Oncology and National Institute of Health for reducing the same things. It is helpful in fertility and IVF support, and some such studies suggest that acupuncture increases the blood flow to the uterus and reduces stress. And lastly, the inflammation reduction is done by modulating the inflammatory markers like TNF-alpha and IL-6. Although most of the benefits are pronounced, there are very, very mild risks of acupuncture. The minor ones are the soreness, minor bleeding, little lightheadedness after the session, slight fatigue after the session. But the serious ones, which are very, very less common, very, very rare, if done by an unexperienced acupuncturist, are damage to the nerve or damage to the internal organ. There are certain contraindications. Yes, during pregnancy, certain acupuncture points are forbidden, which we don't use. We have to take care if there is any bleeding disorder, if the patient is on blood thinners. Although the acupuncture needle is 1/10 of our hypodermic needle, 1/10 of the bow, so usually it doesn't carry any risks. And we do not use electroacupuncture on patients with pacemakers. My present study was on the role of acupuncture in treatment of insufficient lactation. Since the entire theme of the summit was mother and child health care, so I thought let me include one of the studies where acupuncture works a lot. Although there is a big list of indications where acupuncture can work, and WHO website shows the complete list on different system-wise list where we can use acupuncture either as a standalone therapy or in combination with our Western medicine. As we know, lactation is a very, very important aspect and very highly emotional and socially charged topic in today's world. And the many strong views about the rights and wrongs of breastfeeding, which can leave new moms feeling conflicted, confused, and under unnecessary pressure. And we know the importance of the breast milk, how important it is for the mother as well as the baby, especially for making more bonding between the two. And the lack of the breast milk has correspondence harm to both mother and the baby. And both WHO as well as UNICEF recommend exclusive breastfeeding for at least 6 months and accompany this with complementary food for another 2 years of life. And the global situation for the exclusive breastfeeding is very poor. It's only 48%. 52% of the women do not do exclusive breastfeeding till 6 months. And the barriers could be from the mother side, baby problems, or from the environment. So hypogalactia, or inadequate amount of breast milk or delayed breast milk, is one of the major causes of non-exclusive breastfeeding. The delayed breast milk production causes stress, interferes with the oxytocin reflex, which leads to inadequate amount of breast milk. And the treatment done is the regular treatment, conventional treatment, which is done at the hospital, which may include pharmacological treatment, herbs, massage, but now we can also include complementary medicines like acupuncture and moxibustion. This presentation intends to use the wisdom of acupuncture as an adjunct to the conventional treatment for the treatment of insufficient lactation. Usually the lactation failure, according to the Eastern view, fall into two groups. One is the deficiency group, which is the deficiency of chi and blood. Chi is the vital force, the prana, the energy that we call, which flows in the meridians. So there is deficiency of chi and blood group. The most important causes are the fasting before the cesarean section, loss of blood, excessive loss of blood during surgery, and poor diet. The second group is the liver chi stagnation group, where there is galactostasis, means there is a lot of stasis of milk in the breast, which can be due to pain, incisional pain, poor sleep, and depression. The Western view is the first is a raised NLR ratio, the neutrophil lymphocyte ratio in mothers who have cesarean section, which lead to mostly the group 2 type of lactation failure. And second is decrease in the synthesis of the mitochondrial ATP, leading to weakness, which mostly leads to the group 1, the chi and blood deficiency type of lactation failure. So there is a lot of social and personal impact of the lactation failure on mother. Usually the mother is emotionally distressed, there is a lot of anxiety, there is lack of self-esteem, negative body image, lot of sleep disturbance and fatigue in the mother because she is not able to pump with success. There's a lot of physical discomfort because the milk supply is low but not completely absent. There's a lot of social stigma attached to this. criticism, pressure from the family. Even it can go up to straining the relationships and avoiding the social situation. Mother usually avoids talking about it in society. A lot of practical challenges like increased financial burden from formula feeding, which many of the mothers in India, they belong to the poor strata of society, so they cannot afford. So present study is ongoing at my institute, which is Institute of Acupuncture and Natural Medicine. The aim is to assess the efficacy of acupuncture in solving the problems of insufficient lactation in postpartum period. I have done 72 cases in various hospitals from April 23 to April 25, and the study is still ongoing, and in which I used the illness, duration of illness means duration of insufficient lactation from the postpartum period, day 2 to day 10, 56 cases belong to that. From day 10 to day 20, 10 cases belong, and from day 20 to day 30, 6 cases were included. 25 cases out of the 72 cases belong to the Qi and blood deficiency group, and 47 cases were to the liver Qi stagnation group. They all had less than 5 ml of breast milk at one time of expression. They all received conventional treatment for insufficient lactation. So inclusion criteria was women between age group of 18 to 45 years, all had 37 to 42 weeks of gestational age and delivered by vaginal or cesarean section. They were primi or multigravida. Baby's APGAR score was 8 to 10, but all had less than 5 ml of breast milk on single expression. We excluded any bleeding abnormality, any anomalies in the breast development, or any, if they were taking any drugs which is contraindicated during breastfeeding. So we did acupuncture treatment for 3 days, starting from the time when they came to us, starting from the day, postpartum day they came to us. Only 3 sessions of acupuncture were given, one every day and consecutively. And I used various groups of points. The common group of points were given to both the groups, and there were individual groups of points which were added to the individual groups. The main outcome indicator was the amount of breast milk expressed and the serum prolactin level. And secondary outcome were the symptoms of the differentiating syndromes according to Qi and blood deficiency or liver Qi stagnation. And breast milk was collected by hand expression daily between 8 to 12 p.m. by the 5 ml plastic syringe. And in both the groups, the breast milk amount was written on day 1 of the treatment, day 7 and day 14 of the treatment respectively, so that we could maintain a data and make a study out of that. Amount of breast milk after the first acupuncture session increased to 19 to 30 ml from 5 ml in 90% of the cases. And the therapeutic effect improved after 3 sessions. Stop kar do? And was significantly enhanced in primigravida. Okay. And the serum prolactin level, which was done before and after, was also maintained throughout during the treatment. These are the acupuncture points we did. And the demographic data of the mother and the baby, including their parity. And these are the amount of breast milk, increase in the breast milk after the acupuncture session, day 1, day 7 and day 14. So the result of the study was the breast milk volume increased in both the groups at day 1, 7 and 14. No complication was observed in any patient, and acupuncture intervention could boost breast milk production in postpartum period after 48 hours. I just want to emphasize on one patient which was very close to my heart during this entire study. Was a 30-year-old, second gravida, with pregnancy-induced leukopenia. So much so that the absolute neutrophil count would go down to less than 500. She would require GCSF injection twice a week. We started her acupuncture, and with the treatment, gradually she didn't require GCSF. She would require it once in a fortnight or once a month. So she belonged, after the delivery, she belonged to group 1 of the insufficient lactation. We started her acupuncture and moxibustion, And after the first session, the breast milk volume increased significantly. And after the 14th day, we followed her up till the 14th day of the treatment, and the breast milk volume was more than 128 ml per expression. So I think I'm running out of time, so I won't discuss the rationale of acupuncture. Thank you so much, Dr. Radhika. These are the various studies that have been done all over the world for insufficient lactation. Thank you.
Thank you so much, Dr. Sunita. Sorry for hurrying you up like that. I think we started late, so we are also getting. So we are immediately going to the next session, and I'm happy to invite Dr. Amita and Dr. Reena Yadav to chair the session, and I would invite Dr. Ram Avatar to deliver his quick points on yoga. Come, Dr. Ram Avatar, please come.
So there's a constraint of time, so I'll briefly introduce the next speaker.
What should I say? Thank you?
Yeah. Okay. Dr. Ram Avatar Sharma is Associate Professor, Department of Swasthya Vrita and Yoga, All India Institute of Ayurveda, New Delhi. I think I invite you to start your talk.
I can understand the situation very well. So, very good morning to all of you, and it's an honor for me to be part of this esteemed gathering under the banner of World Health Summit. And I would also like to convey my greetings to the organizers, to the Cochrane and ICMR for bringing together such a visionary dialogue on traditional medicine for maternal and child health. As you all know that pregnancy is a transformative phase, not just only physiologically, but also psychologically. And it has a huge impact on every woman's life and is also associated with various physiological and psychological symptoms, trimester-wise, such as nausea, vomiting, anorexia, constipations, backache, and so on. And every woman's desire to settle down these kind of changes without or minimum medications due to their fear of safety. Yoga has a long and rich history starting from the pre-Vedic period 5,000 years ago, when the depictions of yoga postures were found in the excavations of From the excavations of Harappa and Mohenjo-daro, but we don't have any conclusive or written records to prove it conclusively. However, during the Vedic period, the yoga has been practiced ritually to improve their concentration level, and this is almost similar to the definition of yoga, that is to unite individual with the Supreme Self. And during the classical period, Maharishi Patanjali came into existence and he compiled a Patanjali Yoga Sutra, consists of 195 sutras, and he also mentioned in detail about the 8 limbs of yoga. Further, the followers of Patanjali gave a new outlook of yoga, focusing only on the asana, pranayama, kriyas, and the modern yoga was evolved by the Swami Vivekananda in his speech in the Parliament of Chicago. So here you can see that the classics don't describe about the prenatal yoga. Prenatal yoga was evolved only in the modern era. And so what should I do? I can say thank you. No, it's better to say thank you.
They are also waiting actually.
No. Thank you all.
No, you can finish your last. I think it's the last lecture could not be accomplished. Very apologies from our side to Dr. Ramavtar. But the point is, we started late. In the morning, we did not have people here, so we started about 20 minutes late. So that is the reason for the delay that has happened here. And we can also understand for the next session, the people are waiting. But then this has to be taken care of, I don't know by who. But apologies for this, for the speaker as well as for the chairpersons. I think it's been a very important session. It was a very thing of great deliberation for us. Unfortunately, this could not be accomplished for the last session. Dr. Ramavtar, there will be a solution that we'll find for you.
I think
Apologies
you can
for
give
this.
one line key home. Key. What is the lesson you want to give? One liner. Yeah, concluding remarks. Take home message.
I like to show one slide first. Before coming to this conclave, I did a PubMed search and using the keywords prenatal and yoga and pregnancy. And further, I applied systematic review with the last 10 years. And really, I found an interesting outcome. I will focus on only those outcomes. And the study shows normal vaginal worth 60 to 84% in yoga group in comparison to the control group. And there was an average reduction in labor duration up to 1 hour in primary gravida. And coming to the quality of life of the woman, pregnant woman, measured through WHO quality of life and perceived stress score and Hamilton score for anxiety and depression was also significantly improved. So that I can say only for this presentation. Thank you all.
Thank you so much, Dr. Ramavtar. Thank you for understanding. So thank you, chairpersons, and thank you for the entire team for being with us together today. Thank you. And apologies to the people who are waiting. Sorry.
Hi, good morning, everyone, and a very warm welcome. Apologies, we're starting slightly late, but to save on time, I know the room is still filling up, but I'd like to start the session. I'm very fortunate today to be moderating such an esteemed panel. We have on the panel rich experiences that have navigated many challenges on the field, on the ground, have introduced innovations to bring about envisioned results, and they've really all supported the bedrock of healthcare delivery, which is primary healthcare. As we know, the road to UHC is through primary healthcare and adopting a whole of society approach to strengthen national health systems to bring health services closer to the communities for health and well-being. Given the rising cost of care and the demographic shift, and always the constrained health budgets that we always face, all of us today understand the critical role of primary healthcare, the most inclusive, equitable, cost-effective, and efficient approach to enhance people's physical and mental health, as well as social well-being. PHC over the years, however, has evolved and increasingly aims to provide comprehensive services, including preventive, palliative, curative, and rehabilitative. It has been strongly influenced by the recent COVID pandemic and also the rising health challenges of NCDs, AMR, and the impact of climate and health. An overview of PHC reveals its changing dynamic. This clearly articulates the need for adaptability of PHC nuances in the local context. Countries have been responding to these challenges and striving towards efficient implementation of PHC systems. In this session, we have leading experts from 3 countries, including India, Indonesia, and Thailand. We look forward to learning from them about their challenges, solutions, and innovations and future plans. But before I invite the panel, please let me invite Director Manoj Jhalani to set the context for today's session. Thank you very much.
Good morning, everyone. And I'm filling in for my colleague, Dr. Mack, who unfortunately is not well. So rather than, I'm basically going to largely read out the draft that Ibadat prepared as talking points for Mack. Okay, distinguished representatives from our member states, senior advisors and experts, partners, colleagues, and friends. Good morning and welcome to the session on primary healthcare vision to reality, embedding a collective learning agenda alongside health system reforms, experience from Southeast Asia region. Thank you all for spending your Sunday with us. I recall Ibadat was concerned, Sunday morning, do you think there'll be people to fill in the room? But I'm so happy there is enough enthusiasm for this session that the room is already full. I want you to know that our discussions with PHC as the vision will continue in the sessions after lunch, where we'll together share learning on how to enable a competent and compassionate health workforce that prioritizes needs of the people, particularly those most vulnerable. Please do join the following sessions also, which are going to take place in this room. Now, returning to primary health care. So why did we highlight a learning agenda in our discussion today? The development of PHC, as emphasized by our ex-WHO DG, Houghton Mahler, in 1978, must first and foremost, in his verse, must first and foremost be a concern of communities allowed to incorporate local values, conditions, and lifestyles. By its very definition, PHC must embrace diversity and innovation. It's also important to remember that the roots of primary health care run deep in our region. The historian Iris Borowy describes the 1937 Bandung Conference from Indonesia on rural hygiene as the first major international event in public health in which Asian voices were heard and representatives of non-Western regions were allowed to speak for themselves and challenge the idea of one universal Western model for world health. 4 decades later, reflecting on the conclusion of that Bandung conference, the then WHO DG, Dr. Mahaler, wrote in 1978 that the similarity between the principles underpinning Alma-Ata and the conclusions reached in 1937 cannot be denied. Clearly, PHC is not new. But why has it been necessary to resurrect ideas that were put forward decades ago? We stand again at a historic moment in time. Across the region, and as you will hear today, a remarkable transformation is taking place across our countries. A transformation from focus on a few select disease conditions to that of the full human condition across the life course. Political commitments have prioritized a renewed vision of PHC as the cornerstone for UHC at the UNGA, at the G20, and at our regional committees' yearly meeting. However, as you know, delivering quality, comprehensive primary health care in the context of the diversity of 2 billion people of the region and the geographies in which they reside is not a simple task. As you will have heard over the last few days, so much of innovation is present in just India alone, let alone Asia at large. Embedding a strong learning agenda is critical to understand what is working, in what context, and why, and also what may not be working. This principle of learning and knowledge management is embedded in our WHO Regional Roadmap for Results and Resilience. It's also articulated in our regional PHC strategy, where a learning health system is contrasted from a monitoring system. A routine monitoring system identifies implementation gaps in planned strategies and activities. A learning health system, on the other hand, would identify design failures, understand the day-to-day challenges of implementers, assess the effectiveness of context-specific solutions to address specific problems, and identify and evaluate local innovations for potential scaling up. As you will hear today, it's also expressed in our Southeast Asia Regional Forum for PHC-oriented health systems. While challenges no doubt exist, the economic, social, and technological resources available to us are more than anyone before us ever had. Together, with a strong learning agenda, we can innovate for quality primary health care and meaningfully advance the vision of health for all. Thank you.
Thank you so much, Director Delani. The way we've structured this session is in 2 parts, actually. The first part is to hear from our country counterparts, and the second part is to hear from partners. So I think having Mr. Jelani chair this session is really straddling both worlds based on experience. As you know, he's a part of the Indian Administrative Service and now Director of WHO, so it's ideal to have him bring a crux to these both sessions. Now with that, may I please invite our panelists. It would be Major General Professor Atul Kotwal. May I please invite you on stage? Dr. Atul is the Executive Director for National Health NHSRC under India's Ministry of Health and Family Welfare. With over 40 years of experience as a public health specialist and epidemiologist, he has led initiatives in health systems reforms, primary health care, and policy development. A decorated military medical officer, Dr. Kotwal has served in various capacities, including as advisor of Government of Botswana and officer on special duty in India's Planning Commission. Thank you, Dr. Kotwal. May I please also invite Dr. Maria Endang. Again, Dr. Endang is an MD and MPH and serves as Director General of Public Health at Indonesia's Ministry of Health. She leads national efforts to strengthen primary health care, including PHC Consortium. Dr. Endang has been instrumental in implementing India's health system transformation agenda, emphasizing preventive care, digital health integration, and equitable access to services across the country's diverse regions. Thank you, Dr. Endang, for joining us today. May I also invite Dr. Nithiwat. Dr. Nithiwat is the Assistant Secretary General at Thailand's National Health Security Office, where he plays a pivotal role in overseeing the Universal Health Coverage Scheme, which provides health coverage to the Thai citizens. Thank you, Dr. Nithiwat, for being here today. With that, we'd like to start with the panel discussion. And my first, Dr. Kotwal, my first question would be to you on the India's implementation of comprehensive primary health care, especially given India's diverse challenges across the states. And also, how do you feel that the learnings of the states from each other are being captured effectively into systematic orientation? Thank you.
Thank you, Dr. Sonali, and thanks to World Health Organization for this opportunity. And I'm been nominated by the Ministry of Health, filling in from ASNMD NHM, who had some prior commitments. I think most of us are aware the tremendous change which is taking place. But Manoj Dhanani sir reminded me of my UG days from 80 to 84, when in Park we used to read about the Alma Ata Declaration and you know the 8 principles and all which were there. And surprisingly, that one of the 8 principles was also water and sanitation and nutrition also, which now become social determinants of health. They were part of the actual main 8 core principles of Alma Ata. But it's really great, you know, from 2000, as per the National Health Policy 2017. And I was lucky to be part of the initial committee of 2014 when we started writing the, you know, National Health Policy, the initial inputs and all. We worked for 1 year for 2015, and now 16 the draft was put up. And that has given a focus again on comprehensive primary health care. Not only primary health care, comprehensive primary health care, as you alluded to earlier, preventive, promotive, curative, palliative, and rehabilitative, and wellness. From illness to wellness, that's the move which is there from 2018 onwards under Ayushman Bharat, Ayushman Arogya Mandir, the erstwhile Health and Wellness Center, which was renamed as such. So the changes are multi-pronged. One is the infrastructure. And for infrastructure, there are 2 additional schemes of PM Abhim, Ayushman Bharat Health Infrastructure Mission, the largest infrastructure mission ever launched by the country, and coupled with the 15 Finance Commission grants. I think challenges we'll discuss later. I'll just share first what is being done, just a quick recap. And the other is, you know, the additional HR. And one of the architects of that, Ms. Manoj Dhanani sir, is already here. And I referred to that in day for yesterday also in that financing session. The community health officers, mid-level health providers. So that's after a long time, we have created a new HR post at primary healthcare level. And from single A&M-led, not very highly functional sub-centers, now we have sub-center Ayushman Arogya Mandir with CHO-led. Challenges, and again, how way forward and all, I'll cover it later on. And the move from RMNCH plus nutrition and adolescent health to include the unmet need, that is the non-communicable diseases, the oral care, eye and ENT care, elderly and palliative care, including home visits by the team, and the mental, neurological, and substance abuse. So these are the change paradigm which is there. There's definite funding for implementation research. That's what when we meant, one of the topics, one of these themes of this is how we learn from each other, from the states and cross learnings. There's a funding for implementation research. We have implementation research health system strengthening platform also formally. And we also have a annual summit, which I'll come to later on. The other is enhanced drugs and diagnostics. And I met someone from Unit 8 outside, and we're discussing about the drugs and diagnostics as such. So there's a conscious effort. And as per our survey of 18 states last year, more than 60% of the Ayushman Arogya Mandir had 80% of these drugs and diagnostics available. And as per the portal, again, those numbers are increasing to 66 to 70% of this year's portal. To assess them from other point of view, like a triangulation, we have IPHS leveraging technology, where health facilities themselves are also filling up. And that kind of data analytics has also taken place, and that's where leveraging technology, we have various portals. What we are doing now going ahead is integrating these portals. Easier said than done. The other aspect with strengthening of primary health care is taking place is continuum of care. And I would like to share with you here that we, NHRC and WHO, are collaborating on a pilot project in 6 states, that with the existing available HR and funds, how continuum of care can be strengthened. And again, this initiative from Manoj Jhalani sir only 2 years ago when we discussed. And the initial results are very, very encouraging that wherever we gone. And we have leveraged technology in this also, that we are using the clinical decision support system, which was piloted in Punjab. We have added that module in the NPNCD portal. And once these 6 states show the uptake and all, we can see how we can replicate and upscale it immediately. The other is, that how we can learn. We have an annual summit. We have a National Health Innovation Portal where states are encouraged to submit their innovations and best practices. We are strengthening state health system resource centers. The 16 states is already functional. 4 states are in the process of forming. Enhanced funding is now available for SHSRCs, almost more than double for what it was written in the initial program implementation plan of 2005 of NRHM. From 1, it is now to 2.5 CR. So better quality HR are there. We have embedded state innovation hub within the SHSRC. And that's learning from Odisha and J&K. Informally, they are following that same system. We recently concluded one of those summits, the 9th annual summit started from 2013. So 9th summit we did in Puri in the first week of March. And there are few practices. I think in the second round, I'll share those few, or you would like me to share now only?
No, please, go ahead.
Okay. So there are few practices. One was HRH. Like Uttar Pradesh has started, training of behavioral skills for HRH, which is again one of the, topics being discussed again and again. And Mera Aspatal, which is our, patient redressal feedback system, not redressal, the feedback system. Also, one of the major negative which came out was the behavior of the health team. So UP has taken a lead in that, which was shared with all the other states, and the states will uptake. Other was, Andhra Pradesh Medical Recruitment Board. HR recruitment is again a challenge to how to attract and retain. There are commissions and all in various states and all, state public service commissions and all, but the selection cycle is too long. And by the time the final comes play, there's some court cases or some other challenges and also. That's why medical recruitment boards, which we have been recommending the states. Other is HRMIS. Few of the states have already started working on it. The software for team-based incentives and performance-based incentive. So earlier it was, the hard copies and all and approval at the state level. Now Asha Soft is there in few states. So that was also shared. That was in fact shared last year. And we from NHSRC did an evaluation of these 5 important ones shared by few states. The leader was Jharkhand in that. And we've now shared with those states that these are the softwares available. Pick up any, just minor tweaking, and it is available for you instead of spending the money again and doing the work de novo. Same for CHO, performance incentives. 25,000 rupees is for the fixed salary and 15,000 is the incentive. And that depends on performance with various indicators. States are given flexibility in this, which indicators to use for up to 4 or 5 out of 15. And that also through a software, and that is a few states which have made, other states have been taking. Jharkhand is using, again, odd-even training. Using the same HR and HR facilitators, Asha and Asha, they call it Sayya and Sayya facilitators. How they made diets and learning from each other. And that is shared with everyone. The other area is RMNCH. Telangana has leveraged the Emergency COVID Response Package funds to create pediatric centers of excellence. And they reduced their referrals to tertiary care by more than 10% within less than 1 year of implementing this kind of thing, using a tertiary care of center of excellence. Madhya Pradesh immunization wheel is again, Manipur is again very interesting. The name is Miron Bizing G. Khudol. It's an extension of PMSMA, Pradhan Mantri Surakshit Matrita Ashwasan. And where the teams are going by helicopter or by their own car, and all the volunteers are going to remote areas, and for quality care of antenatal care, also intrapartum care. So that's a learning. I'll just share 2-3 more. The other is NCDs. That's another area. So learning from STEMI program of ST elevation myocardial infarction program from Tamil Nadu. That was upscaled 2 years ago. Guidelines were issued. Himachal Pradesh has come up with the stroke program in the same kind of, so they just leveraged it and utilized it, but stroke again, it's tougher than STEMI. STEMI, it is with the ECG, the drug can be given. Here you have to do a CT scan to see whether it's hemorrhagic or thrombotic, and drug can be given only in thrombotic, not in hemorrhagic. So there, how CT scan was made available, how teleradiology has been used by Himachal Pradesh in hilly area, and for effective, and they have shared the statistics with us, which was again shared with all the states, and a lot of other states are now working towards that, how to improve that. Brain health. When we talk of MNS, we generally talk of only mental health, for which Telemanas is already there, which is tremendous success. A lot of calls, and few states have shared how they prevented few suicides also. Karnataka, along with NIMHANS, has come with the Karnataka Brain Health Initiatives, and I have visited few of these in Karnataka to see how these conditions can be prevented, and also early diagnosis with the number of dementia and Alzheimer's cases now increasing, and also post-traumatic injuries and all, and the effect of post-traumatic after post-trauma, how that kind of brain health can be looked at in the primary and secondary care, and how states can learn from each other. I think I'll stop here. I'll come in subsequently. Thank you.
Thank you, Dr. Kotwal. I think you made very pertinent points, especially on the need for the public health cadre at the primary healthcare level, because I think we all today recognize that it's a very critical and unique skill that cannot alone be served by medical officers at the PHC level. And also, we as ADB have been keenly aware of the innovations portal that NHSRC has been supporting, and what a celebration it has been for motivating different state counterparts to come and share their experiences, and also solutions that have been organically developed. Because over the years, we do understand best practices can be shared, but they need to be adapted to the local context. And I think this provides an excellent platform to facilitating those exchanges. So thank you very much for sharing those excellent examples with us. With that, may I please invite Dr. Maria. Dr. Maria, Indonesia has made remarkable shifts from addressing a select few diseases to the entirety of the life course through PHC transformation. How is this being rolled out across the different geographies in Indonesia? Could you also please speak to the importance of embedding a learning agenda in operationalizing ILP, aligning partners, as well as the role of the National PHC Consortium? Thank you.
Thank you. Thank you very much. Glad to be here with everyone. Good morning, everyone. So it's true that after COVID, actually the government of Indonesia, the Ministry of Health, is rolling out the transformation agenda for the health system. One of it is the primary healthcare transformation. In this transformation, there are three focus. The first one is to have an integrated approach of services and using life cycle approach. So we know that our system was fragmented for the primary healthcare. We work by program. Actually, our primary healthcare is like a mini Ministry of Health. You have malaria officer, you have TB officer, you have nutrition officer, maternal and neonatal health officer, and etc. And we know that we cannot move or we cannot give the best by being trapped in that system, because resources are just not enough, and people are actually compete for resources. The nutrition has money to go to the field. The maternal health do not have money to go to the field. They cannot share each other, because this is my money, that is your money. So that's why the first is integrated approach. The second, we call it ILP. This is the nickname, and it's very now famous in Indonesia. This is the integrated primary healthcare. And the second one is to strengthen the structure to the village and even to the hamlet. We learned from ASA in India how to strengthen our community health worker. That's number 2. Number 3 is local area monitoring for local action with digitalization, and a dashboard of health status for village level. So this is the third focus. Now, how we roll it, the whole country. The national level government, by law, has the mandate for standard, for producing standard regulation of services. The district and the district is the one who has to provide services. Now, when the law is produced for the integrated primary healthcare, we did the pilot in 2022, we roll out in 2023, but now will the 514 district follow this standard? And this is why the primary healthcare consortium coming in. I have some pictures of the primary healthcare consortium, if I can share it here. So, we understand that the national level is just too far from the field. And because of that, we also understand that partners who is working on the primary healthcare, they have another strength that is different from the government, which is they innovate in the field, they have time to understand deeply what happened in the field, and this strength should be used also for us because they need also sustainability. Government can produce sustainability and scale. And if we always say to our partners, if you work in the field, you produce best practice and no one is using it, then it will go in vain. So that's why we make the primary healthcare consortium. And this is a picture from Primary Healthcare Forum of the Southeast Asia region that is hosted by Indonesia. And actually the committee come from Primary Healthcare Consortium. It consists of government but also organization. So it started in 2022. Actually, we were approached by Gates Foundation saying that we would like to support primary healthcare in Indonesia in the financing part. And we say that now we don't want project from the government, because project will just result in publication, perhaps better knowledge, but not really refining our system. So that's why we ask the Gates Foundation, can you make the work as a consortium? So we ask also them to work with university. So they have actually local partner, Think Well, Path, and Summit Institute of Development. We ask them, please work also with university, because we want the university also think about primary healthcare. Now university has MPH program, has epidemiological program, but never approach primary healthcare as a system. So we ask them, okay, please, your partner also work with university. So we have for university actually on board with the project of the Gates Foundation. And then because of this, we also being approached also by other, like USAID, other organizations saying that we would like to support primary healthcare. And then we said, okay, now we have more partners on board, and we actually mentioned this is our priority, and because and also say why we are doing this. And actually, it becomes a kind of a family of practice. So USAID actually helping us a lot in scaling up the rolling out the integrated primary healthcare. Now the consortium actually consists of 27, now minus USAID, unfortunately. But this is where they are working in the country and in which field. And we know what they produce. We are taking up the knowledge that coming from the field. For example, PATH is really working on the community health worker digitalization, job aid, etc. And then we adopt them to our digital system. So that's how the primary healthcare consortium works. And it works together with the government, so we make a kind of structure, but this is really a mechanism of work. So we have the consortium, and we have the technical partners in the Ministry of Health, different directorate. We have health promotion, who is overseeing community health worker. We have governance of primary healthcare, who is overseeing primary healthcare. We have non-communicable diseases, communicable diseases control, and they are actually working together. With the partners. We have a steering committee in the Ministry of Health, and we have a consultative group in the different ministerial line, because we have community health worker who is under the Ministry of Home Affairs and also under the village ministry. So we have a lot of people here, but really in the central of it is Ministry of Health, because we are the one who can actually reach out to everyone in the government sector, but also in the NGO organization, yeah. And what is being done? Actually, we are making learning event. So bi-weekly dialogue with all the health center directly. Now with the digital system, we can do Zoom and YouTube and etc. And actually experience coming from the organization, also from their partner in the field. So the primary healthcare that work directly with them also can share the experience. So this is a learning platform across the primary healthcare in Indonesia. But Ministry of Health with the consortium actually have monthly meeting, because we have new priority. For example, we want to make a geospatial mapping, and if possible with AI showing the capacity of our primary healthcare with the outcome that we can achieve. So this kind of thing. And of course, in the human resource, we would like to have also a learning journey that our health worker actually, now we have a kind of a marketplace for learning. So we have a digital marketplace that if you want to have that digital course, you can take it. But we would like to have it as a learning journey. If you are a midwife in this puskesmas, actually you have to have this competency, etc. Now this is a priority that we share. This is still new, and we are in discussion with partners to develop this. Just some illustration on the work in the field, and this is what we actually really want to capture from the primary healthcare consortium, that we are really a system that can learn, and we are learning from all the study that is produced, all the experience that is actually developed or our partners is actually having in the field, so that they can give us input, and then we are the one who scale the good practice, but also we are the one actually to sustain their good initiative. So that's what I can share about the Primary Healthcare Consortium in Indonesia. Thank you.
Dr. Maria, thank you so much for, it's working? Thank you so much for sharing this. And it's truly heartening to see this kind of leadership coming from the government in building a consortium such as this. What I have often seen in my experience has been partner-led consortiums. And I think this is truly so encouraging and a great learning for other countries as well, to see that commitment coming from the top. Thank you for that. May I please invite, after this, Dr. Nithiwat, Assistant Secretary General. Dr. Nithiwat, Thailand has shown us that UHC can be achieved in the context of limited resources. And through continuous learning and reform, I think, which is absolutely critical. Could you please share with us the ongoing scale-up of the UCS treats all diseases to UCS anywhere through rapid pilots and evaluation? What can others learn from your approach? Thank you.
Thank you, Dr. Sunalini, and good morning, everyone. Today, I would like to share the Thailand experience in implementing our Universal Coverage or UCS scheme. Our journey towards the UCS anywhere is not a sprint, but a marathon of dedication. It took over 20 years to develop this system into what it is today. When Thailand launched the UCS in 2002 to treat all diseases, we were still recovering from an economic crisis. However, the strong foundation built by the Ministry of Public Health makes the implementation smoother. This includes a nationwide health workforce, hospital in every district, and existing health insurance for civil servants and private employees. At that time, only around 30% of the population had no public health insurance. Through infrastructure and resources planning, we were able to expand the program to cover everyone quickly and efficiently. Okay. During the COVID-19 pandemic, we faced the crisis again and learned many valuable lessons. We realized that technology could play a key role in patient care. So we introduced the telemedicine into our system, along with the self-assessing tool, to empower people to take care of themselves. We also used the electronic claim and audit system and implemented policy focused on health promotion and disease prevention, or PNP, anywhere. For the AIDS Society and NCD's era, we have found that government facilities alone are no longer sufficient. Therefore, it is essential to engage new and diverse into the system, including community-based and private sector actors. All of these show that expanding of UCS Anywhere model is not just necessary, but possible. To offer healthcare coverage no matter where people are. Under the UCS Anywhere policy, we have taken action in 3 areas. First, we have introduced the service innovations into the system, including health kiosks, telemedicine, and the option for patients to pick up a medication at the drugstore when they have a common illness. Second, we have improved data connectivity between the hospital and ensure that health information return to the patient themselves. And third, we are promoting self-care by integrating self-testing options into the system, such as HIV self-test, urine pregnancy test, and HPV cell correction kit. We implemented step by step in 4 phases. We started with 4 provinces and then 8 provinces, half the country, and expand to the nationwide in 1 year. Before we scale up, we have monitored and evaluated by Mahidol University and HITAP, the researcher, and informed to the policymaker for improve the services. This is the result. Over the past year, the UCS Anywhere policy have received a positive response from the public and has significantly improved access to care. More than 200,000 new people have used the services, and over 4,500 drugstores and private clinics have joined the UCS. As a result, this helped reduce waiting time by more than 300% and save patients around $15 per visit for indirect cost. One key insight is a shift in mindset among healthcare providers in Thailand, which show that primary healthcare is not just responsible of public health units, but require the collaboration with the private sector. We have also seen people starting to take better care for their own health. They choose to visit a local drugstore nearby their home before going to the big hospital. This change make our primary healthcare system stronger, and they also make the whole health system work better and last longer. Thank you.
Thank you, Dr. Nitiwat. I think a great learning, which you've just shared with all of us, is an evolving policy to make everything work well with time. Thank you very much for that. May I please invite Dr. Jalani now to summarize some of the discussions. We're following the flow, which was agreed on. Please, Dr. Jalani.
Thanks. So I was asked to, reflect on my experience, and having been in the government and now with the WHO, of course, I have fairly rich experience of close to 4 decades. Now, basically, we heard from three countries and looked at how innovations and learning are happening and how that's being scaled up. Now, in my own thought, when I was coming in, every time I remind myself of the WHO goal and what is provided in the Constitution about helping realize the right of every human being. I mean, that's the fundamental right to the attainment of highest possible level of health, irrespective of their socio-economic background. And this has to be progressively realized. And how do we accelerate the progress? And I think the acceleration will happen by doing better by learning. Now, I'll just give some personal examples. Way back in 1990s, early 90s, we had half of the global polio burden in India. And around 1994, the then health minister in Delhi had implemented mass administration of oral polio drops on a single day at the same time across Delhi, you know. So that, of course, would help in terms of building herd immunity, but also would hugely help in creating, very large awareness and ensuring that it is effectively implemented. Even a month before it was done in Delhi, I was posted as district collector Jhabua, which is on the western part of Madhya Pradesh, and is the most tribal, was the most tribal district of the country. In fact, the literacy rate in Jhabua district of India, Madhya Pradesh, was 13%, with female literacy rate of just 6%. Now, so in 1994, we did exactly that. In fact, a month before it was done in Delhi, of mass administration of immunization on a single day, essentially around administration of oral polio vaccine. And so in 1995, based on the success in Delhi, Delhi was recognized globally, nationally, because all the media is here. And then it was thought as to whether we can implement this whole thing across the vast country like India. And at that point of time, when the GOI was deliberating on it, they looked at what was done in Jhabua, and then they realized that if it could be done in the most backward district of the country, it could as well be done across the country as a whole. And that's when in 1995, they decided to really implement National Pulse Polio campaign. And then we started, the cases of polio started declining very fast. And by 2011, we had our last case of polio in, I think, March 2011. And after that, we have not had a case. So from a learning in a small district, that those learnings could then be replicated and scaled up across a country as large and diverse as India. India, recently we had this report on maternal mortality ratio, global estimates, and India recorded about 80% decline in maternal mortality from year 2000 to 2023, a remarkable decline. And one of the things was in terms of enhancing institutional deliveries. And one of the ways was to, how do you facilitate transfer or travel of women from remote villages to the healthcare facilities which could provide basic or comprehensive emergency obstetric care. And this is the learning that happens. So in state of Andhra Pradesh, an IT company along with the state government implemented a simple call center based dial 102 or 108 to call the ambulance across the state. Anyone, ASHA worker or pregnant woman could call up, and within a certain time, the ambulance would be there to pick up the patient and the family members and the ASHA workers and bring them to the healthcare facility. And between 2004 to 2014, in less than 10 years' time, the institutional deliveries went up by double, from nearly 45% to 90%. And now you have the dial 102, 108 network spreading to almost 25,000 plus ambulances across the country. So these are just some examples of how good practice learning and then helping the scale up with some degree of backing, federal backing to really, learning and then scale up and everyone benefiting out of it. So these are just two examples. There were several more, including ASHA workers, Midanin experience in Chhattisgarh, etc. And we had, but then I must also say, when we were listening to, say, Dr. Kotwal here, he shared a large number of very, very good examples happening across the country. And this would hold true for very large countries, including Indonesia and all, where you have large number of states or provinces and public sector, private sector. So it's a huge laboratory and there is a huge amount of learning that's available. We need to create mechanisms to identify good practices. We need to create mechanisms to share those practices and also in terms of adaptation and scale up. So if I have to look at in terms of, while there has been a good improvement in terms of, we have learned many good practices, I still feel that in terms of several good practices, Dr. Koth was mentioning about STEMI, I recall this was presented in the best practices workshop in Assam way back in, I think, 2017. We had organized the best practices workshop there. But since then, it's really not taken off as well as it should have. We are, so what is it that can further, so what is it, we have done a lot, there's a good learning, but how do you create incentives for different level? So why should a facility want to implement a good practice, or districts having an incentive? You talked about Gujarat model, then you had a national level exchange, but I recall, this itself is a good area of implementation research as to why are some good practices not really taken up as quickly as one would ideally wish them to be. What we realized from what we heard is, one, in terms of creating mechanisms to capture innovation and creating forums to sharing information, providing structured templates or backing, like you have the ILP and then you have a national program to support it. One of the things that seemed to work was also in terms of incentives for states or provinces based on implementation of health sector reforms. And one interesting thing, although I had not seen the last 2 years, but was also in terms of rating states in terms of the improvements in implementation of undertaking health sector reforms. So the improvements in health outcomes and also in implementing key health sector reforms. And that kind of health profile used to come. And I recall when I used to be in the ministry that the principal secretary from the states would call up requesting that the chief minister is concerned. Why are we ranked below? Why is X state doing so well? And that reflected that when you try to share that with the community, I'm talking about why do you create an incentive for the chief minister to want to make sure that all the health sector reforms indeed are implemented, is when you start presenting a state profile. So the governor of state A would then be interested that, oh, in that ranking, this state is doing better than mine and I need to be doing something more to reflect. That happens with the global ranking and rating, etc. So before I conclude, we created this regional PHC forum, and I'm sure we are sharing some of the 20 positive practices out of about 250 positive practices that we got. And there has been, we have also facilitated cross-learning, including the ASHA program from India to Indonesia and all that. And so that came as a result of the request from the states. Indonesia, we heard about the National PHC Consortia for capturing best practices from and bringing in not only the development partners but also knowledge partners, and then trying to with a under the national leadership and then helping scale up of the good practices. I think one of the recommendations from the Delhi Declaration was to create such national and sub-national consortia across all countries in the region, and I think there's a good lesson there. Thank you very much.
Could I just make one quick comment,
Yes.
Dr. Rani?
Yes.
Thank you, sir. I'll just two quick comments. One is for STEMI, and you mentioned that how incentivization and all also works, and how IR implementation research looks at challenges and strengths, and that could also be shared. One is STEMI, sir. When I joined in 2021 in March, this organization, at the time I was discussing with advisor HCT, why uptake of STEMI is not there. So we made the guidelines. Earlier, sir, the guidelines were not very, very specific. We made the guidelines, and under the NCD pool of NHMPIP, there's a separate subline in that. Now states are asking money for it, and they're trying to replicate. Second thing I would like to share, which is very interesting, sir. Till about 5 years ago, we were always used to cite examples of Tamil Nadu only. Now we started citing examples of all the other states like Odisha, Jharkhand, UP, which was not there earlier mentioned anywhere, Manipur, Assam, Rajasthan. So that also has now, suddenly other states are now looking up that, okay, if they can do it, that we can also do it. With only Tamil Nadu example, there was kind of inertia. Oh, they have public health charters since last 100 years. They've been doing so much like this, and their systems are there. So they just wanted to share these two important, how it is now taking up all these innovations which are being discussed, how they're taking up, and how there's a dedicated funding needs to be there for each and every initiative. Thank you, sir.
Thank you, Dr. Kotwal. I think we have a very rich panel today with experiences shared from both Indonesia, Thailand, and India. And I'm sure challenges faced in India are very similar to those in Indonesia as well, because they're very diverse. And I think rich experiences are brought from the ground up to the center and then translated into this PHC forum, such as Dr. Maria described. I think that's quite invaluable. Now, we would like to open the floor to some questions and answers before we do a transition in our panel and invite the rich experiences that is available in this room and our partners. But just a quick round of questions in case anyone has any at this stage. Yes, please. Could you please introduce yourself, the organization you represent, and who your question is addressed to?
Thank you. Thank you. I'm Saravanamurthy, representing PATH. My question is to Dr. Kotwal. Sir, I've been listening to your session. Primarily, you're sharing about India's experience in learning between the states and how you are taking that as a success for the national programs also. And you are also facilitating that implementation research. So, curious to know the challenges on that aspect, but later. But my interest now is what all the factors that you consider from all these learnings for making a policy at national level. That's my question.
Okay. It's a very interesting question, and because we being the think tank of the Ministry of Health, and we are closely involved in policy making, and also working with the states. So number one, important positive factor is like the not positive, the enabler is that to have a understanding of the ground, the states' challenges, and also success stories to look at how some of the states have been overcome those challenges. The number two is that community connect also. So when my teams go anywhere, it's not only that they visit the health facilities or with wherever the states take them. No, in our IR and also our routine visits. And they also interact with the community, attend Jan Arogya Samiti, attend VHSND, talk to the local representatives, community-based organizations. So that's the kind of information from ground which we need. And number two is evidence. That's why when I joined, we created this IRHSS, Implementation Health System Strengthening Platform. We dedicated separate funding from the government, we were able to convince. And now in last 4 years, we have had 2 rounds of IRHSS plus non-IRHSS implementation research studies and evaluations, where we are presenting evidence to the government of India that this is the evidence, and based on that, how newer policies can be made or existing one can be modified. And even within the newer policies, with whatever modifications we are doing, we are giving more flexibility to each and every state also. It's not that it's rigid. If I start giving examples, I think it'll take more time for the panel also. But just to suffice to say that for any kind of policy making at national level, it is an iterative process. The olden times when I was on UG and PG, we used to read that policies are made by people sitting in glass houses in Delhi and all. I think that time is no more there. It is now more there more interaction with the state. And secondly, another important thing is whenever something is made, even with all that information and all, it is consultations held with the states. And not once, twice or thrice. And now with the video conferencing, it is easier. What we have also added now since last year, and that's the ASMD's idea, which I must, I think, give her due credit, Ms. Ratna Patnaik's. She started, instead of, so many visits, 4 regional workshops with all the states. So last year we held those 4 workshops, 8 states in each workshop. All issues were discussed, all policies were discussed, what changes need to be done were discussed. And that was also added with half a day or 3/4 of a day of field visit in that particular state for all the other states also to learn. And this year's 4 regional workshops, draft dates and agenda and venue are already been decided. So that's the kind of change which is taking place and how more interaction with the states is taking place. That's why the policies are becoming more effective as such. Thank you.
Thank you very much.
Hello. My name is Dr. Shruti, and my question, I'm from Seva Rural Organization, and my question is to Kotwalji. Sir, India, in case of primary health, has been doing great in forms of tech involvement, in form of service provision. We're looking at various forms of service provision. But is it time now to look into the quality of service being provided, and not only amongst us, but also going to a lower level, the purpose of this healthcare delivery should be given. For example, to the lower lining for frontline workers like ASHA and ANM, should they be given the purpose of what they're doing? Will that increase the quality of work?
Thank you for the question. Again, give me an opportunity to add what I forgot last time in the previous answer to previous question is also knowledge from development partners who are working on ground. That I forgot to add, which was there in my mind, but I think in a hurry to finish off my answer to save time. So that's again a great learning. And I've learned from Indonesia. We have been having few meetings quarterly with all development partners, NHSRC. But let's see how we can, change that, add government ministry representatives also. And coming back to your question. One is what we have done is, one is IPHS. We have made a tool, which is a governance tool for everyone to see the gaps on ground. Other is National Quality Assurance Standards, homegrown standards which are accredited by ISQA, International Society. They are at par with NABH. Rather, our training also accredited by ISQA, but NABH training is not accredited by ISQA. And same, NHA also same is there. Third, now coming to your specific of how to, this is facility based. How to get the ASHAs and also other field level workers. So community based, the ANMs and CHOs are getting involved as such. What we are now looking at is comprehensive training manuals instead of package-based training for all the healthcare workers. And I would like to share in that recently had summit, when we were discussing this, there was already a best practice from Chhattisgarh, where they already made these composite manuals for CHOs. And there, now for ASHAs also, we are making those composite manuals. ASHAs, CHOs, ANMs, staff nurses, and medical officers. Quality of care, social, the behavioral skills, and also all part of it. So instead of going package-wise, we're going how to approach the community, how to approach the patient, and that's why we hope quality also will subsequently increase.
Thank you, Dr. Kotwal. No, please. We have such a rich panel and we're all very fortunate. If there are any questions for Thailand and Indonesia, we'll take those. And then we'll do another round of Q&A after we hear from our partners, please.
Yeah, I'm Morita from Universitas Gadjah Mada and Indonesian Young Academy of Science. I would like to ask Dr. Maria about the consortium that is created in Indonesia. It's a wonderful initiative, and I would like to ask the challenges you faced so far and how do you overcome those? And with the withdrawal of US aid and its funding, what are the strategies of the government to close the gap? Thank you.
Yes, Dr. Maria.
Thank you very much. Actually, in terms of partnering with all the partners in the primary healthcare consortium, we don't really face challenges because they have been very, very helpful to us. For example, now we have identified, even in my unit, this is a big unit actually, it's a one Directorate General, we have more than 200 guidelines issued in the last 15 years for the primary healthcare. So one is on maternal nutrition, one is on wasting, one of etc., etc. So because of that, we said, okay, we don't need this anymore. We just need 5 guidelines for primary healthcare. And this is for management of mother to adolescents, adult to elderly, communicable diseases, management, and then the supporting structure, which is the drug management, laboratory, and etc. So now everything will become only 5 books, and we will edit it every year. And the primary healthcare consortium actually helping us a lot in producing this. And we work on this like very, very quick. In 1 year, we produce 5 books for the primary healthcare. Of course, it's compiling all the all the things. It's more than 200 images from the Ministry of Health, all, yeah. So this is how we work, and actually we don't face really a big challenge to work with the primary healthcare consortium. However, the gap that is left by USAID is actually quite big because they help us in scaling up. So they help us even in 140 districts to start the rollout. We have 514. Of course, the rollout officially launched in 2023 when we produced the ministerial decree of integrated primary healthcare. But when USAID actually stopped, even the Secretariat of Primary Healthcare Consortium was supported by USAID, but now other partners is actually stepping up to support the Secretariat of Primary Healthcare Consortium seated in the Ministry of Health. But the gap for the direct implementation in the field and also a lot of input that coming perhaps from 140 districts directly through USAID, of course the gap will be there. And I think we really just need to accept and mitigate this risk that we are not that directly connected through our partners, direct input. So perhaps we need to work together with other partners also too. Of course, we still can listen to the district, but losing such big support, of course, is unfortunate. Thank you.
Thank you, Dr. Maria, for your honest and candid response. We would hold on the questions right now. We'll have another round of questions. I would like to first thank our partners who've been sitting so patiently. I'm deeply honored that you waited and listened to all these valuable inputs. Please let me start by inviting Dr. Amit Shah, who is Country Director for Japaigo, India. Thank you, Dr. Amit, for joining us today. Let me please also invite Mr. Neeraj Jain. He is Country Director for PATH India and Director of Growth Operations for Asia, Middle East, and Europe regions. Dr. Mate Davidson is Director for Global Health Programs, Social and Humanitarian at Novo Nordisk Foundation. And she leads initiatives aimed at reducing health inequities. So a very warm welcome, Dr. Mate. And finally, Dr. Rene Ekpini, who's the Regional Advisor Health at UNICEF South Asia Office, based in Kathmandu. Thank you so much for joining us today and taking out your time. We as partners have been working very closely with some of you in implementation efforts at ADB, and we're very glad to see several of you here today. Thank you. I think I'm going to pose the same question to all the partners, and I'm hoping we could start with Dr. Amit, Mr. Neeraj, Dr. Rene, and then Dr. Mate. How do you tailor your technical support to ensure it resonates with member states' vision of primary healthcare? What are some of the mechanisms that you have put in place to enable and scale up implementation-focused learning? And finally, how can we be more efficient and effective together? So over to you, Dr. Amit.
So thank you, Sonalini, for the opportunity for Japaigo to present our insights, and it's a pleasure to be here. I would say on behalf of Japaigo, the best example on providing tailored TA for PHC, not only regionally but globally, I can say it safely. I'm just 3 weeks old in Japaigo, but I can still say it. Is the work that we have done on comprehensive primary healthcare in India, the government stewardship under the government's leadership. I think it's very interesting, and if I just have to call out a few principles on what worked so well, was that full alignment with the national priorities, and those also are not only at the start planning phase, throughout the cycle. Because though, and Dr. Kotwal mentioned, and Mr. Manu Chalani also mentioned, when the health policy was formed and then with the Ayushman Bharat program was launched, the needs were evolving. Because when it initially started off with CHO trainings, and then it was about operationalizing of the health wellness centers, as well as a lot of the learning packages. Then it went into telemedicine, supply chain. So I think the evolving needs that were there, so being responsive to the evolving needs, again, just being responsive, and I can safely say Neeraj will also attest to that, is work in India is very different. It's very, very different. We are already always in a catch-up mode. We have to, there is constant pressure to create value. This is the 100% government-owned, government-financed CPHC program. So the pressure on partners is to add value. And the value that we were able to do was just on ground, work in the states, identifying those localized problems where we could demonstrate those learning labs, generate that evidence, and always following that mantra of learn fast, fail fast, move on. But present the evidence continuously to NHSRC, to the ministry, and so those lessons could be taken forward. Regarding to a second part of question on what worked well related to scale up, I think the second part is embedded in the first, because it was constant process that was there. And the proof is, I'm not talking of any theoretical framework, is though the program has ended, a lot of the states, the programs, the learning labs have now been mainstreamed and scaled up to the national program. Just one example on the family caregiver model, where it was demonstrated the role of family members in TB and DRTB patients on providing on increasing the treatment adherence and providing the psychosocial support has been mainstream and was then launched by the Prime Minister of India and scaled up across the country. So I think that is the value add in terms of scale up when close partnership happen. In terms of the final, what can be effective? What was it? Effect and the next one?
It's how can we be more
How can we
efficient
work
and
better
effective together? Together is a keyword.
So how can we work better together? I think that's where the government stewardship plays such an important role. I think it's contingent on all of us, whether it's the funder hat we wear or the government representatives, the partner agencies, just keeping in mind that who we are here for, the communities that we serve. So it's contingent on us not to duplicate our efforts, just try to complement and add value. And again, those fora such as the Indonesia example is an excellent fora. In India also we have NHSRC, where the National Innovation Portal provides us the platform to share those lessons. So I think the mantra is simple, but it's actual delivery where it counts. Thank you, Viraj. Thank you.
Thank you, Amit. Thank you for, and I'm so glad we are short on time now. I'm so sorry. So we'll keep it to 3 to 4 minutes. We'll have more rich discussions through Q&A, I'm hoping, after that.
Absolutely, Sonali. Yeah, so I'll go really fast. I think I'm gonna just helicopter up a bit and put on my regional hat and just quickly sort of, first thing is to understand the differences and the nuances of each country. I mean, we work in Nepal where it's gone completely decentralized. A bit crazy, but it's the new way of working. Indonesia is fantastic. Thank you, Dr. Maria, for talking about our partnership in Indonesia. But that the geographical spread of Indonesia, how's that going to work, etc. So that's the nuance there. We work in the Pacific Islands, which is again very interesting. Small populations spread across, large sort of water bodies. Myanmar. Public, private, all a confusion right now, but we do a lot of work there. Finally, Bangladesh. You have the public, you have the private, and then you have this NGO sort of pillar, which we also have to work with the BRACs of the world, etc. So I think understanding the nuances is absolutely critical in primary healthcare because it's integrated delivery. I'd like to, also say that the three, and I'm going to take just like 2 more minutes, but the 3 things that we kind of focus on. Primary healthcare is all about screening, diagnostic. People are walking in with a tummy ache or a fever, screening and diagnostic. Not dengue, not malaria, not chikungunya. And I think all the 3 leaders have already talked about that. So we focus a lot on that, especially in the situation of LMICs where we do not have the human resources who have all the technical knowledge to be able to do all of that. So how do we use technology? So PATH focuses hugely on technology. Sometimes we are actually told that we are technology obsessed, and we probably are. Secondly, continuum of care with a digital backbone. I think that's critical for primary healthcare because otherwise you cannot actually build a continuum of care. And how do people actually move across the whole health system, both public and private, is going to be critical. What we found to really, what we've evolved into really is to think about governance. And primary healthcare governance is going to be absolutely critical. You know, I was listening to Mr. Jalani about his experience as a district administrator. So for us now, the district magistrate is our point of contact.
Yes.
That is where the governance happens. So we are kind of looking at district models in Indonesia. Ma'am, I think you're aware of our program there. In India, across wherever we work, we are not looking at working sub-district. It has to be a district because without the governance, primary healthcare is not going to work. The entire continuum will never work. So we're kind of saying, okay, let's design for the system in the country, but make sure that we design for governance, the lowest level of governance that we can go to, and move towards quality and sustainability. Thank you.
Thank you, Neeraj. Dr. Rene, over to you.
Thank you very much. I will try to be very brief. Maybe starting with sort of board statement, repeating a bit of the question and stating that one size fits all is not an option in terms of providing support countries, especially coming from an organization as UNICEF, where we're working across region supporting countries. Few things that I would like to highlight before going through the question is, I'm coming from a different region, different continents. I have a huge experience working in several systems, but the first thing that I saw here is the immense diversity. Diversity in terms of culture, diversity in language, diversity in terms of geography. And linked to that, we have also the health systems in this region, which are at different level of maturity. When you're talking of India, you're not talking of Maldives or Bhutan. And third, when you're looking even within countries, we still have equity gaps. We still have diversity. We still have pockets of deprivation. So the support you're providing is just trying to tailor the specific needs of country. The third element I would like to highlight, for us, it's also very important in terms of responding to country needs, to clearly identify the areas where the needs are, and especially link it to the reform, maybe going through the list, because I do think it's very important at this point of time. Whether you're talking of governance reform, you're talking of human resource development, the area around how we can actually integrate the emerging challenges, talking of NCDs, mental health, environmental health, looking at the need to actually scale up the digital transformation as one of the key pillars of the health system, to have a sort of digitally enabled health system. The demographic transition, you're also taking into consideration all the issues about humanitarian and development nexus. That's also very important. And the last three that I think also very important, especially now, is first, for the health sector, how we can be able to leverage the other sectors to achieve results. Two is how we engage more strategically with the private sector. And three, at the opening, the issue was raised in terms of how we can strike the balance between the survival agenda and the well-being one. So these are the areas that are very important when you're targeting your support. Having said that, the key principle for us, and I think as our big sister WHO, is to make sure that whatever support you're providing is responding to the country needs. Because it's not an ad hoc support. We should make sure that we respond to the priorities, the policies, and the actual needs of the countries. It's also very important, maybe taking down as UNICEF to the specific on the ground. How can make sure that this is addressing the community needs? And this is where going back and looking into what we have learned, particularly linked to the COVID-19 pandemic, how the response from communities, from cultural backgrounds are also very important. Here, I want to, at least for UNICEF, highlight some of the things that we are using, the social listening, the community-based approach that we on community engagement itself, beyond engaging community workers. And finally, going to question 2, not to be too long, in terms of
That's fine.
What are some of the mechanisms that we have put in place to address this issue? First of all, it's very important for us to integrate learning as one of the core elements of our country programs, of our regional level programs. And these require defining, identifying the resources that are needed in terms of human capacity, but also how we leverage some resources to support, financial resources to support this. But this should be done in a more systematic way and not in the ad hoc way. Three is, it's also very important, and I think when you're talking of implementation, learning, is the issue of feasibility, scalability, and sustainability. Whatever you're innovating, whatever you're supporting down with learning, you should keep in mind that in the end, what you're trying to do is to move this to scale. And third is, of course, this is about partnership, it's about co-creation, it's about partnership, collaboration with usual partners, but also how we can actually be more strategic in terms of engaging the private sector. And finally, what should be done differently or you should improve on? I don't want to repeat what we all know. I think Dr. Jalali, you did mention the PSC forum. For us, moving forward, it will be very important to be more strategic in terms of leveraging the existing platform we have, strengthen the collaboration among partners, but also strengthen the collaboration with government. And this linked to the need also to think more about how we can support and promote regional and country learning hubs. From where I'm sitting in Nepal and looking at what is going on in India, definitely it's very important for us to have some country hubs which actually help implementing innovation, documenting lesson learned, and dissemination. And third, we always raise these issues, South-South exchange, collaboration, but we should be more focusing on actual action to make sure that this is happening. It's about learning, of course, using the platform we have, but also supporting country visit and having this exchange more periodically. And finally, if I don't mention this, then I might get in trouble with my boss, the community of practice, which for us is very important, making sure that all these specific areas, I did mention some of the government's priorities that should be identified, should be part of this community of practice. So I'll stop here, and thank you again for the opportunities.
Thank you. Thank you so much. Over to you, Dr. Mate.
Thanks a lot, and thanks for inviting me as part of the panel. It's nice to be last in line, because then I can be very brief and just refer to the good points already that has been made. And but also just let me take just 1 second to introduce the Novo Nordisk Foundation. We are a philanthropic foundation based in Denmark, and actually we are among the largest foundations in the world. We are a newcomer in India and on the global scene. We just, 2 years ago, we opened our office in India, and I'm so lucky to have some of my colleagues here that are based in Delhi, and last year we opened an office in Kenya. So we are newcomers, and we are very happy to be here. And then to your questions, my inputs today will mainly be based on our Partnership for Education of Health Professionals, a flagship program that actually our first international flagship program that was developed and implemented with Indian partners, and now the same is happening in Kenya. And I think on the first question, how do we make sure align with government priorities, I think the most important point to highlight here is that we are working along with government policies and practices, and that the approach is to strengthen institutional capacity of education and health institutions in India and in Kenya and across East Africa. So we are not creating any parallel systems or developing something in Denmark that we are trying to support. So I think that's the most important point. And then I could highlight here, and I'm so lucky I have 2 witnesses for this in the panel, Professor Kotwal and also Niraj, because even before we started designing the program, we came to India, and actually I was here with our CEO, and the very first night, it was a lovely dinner, we had a dinner, and both of you were there, and we were asking all these clever, or maybe stupid questions. What's that?
We have
okay.
maybe
Time
one
is
more
over.
minute.
Okay. I'll take this. Okay, so I'll be quick. Then moving on to the next the next question. But then when we got the mandate to develop a program, what we did is actually, and that's, I hope that will answer the second question. We integrated research as one pillar. So one pillar of the program is education of healthcare professionals to improve capacity on prevention and care for cardiometabolic diseases. Second pillar is research. So sort of just integrating it so practitioners will also be trained in research capacity and do research. And then finally, partnerships, knowledge sharing, that's a very important part of the program. So I think that's actually what we're doing right here. And my last point would be, I think it has already been mentioned, share learnings, also some of the negative ones. And I realized actually maybe I'm not living up to that because I brought a brochure here today with highlights from our program. And it doesn't include that many sort of failures or mistakes, but that's also an important part of it. And then I think what was mentioned today, to do it in partnerships, to do it in consortia, because then it's even easier to share also sort of some of the failures and lessons. And I think I'm over time now, but thanks a lot.
I truly wish we had more time today for this panel. We have such rich experiences here. But please let me call Dr. Dodo Banzon. He's Director Health ADB to give concluding remarks. Thank you.
First of all, I think I would also offer apologies for the short time. But I think this panel is about collective learning about primary health care. And I love the way that you frame back to 1978. I think I was a little boy then when we started talking primary health care. And you got to start asking, why do we still talk about primary care as if it's something we have not reached? I think the answer to reaching that is in the first 3 seats here. At the end of the day, it is government-led. Sorry to the partners, sorry to us as well. It's not an ADB thing. It's not a WHO thing. It cannot be solved by Novo Nordisk, although they will solve diabetes. Okay, go Ozempic. It's countries. And I think our challenge before is that the countries were sort of doing not innovative things, right? They were basically told PHCs, it's like putting a health center, putting health workers, nothing with WHO and former WHO. But as I listen to Indonesia, I work in Indonesia and Thailand and India, the richness of the innovation they're doing there is unbelievable. Thailand talks about UC, it's about health insurance and all, but they're using UCS now, very powerful, UCS everywhere, to use that financing approach, which they're so known to drive primary care. Indonesia, Ibu Endang, the Primary Care Consortium, you should meet all of these NGOs in Indonesia. They're all experts, right? They're like India, right? So to get them to work together with them, without all of this, even that all of us banks work together, right? So that's such power, and it's government-driven. In India, it's government-driven. So I think as we end this session, we talk about sharing all that. I call on all the partners, please do not assume that you could solve primary care on your own. That really, if we want this to happen, you should start going to Ibu Endang, our friends from NHSO, to India. Because at the end of the day, they will be the one who will lead it. And if we share and help them disseminate, if we share and help them deploy the innovations, right? If we accept that they're not perfect, so that's my, don't criticize us if you can solve everything. And in a sense, because at the end of the day, that's when we can actually make PHC a reality. So before we end, let's just give a big hand to Ibu Endang, to NHSO, to India.
Thank you so much, Dr. Dodo, as he's fondly called. And thank you, my sincere thanks to all the panelists who could join us today. Very grateful for your time, valuable inputs and contributions. I am not sure if we're okay to be kicked out or we have time, 5 minutes or so for Q&A. Okay, let's open to Q&A. Thank you. Yes, this gentleman, you've been very patient. Thank you so much.
One for
okay, please.
Hello everyone, I am Kumar from PATH. So for my question is with, have you, I mean, to the panel and to everyone here in the audience, do you have came across any documents where we can measure how the partnerships, multi-sectoral coordinations is moving, is quantifiable in terms? Everyone is talking about partnerships, multi-sectoral approach. Have you came across any documents at each level? No.
Your question is to?
Yes, is question to panel and to anyone in the audience also. Have you came across any documents where we can measure how the partnerships between the different agencies? I mean, you know, on the ground, I mean, theoretical, we all are saying that things are complementary, but actually on the grounds, many times the things are competing with each other. The interventions are competing with each other for resources. So number one. My second question is with Thailand. Many congratulations for this wonderful initiatives. I just want to know, I mean, you talked about the health record systems. So what is the repository system you have? Health data repository system.
The mic is. Yes,
First
yes.
one first?
Dr.
Okay, we'll go in a sequence. I think quantification becomes very difficult in health. There are a lot of intangibles. So I think let's not go there. Qualitatively, I'll share with you. Even if there is some competing and all, as you mentioned, and let's not go there as such. India's CRM, and we are publishing papers looking at various aspects through the lens of CRM over the last so many years, where development partners have worked on ground with the states, aligned with the policies and all, where change has taken place over the years. I'll just stop here. So there is some kind of documentation. It's a various different reports, but we are now culling information, and the reports are available on our website and Government of India's website. Please see there how over the years change has taken place. It will give you some information over there. Thank you.
Dr. Nithrat.
Can I just? No, but it was actually related to Kotwal's comment.
Yes,
actually, I think more research is needed, and I was already highlighting research, but I actually planned to refer to Professor Kotwal's mentioning of implementation research, and how does partnerships and consortia work within this when we are implementing things. So I think this is something we could look further into. So maybe, yeah, some evidence is there, but maybe more is needed. Thanks for your question.
Thank you.
Okay, from Thailand, for the health data, the hospital and clinic send the data to the NHSO. Then we are any HIS provider. Then I for claim, and then I integrated the health data, connect to the other providers, and respond to the people on the PHR platform, personal health record platform for the people.
Thank you. I think we'll end the session with that because we have to be very respectful of the next session. We will be correct in this. Thank you very much. Could everyone please come for a photo? Dr. Jalani, Dr. Banzon, please.
We must thank Dr. Sonali for an excellent conduction of the panel. We must big round of applause for you.
Thank you.
Hello and welcome to the World Health Summit. To get us started, policy is increasingly focused. So we've all wondered, why is it that this coverage is not enough? And in fact, the World Health
Good afternoon, everyone. Welcome back to some of you, those of you who were in our primary healthcare session. We are now switching to our session, Human Resources for Health, Quality with Compassion. First, thank you for joining us. I think it is Sunday afternoon after lunch. We have a rich panel, a very thoughtful panel. And as I keep wondering, why are we here? Fundamentally, in 2006, the World Health Report said that the biggest shortages in human resources for health were in the WHO Southeast Asia region. Today, when we look at just the production capacity, just as India as example, it is producing annually 120,000 medical doctors per year. That is almost close to 38 OECD countries combined. Not to mention pharmacists and lab technicians and nurses. So it is huge in scale. That is why this session we really wanted to focus on quality and quality with compassion. And DG Maria, I think, reminded me that really fundamentally it's about the values we are trying to work towards. And hopefully that will come through in our session today. So we are co-organizing with the ADB. We have Dr. Nishant Jain, who is the Senior Health Specialist, and Dr. Shanti, who is the Director of Health and Social Development, who are the co-chairs for this session. But first, asking Dr. Nishant to say a few opening remarks.
Thanks, Ibadat, and good afternoon to all of you. And generally, I say the session after lunch is very easy because everybody had a good lunch, so they will be in a relaxing mood, no more questions. But seeing what is happening from past 3 days, I doubt that. I have seen audience have been very engaged, and I think people are still coming in after lunch. So on a Sunday, so I'm very thankful to everybody who is in the room that you are here. And also, of course, I'm very thankful to the panelists who are here. And as Ibadat was saying, human resource for health, of course, we all know it's a very important area. But I think during COVID and after, people really understood what it means. Because when people were struggling to find doctors, struggling to find health workers and all, people realize how much it's important that we have human resource for health, and not only in terms of numbers, but also in terms of quality. Because we can have X number of doctors produced, Y number of nurses produced, but whether they are able to carry out all the things, whether they are updated with what is happening, the latest happening in the world, in the country, all these things become very important. So I think that our idea for this session was that we bring together a set of people who are not only working at one level from either from the government side or from the research side, but we have different kind of people coming in so that we get all these different perspectives. And in human resource for health, what ADB is doing actually, we are trying to work with in India plus in many other countries in trying to not only help in improving the delivery of services through human resource for health, but also trying to see how we can actually work on strengthening the policy framework, which many times hinders development of that. So for example, if you set up a medical college in one of the remote districts, it's easy to make the building. But how do you get the doctors to go there? How do you get the professors to go there? And so if you can make a very nice building and it will be climate friendly and all these things, but then if you don't have a policy framework which provides incentives or which provide disincentives, provides various kind of things, then the doctors will not go there, professors will not go there. So how do you do that? So I think that we are trying to see from the policy angle, we are trying to see from the operational angle, and also I'm very happy that Professor Madhuri is here because we are also trying to work with her to set up a center of excellence on medical education, which could have been a very nice thing, but it will be, I think, much nicer because she is here and working on that. So because they are trying to do so many very interesting things. ADB as an organization, I think, has decided that this is a very important topic for us, and we try to work very closely with the government, with academia, with civil society organizations in trying to how do we improve it. And it should not only be a doctor-centric healthcare system, because in our country or in any large country where you have shortage of doctors and doctors especially, you cannot afford to have only a doctor-centric system where how do you engage and empower your nurses, how do you empower your field workers to do more things. So I think that there are a lot of things we can do. And in this respect, I think I'm very happy to see all of you, and I think we'll have an engaging discussion today. And I think we will have the discussion starting slowly, but I'll give back to you. Thank you.
Thank you. I will save some time. My main job today is to keep us on time, but I will start by just inviting Professor Saroj, Lieutenant General Professor Madhuri, Dr. Oscar, and Dr. Shanti to just join the panel. We have two scene-setting presentations that will start. Please, Dr. Shanti, please, Dr. Oscar, please, Professor Saroj. We will start with two scene-setting presentations. One on really focused on clinical quality, one on compassion and empathy. So we will start. The first one is a presentation by Professor Jishnu Das, who could not be here. It's 3 o'clock in the morning in Washington, D.C. He is the distinguished professor at Georgetown University. He leads the health section in MIT's JPAL lab. So very renowned researcher, but really raising some very important questions we have to think about. So maybe we can start his presentation, Priyanka. Oh, I think pause. Only I can hear it. It's playing on the. It's playing on this. It's playing on this. It's playing on this computer. One second. Give us 2 seconds.
But the problem that's coming up is we see time and again across many different countries.
Thank you. I'm constantly reminded of my digital.
Hello and welcome to the World Health Summit's session on human resources for health, quality with compassion. My name is Jishnu Das and I'm going to talk about effective UHC and the critical role of quality. So just to get us started, policy is increasingly focusing on UHC or universal health coverage, but a lot of the part of UHC that it focuses on is really the C or the coverage. And that makes sense because we want to make sure that people can afford care when they need it. And we want to make sure that the coverage allows people to get that care when and how they need it, and it allows them to improve their health. But the problem that's coming up is we see time and again across many different countries and many different conditions that coverage alone isn't enough. So we've often wondered, why is it that this coverage is not enough? And in fact, the World Health Organization has a wonderful definition of what universal health coverage actually means. And as they say, it means that all people and communities can use the health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. There's a reason I've bolded and made in a different color sufficient quality, because although it's something that all of us will agree is very important, it's also something that's proven to be very hard to operationalize. So what I'm going to try and do here is take you through the operationalization of what sufficient quality means on the ground, and then come back to thinking through how are we going to proceed towards meeting this real goal of UHC, which is providing people with the health services they need of sufficient quality to be effective. So the key, again, coming back to this, the key again is we have coverage, we have health outcomes, but often that coverage is not leading to health outcomes, and we believe that the missing middle in all of this is quality. Okay, So the question is, what do we really know about quality? And I want to start with an example, and I'm going to give you a couple of examples from India. And this is not because I'm particularly fixated on showing that whether India has high or low quality. It has very high quality and sometimes low quality, but because it's a place where I've done a lot of my work. And then fortunately, over time, we have been able to expand that work to lots of other countries. So we can check for see whether the findings from India are also generalizable to other countries or other conditions. Okay, so here's my big, we've got a one big slide, right? Which is we're going to think about a 45 to 50-year-old man who reports in with a doctor and says, Doctor, I woke up in the morning, I was really, really anxious, and I have this pain in my chest, right? And a lot of you are clinicians, a lot of you are doctors, you know roughly what questions you would ask, you know roughly what examinations you would do. And whatever questions you ask, whatever examinations you would do, the person would answer truthfully, the person would tell you what's going on with them. And in this particular case, it wouldn't be hard for you to deduce that the person has suffered from an MI, right? Or has had a heart attack. You're not sure whether it's unstable or stable angina, but the right thing to do would be to refer the patient onwards to a hospital, ask them to get an ECG, and maybe you want to give them aspirin as a blood thinner in the meantime. So what happens to these patients when they go to actual doctors in rural, in this case in rural India, and what kind of care do they receive? So the first part is the doctor spends about 3.89 minutes with them. They ask about 2.89 questions. They do about 1.46 exams, and based on that, they give about 2.34 medicines, and they charge about 31 rupees. This was a while back. This was in 2010. Two things. Things could have changed. Things could have become more expensive. Things could have become better, but we don't have studies that are more recent from this area and for this condition. As they become available, we'll keep incorporating them. And you could ask also, what specifically does the doctor do? Well, here's what the doctor does. So if we think about the temperature attempt, which is here, the BP, the pulse, and the auscultation as kind of our combined vital signs, that's happening in a combined way. The temperature is happening about 12% of the times, the BP about 32% of the times. Overall, I would say vital signs are taken less than 15% of the time, right? Does the doctor ask about family history? Well, 1% of cases. Do they ask about smoking? 7% of cases. More worryingly, do they ask about pain radiation? And remember, the patient is not trying to trick the doctor. So if the doctor had asked about pain radiation, the patient would have said, yes, I had shooting pain down my arm. That's asked about 16% of the time. Right? More worryingly, how many doctors actually recommend an ECG? And it's about 24%. Right? Based on this, you can come up with some kind of agreement about how often these patients were treated correctly, and you won't be surprised to find that in this particular study sample, it's somewhere around 30%. Right? Now you might think, is this particular to India? Is this particular to this particular sample? And the good thing is, as we have done these studies, lots of groups have done them around the world, and we are typically finding two things. So let me show you what those two things are. The first is all studies find significant deficits in care. So the black bar here shows what fraction of patients are being correctly diagnosed in these different studies, right? So this is Birbhum in West Bengal. These are 3 provinces in China. This is Delhi, India, Bihar. This is Indonesia, Kenya, a second study, Madhya Pradesh in India, Mumbai in India, Patna in India, but then Nigeria, Senegal, South Africa, Tanzania. We are getting data from all over the world. And what we're finding again and again is, in most cases, most of the studies, patients are not correctly diagnosed and treated in more than, say, 40% of cases, right? There's some exceptions. Kenya here is 52%, for example. You get a nice example here from South Africa of 63%. But even then, the majority of patients are not being correctly diagnosed, right? We can also look at whether they're being treated with antibiotics incorrectly, and the answer is almost certainly. So in a lot of cases, the antibiotics are not required, and always we are finding that the fraction of patients who get antibiotics is at least 33% and usually closer to 50% to 60%. So the basic fact of the matter is for patients, the average quality of care is poor. Right? The problem then is people think that average quality being poor means that all doctors are not doing well. That is not true. The average quality being poor means that some doctors, which we all know in India produces some of the best doctors in the world, right? That the quality is in fact highly variable. So what I've done here, we went to 1,800 villages in India and we interviewed the healthcare providers in there and we did medical vignettes to test their knowledge. And what I've plotted here is the competence of these healthcare providers across all these villages, right? And these are the bottom 10% of villages, and these are the top 10% of villages in India. What do these look like? Well, in the bottom 10% of villages, 49% of healthcare providers, so this is 49%, could correctly diagnose TB, and about 25% could correctly diagnose preeclampsia, right? If you move all the way to the top 10%, those numbers become 95% and 89%. So the big problem is not that the average quality is poor. The big problem is that average quality is highly variable, right? The second issue is not only is it variable, it's unpredictable. Right? So what I'm going to try and show you here is the competence of healthcare providers across multiple states in India. And what you find is, and I've shown them for both MBBS doctors, which is these guys in black, and non-MBBS doctors, which is in white. And what you find is a state like Gujarat has the best and most knowledgeable healthcare providers in India, right? But as you go down this group, by the time you get to UP, Bihar, and Jharkhand, the MBBS providers are actually not that knowledgeable, right? So the quality is variable, right? Then you could ask, is this the case also in other countries? And the answer is yes, right? Here are 12 different African countries, sub-Saharan African countries, where we went and we measured knowledge of medical conditions for almost 15,000 healthcare providers. And what I've tried to do here is show you the distribution of that quality in every country. So for example, these doctors are quite poor in their knowledge. These doctors are very good, and this is the average in the full sample. What I want you to see is the following. Think of the average Kenyan nurse, right? So the average Kenyan nurse is somewhere here, right? And then you could ask, well, compared to the average Kenyan nurse, where are the doctors, right? So in Guinea-Bissau, only 30%, 38% of doctors actually have higher knowledge than the average Kenyan nurse. In Kenya, it's 70%, but then in Madagascar, it's 37%. In Malawi, on the other hand, it's 90%, right? So the big issue that we're finding is, again, not that just that the quality is poor for patients on average, it's that the quality is exceedingly variable, right? So if you take Nigeria, it has some of the best doctors on the continent, and it has some of the worst doctors on the continent. Can you tell what that quality is going to be? And the answer is no. When we try and predict that quality using a large number of characteristics of the doctors, we do really poorly. We just cannot tell in the data or from qualifications whether a doctor is going to be high quality or not. Right? Is this going to be easy to improve? No. We've worked quite hard on this, and there is no single strategy that has emerged as a silver bullet. So we have found a number of different strategies that will improve care a little bit or improve care even quite a bit if you're willing to spend a lot of money. But it's not as if there's a single strategy. If you were to ask me, what should I do? There is no single strategy that screams out, if I do this, I can guarantee improvements for you in the time frame that you need, right? Instead, what I think is we cannot, we're at the nascent point on this. We are starting to understand this better, but we're not going to be able to improve quality without first measuring it and having open and honest discussions about the data and what these studies are showing. This is a really active area of research, and I would love to think about future conversations, future collaborations that tackle this problem seriously and say, yes, there is a problem. The problem is not that we don't have good doctors. We have some excellent doctors. Many of them are in the room, but we also have doctors who are not that good with training that is not up to par. So in conclusion, we cannot have effective UHC without a focus on quality. And that average quality can be quite poor for patients. But the broader message I want to take away is not that quality is poor, but that quality is highly variable and highly unpredictable. So the first step towards addressing quality issues is really to systematically measure the quality of services and understand why is it that we are getting this massive variability in quality that we are not being able to predict. I will stop there. Thank you so much for listening, and I hope you have a great day.
No, I think this is always a sensitive presentation by Professor Jishnu, but it starts thinking about the importance of quality. So that's one element of quality. Another element in human resource for health. About 3 years ago, Sri Lanka came to us in the middle of their financial crisis, which was quite confusing for us, to say, please, can we focus on introduction of medical humanities and health humanities? And we are very fortunate that we have Professor Saroj Jayasinghe. We also have Dr. Satyendra in the back. And for us at WHO Zero, I think it was really came out of the blue. But I think over time, we have begun to understand why it is so important, and why it is important to complement the work we're doing on clinical side on the people-centered side. So Professor Saroj, please, if you could give a presentation on your work. Professor Saroj is Emeritus Professor at the University of Colombo School of Medicine and the founder of the Department of Medical Humanities.
Thank you very much, Vedat, and it's wonderful to be here. To begin, I'm a hardcore clinician, right? I've worked for 40 odd years as a clinician, and I'm absolutely convinced on the importance of people-centered care as well as compassion in my clinical practice. So to begin, I would like to first give a conceptual framework, as it were, because we are talking about a session on quality with compassion, and we've heard about clinical quality, and my topic is on compassion in relation to quality. And this covers the areas which we will discuss. So the pathway which I propose is that in order to improve quality, there are several actions which you can take, but this people-centeredness is a key. And in order to develop a people-centered health system as well as health professionals, we can have several inputs, but compassion cultivation is an important pathway. And that's where humanities come in, because we are using humanities to improve compassion and empathy in our students. Now, when you improve compassion or cultivate compassion, it also it also tackles this major problem we are facing, that is the decline in empathy in our health professionals, shown across in several systematic reviews too. And also it counters the burnout in the health workers, because the more compassionate, the self-compassionate health worker does not burn out, is able to carry on, and some of us are still carrying on doing our work. Right, now this is a very simple one, and that's a very complex one, just accepted for publication yesterday in the Discover, in Discover Health Systems, which tries to lock in or describe the different aspects of how education, training, and empathy and compassion can shift this paradigm towards people-centered or person-centered healthcare. Right, so that's just the context. And this is what we have done in Colombo. We've looked at how to enhance compassion, and the framework we are using is that there are several inputs we can make, and one of the key inputs is in humanities, and this model is given in this book, and I've kept 3 copies of the book if you want to take. Right, okay. So we have used humanities to improve compassion. That's the basic formula. And let's see how this has been rolled out. It's not uncommon, because you've seen it published even in 2020 in the US. So in the Western literature, there is a lot of work on use of humanities in promoting some of the attributes of humaneness. We did a situation analysis in CRO, and the pioneers are in India. Satyendra, who is there, right? One of our close friends. And we've looked at some of the work which is being done here in this region. Satyendra and them have done a lot of work in relation to trigger films, forum theatre, and so on. We had Ravi Shankar, who was working in Nepal and now in Malaysia, and they've done a lot of work in several medical schools in relation to introduction of medical humanities. But there are few lessons you can learn from our experience, right? Because we've formalized these structures. We've formalized it. Points up to 5. You know, we had a behavioral sciences stream which runs across the 5 years in the undergraduate MBBS program. Then we established a Department of Medical Humanities. We held an international conference in 2018, and that's one event which brought in the humanities into our curriculum. We've convened a global network for health humanities, which held its first inaugural global conference last year. So we've tried to formalize it in Colombo, especially the establishment of the department. And some of the publications, relevant publications, are given here. Developments in medical humanities in Sri Lanka, I've kept about 5 copies of that paper that was published in the NUS journal. So we will now look at some of the examples which come from this region as well as Sri Lanka. So we use the different types of arts in our medical curriculum. So students would be required to write narratives of patients. That's not to diagnose an illness, but just the human being. Who is that person who has come to see you? And when you do that in the first years, you find a very beautiful description of human beings. And if you do the same in the 3rd or 4th year, you see how we have brainwashed them. They can't talk about the human being. If you ask them to write anything, they're writing about the disease and the differential diagnosis. Just get on to that path. So that's these are transformative to the teachers as well as to the students. And when you get them to read certain short stories or novels, and you ask them to come and comment during their educational programs. We ask them to comment on poetry like this. I'll give you 30 seconds to read this. So the idea is that when they go and see a patient with, for example, who is dying of cancer or palliation, these are the sort of thoughts which are going through those human beings. And the poetry will help you understand another dimension which is outside the technical competencies we are very good at. And we use art to get them to observe and gain certain skills in detecting hints or clues which come from these pictures. This is a famous painting on the doctor, and we get them to look at this and then comment on the fact that this is the child dying probably of typhoid, and this was an era when there was not much treatment available. And in the background you can see the father looking at this interaction between the doctor and the patient. And it's difficult to see, but next to the father is on his left is the mother of the girl, knowing that the child has died. And you see the hands of the father on the mother trying to pacify her. And the environment also gives a clue to the industrialized parts of UK at the time. So these are experiences we try to give them. And this is another performance sort of, I put it under performance because students are required to pay respect to the cadavers, the bodies which are donated to the faculty. Now, when we were students several decades ago, right, it was, we used to do very, very nasty things to these cadavers, right? We used to laugh, we used to, no more, thankfully no more. And in fact, some of the students perform religious observances, and there were some universities where you're supposed to write a letter to the relatives thanking for giving this body to the faculty. That's a very powerful way of changing their perceptions. These are transformative changes. Then we came up with this wonderful program called Humanitas, brainchild of Professor Panduka Karunanayaka and Dr. Santosh Fernando, and they use the arts. It's like a choreographed thing, and this is where the expertise comes in, because you take a topic and over a 2-hour period you use various forms of art to highlight emotional aspects related to a problem. So you use music, dance, film clips, poetry, and so on, and ultimately you obtain feedback. But these are sometimes performed by the students. So you are using several types of arts, and we're trying to aim at what we call transformative learning, where emotions are heightened and you switch, because you have that's a type of learning theory which we are trying to use there. And the topics can be very variable. In fact, we had a whole program on Rabindranath Tagore. We looked at one on cancer and us, where we brought in a mother who had lost a child due to cancer, and she spoke. And in the other one, it was in relation to garment factory workers. So you can see the machine, the garment factory workers who were affected during the COVID, because some of them had to work despite the COVID, right? So we have brought in all these in order to try and fertilize or promote or foster the humane aspects of the medical students. So that's the summary, that's the pathway. We think compassion is key in improving quality for a number of reasons, and we are using the arts. And I think this is an opportunity for this region, which has such a wide, deep heritage, to showcase its own arts. We have enough in this region. We haven't to be copying only Shakespeare. Thank you very much.
Thank you, Professor Saroj. It's always inspiring to hear you speak. Again, in terms of organization, I am not very good. I forgot to introduce Kavita Narayan, who's the first panelist. So Kavita, if you can please join us. Kavita, in her individual, I mean, she's a senior health advisor with Ministry of Health India, working on human resources for health, leading the human resources for health cell. She perhaps best reflects this mix between a scientist and an artist, shows us that it is possible. I will let you speak to that later. But Kavita, we wanted to shift now to, we want to describe, there is a challenge in terms of clinical quality, in terms of compassionate care. So it's a very difficult question. You said this is $1 million question. What are some of the reforms India is putting in place in thinking about these issues and trying to improve the balance between access and quality? I know Dr. Oscar will be faced with the same challenge afterwards, but yes, over to you, Kavita. Yes.
Okay, yeah, thank you. Thank you so much, Ibadat. And thank you so much for those wonderful presentations. I think, Dr. Saroj, I think if nothing else, just to hear you speak and the kind of inspiration that I think all of us who are sitting on the other side and trying to sort of, grapple with this problem of quality at scale, it is so inspiring. It truly, and I think what I was writing down when you were speaking was, how do you keep innocence alive? I think that's the key, right? Because with every passing day from being that child, every day we're losing innocence. Like you said, the first year student medical student is writing this beautiful report, but by the end of 4 years, he or she has become this, what do you call, this machine, right? And is sort of just trying to get it done. So while I will obviously, it'll be very nice to sort of talk about a lot of things that the government has done, but I would like to sort of continue to keep that perspective, and some of the things, again, Ibadat, you can tell me, maybe I'll take 2 to 3 minutes, and then maybe we can add other comments as well. So, the government obviously has, this is a very, very important word for us. I know this is probably hard for people to sort of take in, but particularly after the last, I think the regulatory meeting that we had, which was in Jaipur, I think we heard from you then as well, Professor Saroj, and we heard from Professor Harry Caton. We have spent the last year, and Ibadat and some of the other WHO folks know this, a lot of time and effort on saying how do we build our regulators' capacity. So we have 5 major regulators in India, and we are actually in the process of saying, can we build the capacity of our regulators to be able to then put this in perspective, right? Because if the regulators who are making these standards are not going to be able to change the curriculum, not going to be able to do some of the things that you'll have done, then we are not going to be able to make a change in a country which is as large, complex, and at the scale that we're working on. So one of the things that the WHO makes me do, and I think you will, which is keep count, right, of how many people we have in the country. I think they do a good job of keeping everybody counting, but I am one of the counters in the government. And, our counting has very large numbers. As you very aptly mentioned, Ibadat, currently our count says we have almost 13 lakh, which is 1.3 million doctors. We have 3.6 million nurses for some of the international folks who are there, and nurses and midwives, obviously. We have about 1 million ASHAs, our community health workers. We have about 2.2 million of the Anganwadis and others who also work in the system. We have about almost close to 1.3 million pharmacists. We have, about 3-4 lakh dentists. So we are talking of a very, very large workforce. And when, while I love Jishnu Das and I'm hearing that conversation, I mean, I would like to know what the answer is, right? It is truly a million or maybe $1 billion question of how do you get this kind of quality and how do you inculcate the compassion in that kind of scale. And that truly, in my mind, I think as we've very well internalized it, but obviously the challenge is now in implementing this. How do you internalize, how do you sort of bring this systematically down to every last doctor, every last nurse, every allied and healthcare professional, to be able to deal with compassion and to be able to, because there is no quality without compassion. That I'm very convinced about. I am not a medically trained doctor. I have a PhD, but I'm not a medical doctor. But having spent all my time in sort of running hospitals in the United States, and then obviously with the, sort of the policy work here in India, we cannot be talking about quality if we don't talk of compassion. And without quality, there is no universal healthcare. So I think this is so fundamental. And I think it's amazing that we've had this discussion and put this front and center in this. So again, congratulations to you all for doing that. Very, very important. How are we doing this? So we've tried to do some things in the government end. There was a program that we had called Heal by India, which was about 2 years ago. And what we did as part of that was we said, can we try to think about inculcating these in the curriculum, right? Where would we put it in the curriculum? So we've requested all our regulators, and some of the regulators have done a great job. So whether it is a nursing council, whether it is a medical council, these are now these soft skills, what we call soft, what we are not able to quantify is actually a part of the curriculum. So the part of saying this is important and we need to have a patient-centered approach, there is a soft skill nature to this, is now quite well ingrained in the minds of these regulators, because that's really where they start, because the health workforce gets started there, right? Some states, for example, Bihar has a program now, I believe in about 20 districts, there is a program where they're looking at compassionate care. There is we've got this whole concept ingrained in our national health policy, which we came up with. So while the thought has been very clear, the intent has been clear, the challenge obviously for us is how do you implement this? 3 days ago, we actually inaugurated the curriculum for our allied and healthcare professionals, which are almost, probably 2 million or so in number that we think. We released 10 curriculum, and I was actually part of designing a lot of that curriculum. We've put a 6-month compulsory module where compassion, ethics, communication with the patient, bedside manner has actually been now inculcated as a standard, which means nobody is going to come out and they will not get their license until this has happened. We've given all these colleges across the country a year before which they actually start implementing this, because obviously it's going to take time. But their courses have all now come to a 4-year program. And in each of these 4-year programs, 6 months of it, however they wish to do it. So we are not saying you have to do it in semester 1, right? How the universities want to do it, how states want to do it is up to them. But the regulator is not going to be able to give a license to these people to practice until this has been verified as a competency and as a skill as part of their graduation requirement. Now, obviously, some groups, will take it on faster than the others. So the nursing, I know that the Nursing Council is very, very committed, and they are trying to do this. The Allied and Healthcare Council Commission is again committed. So I think from an intent standpoint and from putting in place some of these policies, we're definitely doing a good job. But I'm going to now take a minute back and say, where does it all start? It starts with leadership. And a culture of compassion has to be pretty much at the leadership level, because otherwise I think we are, like you said, how long does it take for this person to become jaded? How long does it take to sort of kill that innocence? And, just go back to, who cares? My boss is mean to me. When I tried looking at patients 36 hours in a row, day after day after day, being beaten by one thing or the other, not getting the compensation that you deserve, most of all, not getting that respect that you possibly deserve from another person. And I want to see how compassionate you can be, right? So the mental health stress, the burnout of some of these things is a real huge issue that I think we agree. But there's a lot of work to be done in sort of, bringing that as well. So there is really a leadership, I think issue that we have to deal with, or rather not an issue, but rather a solution that we have to come up with in terms of how do you change that. Mission Karma Yogi is a massive program that the government has undertaken, which is truly working a lot to do this. I think I'll stop here, maybe let some others speak, and then we can take some more specific questions. But that's about it. Thank you again.
Thank you, Kavita. Very much appreciated on how you're dealing with this at scale. I think same question, same problem to Dr. Oscar Primadi. Dr. Oscar Primadi, Special Advisor to Ministry of Health, please. He's a very senior figure from Ministry of Health Indonesia, and he's been a good partner for us in the region as we've been looking at the issue of regulation.
Thank you, Ibadat. Grateful for the opportunity to be here, and then we can share insights. This is mine. It's okay. So yes, from Indonesia experience, we see that improving human resources for the health requires us to move, not only the numbers, but also the quality, compassion, and readiness for our health workforce. At the same time, so we recognize the quality improvement needs action across area, including education, regulation, and also distribution technology, and also the workforce well-being. So, and to make it sustainable, we need to openly identify, we need enables for blocks progress. So, and what opportunity we can use that Indonesian walk and run for this way. So, I try to this slide. We can see in our 2023 review, with the CRO. So we identified critical challenges in the health workforce, including Indonesia. With it is vast, in Indonesia, it's vast and diverse archipelago. Faces unique challenges in ensuring equitable distribution of health workers. Many remote areas operated without the doctors. Yeah, but now it's a good progress. While nurses and midwives often lack ongoing support and training. In addition, the system was fragmented, licensing and regulatory process varied widely, and bureaucratic hurdles made it difficult for new health workers to enter and stay in the system. These challenges collectively weaken the system ability to achieve universal health coverage. However, through this review, I have a review with the CRO, we gain a clearer understanding of the gaps and opportunities for change. It became clear the bold, coordinated reforms were not just necessary, they were possible. With shared commitment and strategic action, we believe we can build a stronger. And then the next slide. While we have made a significant process here, the slide, this Patient Health Act number 17 of 2023 is truly game changer for Indonesia. How we manage health services and health professionals nationwide. For the first time, so Indonesia uses an omnibus law, omnibus health law. So approach in the health sectors, consolidating and replacing 11 different laws into one integrated framework. This they repealed laws including major pillars such as the Mental Health Act and Infectious Disease Act, Nursing Act, Midwifery Act, and Health Worker Act, and the Hospital Act, and etc. This is not just administrative consolidation. It is a resets and modernize the entire foundation of health governance in the Indonesia, aiming to improve access to quality healthcare, manage human resources more effectively, meet community needs more responsibly, promote the use of health technology, and ensure stronger legal certainty across the health administration processes. The Health Act represents a complete shifting of paradigm from the fragmented, outdated regulation to the unified, modern, and future-oriented health system. This is omnibus law from Indonesia. The next slide. Then we can see how to implement the transformation program of human resources for the health in Indonesia. Slides, maybe from here. Okay. Sorry. Okay. Yeah. First, on the supply side, we are opening up more medical specialist program, especially for 9 priority diseases like anesthesia and heart surgery. We start a hospital-based specialist training program. No teaching hospital can train specialists directly. And we reserve spots for the doctors from remote areas, also strengthening partnership between medical schools and hospital, so students can learn directly in the public health center settings. Plus, we are offering more scholarship to encourage more young people into the health professionals. Second, deployment. We are making it easier for Indonesia who graduated overseas to come home and work here. We are prioritizing the placement of new doctors in the rural and underserved areas. And on quality, we are offering fellowship to upgrade specialist skill, and then providing regular training for health workers, and bringing in knowledge and technology from Indonesian health professionals abroad to come back to Indonesia to strengthen our local services. Of course, it is not just about training and placing health workers. We also had to make the system easier for them to work in, and that's we are the next slide. This one. Sorry. Yeah. Yes, this is you can see. Beyond the training and deployment, we are also fixing the system that regulates our health, orchestrating, starting with a big structural and process change. Before, we had multiple different councils managing doctors, nurse, and other health professionals separately. It created a lot of paperwork, different rules, and also slow processes. Now, under the new health law, all those councils are merged into one, the Indonesian Health Council. With this merger, the process for practitioners becomes way simpler. No more renewing registration every 5 years. This is long life. So no more chasing recommendation letters from the professional organizations. Instead, they get lifetime registration in a single streamlined system. So this is not just about making things faster, it's about building a system that's more consistent, fairer, and surely focused on serving patients. We are not working in isolation, it's true. It's Indonesia reforms in 2023 for the health practitioner regulation. Yeah, similar conversation and collaboration effort are taking place across Southeast Asia. So it is welcome. Let's look at how our national transformation connects with the regional collaboration agenda. So in this last slide, so this is a result of our meeting in the Jaipur. After discussing how Indonesia is translating the regulatory reforms into practices, it is important to highlight that these efforts are also highly relevant at the regional level. The slides show the outcome of the regional review on health practitioner regulatory reforms among WHO CRO member states. Yeah, we can extend, there are three major: expands the digital health and the telemedicine with the competence and provisional health workers, and continuing health practitioner education, and how to harmonization of accreditation, certification, registration, and licensing standards. Each priority area faces significant issues and challenges, including infrastructure gaps, data privacy concern, and etc. To address these challenges, several methods of collaboration are proposed. Yes, I think this is my Indonesian perspective, so we can discuss more later. Thank you very much.
Thank you, Pa Oscar. I think the scale of reforms happening in Indonesia and India are unimaginable. I think now we'd like to shift to Lieutenant General Professor Madhuri, who's the Vice Chancellor of the Maharashtra University of Health Sciences. She's also, I believe, the third woman awarded the 3-star general rank within the Indian Armed Forces. So we are lucky to have her. Professor Madhuri, MUHS has a strong focus on social responsibility as part of its mandate. How are you improving access to education across the state across different geographies and strata of society while ensuring quality at the same time. But over to you, please.
Firstly, thank you very much for inviting me to this panel and giving importance to quality, bringing in humanities into a profession which was to begin with sort of steeped in these value systems which have got eroded over time. So we are actually trying to, find how to get back to our roots. So I think that's one thing. And in that same spirit, since you did introduce me with 40 years of military training, I think it was built into a system that I came to this organization of the Maharashtra University of Health Sciences with those core value systems which were instilled through the armed forces into me, where service is put before everything, where we are taught from the day one. I mean that it is nation first, organization third, people third, the one I serve, and me last. So that's the philosophy. So with that came in the thought that when I have taken over as Vice Chancellor, how can I bring this philosophy? And it's one of the largest state health universities with 660 healthcare colleges affiliated to it, more than 70,000 students taking admission across the state in various colleges. So the first thing was doing a gap analysis, and I found that I could not equate it to some, we had a huge, that presentation was amazing by Professor Das, the inequality and the variability from college to college. I just give an example of the 68 medical colleges. The student has every right to get the best education, but someone who's in Nandurbar, Chandrapur, Sindhudurg with hardly 32%, 40% faculty, versus with someone who's with AFMC, Vardha, KM, top of the line. So that was the variability that we had to which was the biggest challenge. And the biggest gap I found was that every student he's entitled to the best care. He's entitled to the best education because he comes with the same aspirations. And we are opening so many colleges more because we feel every student has a right. And with our population and the youth, where 60% of our population is below 35 years, and I mean, the youth is aspiring, and the globe is looking at India for providing healthcare professionals. But you cannot give quantity without compassion. So this was the starting point, that it's a huge challenge. So how did we go about it? And I feel we haven't achieved it, but let me share some thoughts. I think every healthcare professional college first needs to have a philosophy. I mean, we see the outcome which comes out of colleges, say Vardha, CMC, AFMC, where you join with a purpose. Whereas today, most colleges are joined with the purpose of earn to learn, or learn to earn. And get out, give the USMLE, go out. That is changing. So unless we start top down on policy changes, that when a college does things, and those core values have to be instilled. And that needs to be incentivized and corporatized. Because finally, assessment drives learning. As an educationist, we all know that. And if we are not going to talk, and if only we are going to talk of the bad things, newspapers, social media, you never hear of the good and lauding of the good and encouraging people to be good. That will bring about a change, and you have to have that service philosophy from day one. It will come if we change the mindset of the teachers. When you cannot care for your teachers, it's not enough for, to bring in policies, to bring in councils. You can keep naming it. The change has to start at the grassroots level. The change has to start with me is the philosophy that we try to instill into every student under the colleges, that bring about a change what you want to see. So some of the things that what I feel what we've done is, firstly, we've aligned our views to a national bigger mission. And we've taken the National Digital Health Mission and the National Education Policy 2020 and the National Health Document. So as a leader, what I did was study those and found the biggest gaps that were there. And on the other hand was that on the strong belief that medicine is a science, treatment is an art. So I have to bring in a combination, and we have Satinder who's going to bring in, and we've heard so much about humanities, but these two have to be bridged, and the left brain and the right brain, unless bridged, will not happen. And every student, no one is born. I'll give you a simple example. I ran this thing in a very small remote hospital when I was posted, just to see how can I bring about a change in my ward ayas, you know, the staff, we call them ward sahikas. So I got them together, and we got my interns to do a role play of showing everything that goes wrong from, and the interns had to practice 10 days to put up that little street play, and got all the ayas and the sweepresses and the ward boys and everyone sitting there. And then I asked for volunteers of all the people, they had acted out, and send them out. And I said, I give you 10 minutes, come and show me how everything is done correctly. And they came and did it beautifully. That goes to the bottom line that everyone naturally is good. No one is doing it purposely. But if you're overburdening them, you're making a racehorse into a mule, and on an empty stomach, you expect that soldier to march on. We are mistaken. So let's start giving those basic things that are required, incentivizing good, and bringing about a change is what I'm trying to do at MUHS. So first is equitability. Whether the student now is at Nandurbar or KM or this, how do we plan to reach out? And the ADB has been really helpful for a vision plan that we are trying to roll out in the rapid fire sequence. Is firstly, we've created our own LMS with using harnessing digital technology, which COVID taught us, and using that to give access to every student, whether he's in the remotest past and across all pathies. It's not the onus that the government they've started, but we are the first state health university. We've rolled it out. We got the costing down, and we have a model where 35% is paid for by the university, 65% by the college, and every student gets an access to information. Secondly, we've started a thing called Degree Plus program, because students are going on getting degrees and not getting, the information is not changing to knowledge or wisdom. So we've given a credit-based course, and though NMC has not regulated, I think NMC gives the bottoms. Councils give the minimum. No one stops us from bringing about a change. We need to all rise above that. And therefore, we've started this Degree Plus academic bank of credits. 10 modules are out, and I hope to have hundreds of such modules. A case and example is our national, DHFC, the Digital Health Foundation course, because I need to get kids ready for the future. So our DHFC, in 3 months, I have 10,000 of my students already doing that course. And when I got asked for it, in 3 months, I've got 62,000 people doing that course. So there is a need. So let us make it accessible to people where they want, when they want, how they want, and let them feel empowered that I can use this. So I think that is an important. The other thing we are trying to get out is state-of-the-art simulation and use AR, VR indigenous. Indian AR, VR, these things to get out to, so that the top colleges in a hub and spoke model, how can I link up colleges that there's an excellent lecture going on? We did a survey of 1,000 students. None of them want those PowerPoint presentations from doctors. None of them want teachers. They want bedside. They want role models of teachers. Let us pick up those teachers and say these people will teach them, and not let anything and everything go on, So that is something where we've started. So we've started a department of digital health. We've just registered a Section 8 company under a state health university. Again, thanks to ADB. Started a postgraduate institute with a ethos, college for community. I mean, I've given it the philosophy. So everything, the MD thesis, the MS thesis, the PhDs, everything that goes on is for community, evaluated by patient outcomes, evaluated by patient safety, and an integrated approach to health. We are the first health university to roll out what does the society need. Today, the society and the patient care is going to the thing because we are all suffering from cystitis. The human body has been broken up into parts. You have the cardiologist. The patient has to decide, I need a cardiologist, I need a nephrologist, I need a this. Yogesh is sitting here, we had these conversations over years. So where do we need to get down to, and have we put this philosophy in the student? Have we glorified becoming a family physician? Why not? That is where we need to bring about a policy change. Unless we do that, we'll keep producing doctors for this. Sorry, I think I am running out of time. I'll continue with your next thing because I can speak for hours. I'm passionate about this. Thank you so much.
No, thank you, Professor Madhuri. Very powerful. I know we're running short on time, but we have so much richness here. And we also have richness online. We have Professor Harry Caton. He was the UK Department of Health's first founding director of Public and the Patient within the UK Department of Health. He went on to become the founding CEO of the Professional Standards Authority, and for his work on health and regulation, he received the Commander of the British Empire from the former UK Queen. Harry, a few reflections on you. We have passed your paper around on what you believe should be the new idea of professionalism. So a few words, and thank you for joining us, Harry, from the UK in these early hours.
Good afternoon. I hope you can hear me okay. It's a pleasure to be with you and to see a number of people who I have met personally and worked with before, and it's really a good experience now. I think I'm meeting friends across the world. So a couple of things about myself that are relevant, that I was particularly listening to Professor Saroj. A few years ago, I chaired a committee in the UK on arts and health. It was jointly funded by the Arts Council and the Department of Health, and we produced a document called a prospectus for arts and health, which gave many examples of the way in which our health system is using the arts to enhance both the experience of patients and the skills and ability of professionals. I'm also patron of a charity called Arts for Dementia, which works with people with dementia to engage them in arts, both as participants and as audience. And we have a particularly strong record in developing music as a tool for enhancing the quality of life of people with Alzheimer's and other dementias. So I feel personally very engaged in this issue. And I want briefly just to comment on some of the things I've heard this morning and on two particular ways in which I think professional regulation can enhance both quality and compassion. So the first is to talk a bit about professionalism, which Ibadat has just mentioned. I gave a paper on this a few years ago. What we find is that regulation itself does not create professionalism. What does create professionalism, and I think we've just heard this from Dr. Madhuri, is the role models that young health professionals work with. So in terms of our moral commitment, how we behave will shape how others behave. And that seems to me to be a fundamental lesson that leaders need to, not to learn, but to actually live out. Your behavior as a leader shapes the behavior of those who are learning from you. And we found in a survey in the UK that those health professionals, young health professionals who learned to be really compassionate human beings, mostly, but not entirely, learned that from their teachers, from their mentors, and from their leaders, and not necessarily from the standards written by the professional regulators. So that's the first thing that's really important. we have to look into our own hearts and into our own behavior before we start to criticize others. I have argued in favor of a form of professionalism which moves away from individual qualities. Traditionally, doctors in particular were supposed to have mastery of their subject. A sense of the word mastery brings a sense of power and overall ability. They were meant to have sympathy for those that they cared for, but I very much prefer, as Professor Saroja suggested, that the word empathy is a much better sense of what we need to achieve. That is, to put yourself in the position of the other person, not just to feel sorry for the other person. They also used to have autonomy, and there was a big, strong sense, I am the autonomous health professional, I make my own decisions. But we all work nowadays in teams. And I think those three things, mastery, sympathy, and autonomy, which are personal attributes, are no longer sufficient. We need a social and team-based concept of professionalism. I suggest that it should be, rather than mastery, it should be expertise, which includes using your knowledge and finding out new knowledge as you go along and adapting to change. Empathy rather than sympathy, and mutuality rather than autonomy. Shared decision-making, engagement with others. So I think we should define professionalism as a set of relationships. Our relationship with patients, mutual respect between health professionals and those that they are caring for, our relationship with colleagues, so that is very much about teamwork and about engagement with others and about respecting the expertise of colleagues. Our relationship with knowledge, which is no longer a fixed thing, but as you know, with the internet and with IT and increasingly with AI, knowledge will be constantly shifting, and our job is to assess the value of data rather than just to use it. I worked with a young doctor here in the UK a few years ago. He was a medical student at the time. He's now fully qualified and working in Canada. He said to me, you know, when we started, we used to have the pharmacopoeia in a book, which we carried in our white coat. And now he said it's all on my mobile phone. This is the kind of change of our relationship with knowledge which we need to understand. Our relationship with self, so mindfulness, self-consciousness, self-awareness, and finally our relationship with community, understanding our role as health professionals, as contributors, significant contributors to the moral fibre of the countries that we work in. So I would like to redefine professionalism as this set of relationships, not as a set of personal attributes. And I think from that we will be able, as it were, to build on those personal qualities that several of you have already talked about, to do with developing compassion and understanding and behaviours. Just to touch briefly then on how does regulation become more compassionate? And we've also just heard mentioned the burnout that many health professionals are experiencing. And we've seen this in many countries, particularly since COVID. How do we enhance the resilience of health professionals in the face of the challenges that they have to deal with. So often regulation is seen as a kind of police force, not supporting health professionals but punishing them. And obviously right touch regulation, which I actively promote, is about getting the balance right and seeing regulation as a supportive activity to encourage and enable health professionals to be more resilient, to understand quality, and to act as a member of a health professional team. There's a story that I quite like about two people standing by a river, and they see drowning people floating past them, and one of them dives in to start saving the drowning people, and the other one runs away and runs up the riverbank, and the one who's saving the drowning people says, "Where are you going? I'm saving these drowning people." And the one who's running up the riverbank says, "I'm going to stop them falling in the first place." So I think we should be moving to a model of regulation that is more about preventing health professionals from coming into a world that is overwhelming, that is too stressful, and we should be acting sooner when we detect people who are weak either in their clinical knowledge or in their personal behavior in order to remediate. We need those health professionals to go on working. So we need a remediative model of regulation rather than a punitive one. So I think that professional regulation can contribute both to quality through standards, to professionalism through regulating for teamwork, and to compassion by being compassionate itself. And I'll stop at that point. It's an honor always to be with these meetings, and I very much appreciate your time. Thank you.
Thank you. Thank you, Harry. I think there's so much wisdom there, so much wisdom in this room. Dr. Satendra, please, if you could join us. Professor Yogesh, Dr. Sharmila. I mean, each of you is displaying these same values in different ways and in different contexts. Dr. Satendra, I think another champion of health humanities. You've shown us how you can have health humanities incorporated both in the education side, but also in regulation. So maybe a few words, Dr. Satendra, from you on just, how you have, wait 1 second. Yeah, how you have championed on the realities of India and how you believe health humanities can help address some of these issues.
Thank you so much, Ibadat. And if I may say, Dr. Ibadat IAS, quote unquote. I'll talk about that later on. Yeah. So the Southeast Asia region of WHO is unique, and it is home to a quarter of world's population. And within this group of 11 nations, India has the maximum number of medical schools, 730 to be precise. And India produces the maximum number of international medical graduates for US and Canada, thereby contributing to their diverse physician workforce. So that is why it is important that what we are producing in this region is not only empathetic, but also compassionate. But having said that, this Southeast Asia region has its unique peculiarities, unique challenges. Number one, overburdened health systems. In Nepal, the doctor-patient relationship ratio is 1:1700. In India, at the PHC level, the Indian doctors usually carry out 40 national programs. Now, what happens because of this is that there is a very limited time, and thereby the focus is more on proficiency rather than human connection. Another unique feature of this region is its cultural and linguistic diversity. Within India, in the northeast state of 8 states, we have around 200 different tribes. In Nepal, we have 125 ethnic groups. And also, we need to tailor approaches which are unique to their cultural context. Because even in India, what you see is that within the LGBTQ community, we have different transgender groups within the socio-economic framework like Jogappa, Kinnar, and the Hijra community. And also, even the sign language in India varies from South India to North India. And that is why these approaches needs to be defined to a level so that we are also taking care of the unique needs of, for example, Baigya community in Madhya Pradesh and Chhattisgarh, who for a very long time was denied the basic human right of contraceptive care. The domestic violence survivors in the rural Gujarat area. Third thing which Professor Saroj talked about was empathy decline, and this was the study which was done at my institution in New Delhi, UCMS, where we found that the empathy level decreases from the first year to the final year. How to keep the innocence alive. Then we have stigma and marginalization. A clinical doctor from a clinical specialty, anesthesiology, when she went to her own alma mater for gender affirmative services, she was a transgender doctor, the postgraduate stopped her at the gate, went back to the head of department, came back and said, "Doctor, we will be charging you." Normally we don't. But our head of department says that if we don't charge you, people like you will start coming to our hospitals. Attitudinal barriers, marginalization. Within Delhi, when we were preparing disability competencies, we heard the stories, the horrific stories there where doctors were not touching people affected by leprosy. They were using ball pens to open their eyelids. Also, there is a burnout and systemic pressure. For example, in Nepal and Chhattisgarh district, there is a huge burnout which you are seeing. A recent study by Aziz et al. Shows that there are 63% prevalence rate of burnout, maximum being 70% in Philippines. So what is the solution? Health humanities holds the key. Why? 5 reasons again, because it enhances empathy, it mitigates burnout, it addresses implicit biases and cultural competency, it increases patient trust, and more important, it aligns with the WHO goal. If you look at the WHO global standards of HRH Workforce 2030, it states that every member of the community should have access to a health worker without discrimination and stigma. Moreover, recently the global competency standards for disability inclusion for health workforce are being drafted. I'm part of the technical committee, so now disability competencies are going beyond India. It is becoming a regular part of, in fact, all of the WHO competencies. You heard the example of Bihar regarding the CBCT, where compassion therapy has been practiced, but also, countries like Thailand, where there is a huge statelessness. I think 5.9 lakh people are in a state of statelessness. We need to tailor our needs based on humanities. There are examples in China as well as Thailand that we can use narrative medicine and poetry to inculcate empathy. So finally, my recommendations for how we can achieve this is 5 points. Number 1, we need to mandatory health humanities in the curriculum. Not only the medical and nursing, but also the allied health professionals curriculums. We need to scale grassroots level training programs. We need to incentivize systemic integration using health system audits. We need to fund research. Do you have any idea in the hall that, how much do we spend on disability inclusive health programs globally? Any wild guess? 50, 40, 30, 20? Not even 10%. It is 0.4% as per the recent OECD database. That shows that the agenda of 2030 will never be achieved. And finally, regional collaboration. Yesterday, Ibada talked about that they are in the process of regional network of regulators. It is very important because if you look at the example, because of my judicial advocacy, disability competencies were part of the medical curriculum. NMC did that. But nursing curriculum do not have that, despite our law mandating that. Dentistry curriculum do not have that, and I need to check the allied health professionals curriculum also. So that's why it is important that the regulators are sensitized in line with nothing about us without us. When those curriculums are being made, involve us, the real stakeholders. Thank you.
Thank you. I think passing over quickly to Dr. Yogesh. I mean, Dr. Yogesh, from 1982 AIMS Delhi cohort, I think. I've learned, being in India, how important it is to be an AIMS Delhi doctor, but who then went on to the most rural areas in Chhattisgarh. And you built teams to provide care for the most vulnerable. So can you speak a little bit on what you believe is important, especially in the role of mentorship and role modeling we've heard here?
So I would suggest 2 things, and hope that WHO CRO as well as Professor Kavita and then and Dr. Madhuri would take on. The first is, I think, if you really want to consider competence along with compassion, I think the minimum requirement is that all health professionals and not professionals, because we belong to different classes, social classes, economic classes, except the ASHA, everyone else, all the health workers belong to a different social strata, socio-economic strata than the people whom you're serving. So therefore, you need to have some sort of a mandatory exposure if you're not even at least drawing them from those communities to, to sort of recruit them, is a minimum requirement. And I think that has to be done not once probably, but maybe periodically throughout your period of, of your training. And I would strongly suggest that, it's not something to say that, when people can get away from by just, by gaming the system. That's my first. I have a second suggestion, which is a larger one about mentoring. I usually have a dim view about whatever we can do about training and training during, however you may do about, informal and informal training that you do. I mean, I'm not saying that we don't want to, that is essential but not sufficient to be able to continue to have people, professionals who come out of after all these trainings to remain compassionate and to remain competent. And for that, I feel one of the missing pieces in the entire healthcare training that we have, in the healthcare, professionalization, is the role of mentors. We don't even hear this word in HRH about mentorship. We don't have training for mentors. We don't, I mean, some of us who have become mentors, we have never been trained. We just learned it on the curbside, in a sense, to become mentors. And finally, we don't have mentors formally being allocated mentees given a mentor. Some state medical universities have considered that. I remember at AIIMS we used to have mentors being there, but I don't think my mentor was trained. But so I think what I'm trying to propose is, if you want to continue professionalization along with competence and compassion, you require individual mentoring first, of all cadres. I'm not only talking about physicians or nurses, but even all other people, by trained mentors. So if we have TOTs, we don't have training of mentors, TOMs, in a sense. So why don't we have, and this is there in some management professions, but not in healthcare. Why not? And the second bit is, I would say, and those requirements of how do you learn active listening? We all health workers are taught to speak, but never to listen. So that will happen when you learn, when mentors can teach those things. And mentorship is actually, if you understand this idea, it's a supportive relationship, a relationship which is long-lasting, not just one time when you teach a student or when you hear when you examine the person. So the mentorship is a supportive relationship when you are there available to even use what you have learned to be trained. Say, if I learned about how to manage a snake bite from a teacher, but when I really have to manage a snake bite, if I have a worry in my mind about decision making, about whether I should do this or that, then I should be able to reach my mentor to ask, do you think I'm okay with doing it? And someone says, just do it, That's what a mentor has to do. And that is individual mentoring. But I think, as we heard from Dr. Harry Clayton, about, teams that we need. Primary healthcare will be delivered by teams. So we have people at the moment thrown together in various institutions that we know, whether it's health and wellness centers or in primary health centers, but who don't work as a team. In fact, they often cut each other in these things. So, how can we not, develop those team spirits about, conflict resolution, about communicating ethically, about learning from what you're doing, about shared leadership, those things and also how do you communicate with people? How do you listen to people? And with those people whom you are serving, those, if you don't think that we can get mentorship as a key HRH strategy, besides training, besides, examining people what you are doing, and this is required for a lifetime. I would like to know maybe 4 or 5 mentors for my life, and why not all the mentees should also. Thank you.
Thank you. Thank you very much. I think this connects also very nicely with Dr. Sharmila, because Harry said, mastery and autonomy versus our connection and our relationships. So why, Dr. Sharmila, you are a pediatrician. We will take 5 more minutes. You are a pediatrician who's worked in the US, in India. Why do you believe these universal human values are so fundamental as we're talking about the subject today? Over to you.
Thank you, Ibadat. And thank you, everyone, for listening, waiting patiently. I think the important thing here is that what we've been talking about, quality with compassion. So what does it need? And I think one of the key things that is required is a holistic, humane world vision. And this is what we are trying to do with the universal human values, putting it in a format which is universal, so that there are no boundaries, so that it can be, over the globe for everyone. And what that involves is truly clarity about 3 things. Clarity about the human being, clarity about this existence of which we are a part, and clarity about our purpose as a human being, our role in this existence. So essentially what we're talking about is when we say clarity about the human being, that the human being is not just this body that we see in the mirror every morning, that the human being is consciousness coexisting with the body. And so how that interplays. Clarity about the existence, not just being a material existence, but having material and consciousness units, and how that plays. And thirdly, the purpose or our role as a human being is to complement all the other units in nature, which includes other human beings, obviously. So to complement the other, how to help the other. So this is essentially what is being put across as universal human values, under that term universal human values. And I'll just come to it in a minute about how health would look with this. But the interesting experiments that we have had with UHV, or Universal Human Values, is that this was started just as a volunteer thing with maybe a couple of volunteers way back in the 80s. And slowly it built up over time. And in 2017, All India Council for Technical Education noticed these efforts and thought it was very worthwhile and took it up, sort of supported it. And there has been experience with, this Universal Human Values has reached more than 90,000 plus engineering faculty teachers, more than 12,000 students. And interestingly, what has been found is that a study was done by IRMA, Institute of Rural Management in Anand, Gujarat, which was facilitated by AICTE. And what they found was that in those people who went through these workshops and who were exploring the content, they had collaboration and teamwork, which we are hearing about a lot of today. They had more, physical health was improved. Mental health and well-being, they said they were feeling, they could see a difference. Academic performance also improved. And awareness towards nature improved. And I think all of these combined is required to have this empathy towards the other. If you see, if somebody is sick in the house, we will do whatever it takes. Even if I don't have the quality in me, I will go to somebody who has that quality, but I will get that person treated properly. So why is it not happening? Dr. Jishnu Das mentioned about the reason why the quality is not working. So, if I don't see the other as related to me, then it's not my problem anymore, even though I may have had the best medical training. So I think that is important, that we see that compassion. Dr. Harry also mentioned about empathy, not sympathy. So all of these put together, I think, is why universal human values is a must. And when we look at health from this perspective, So understanding the self or the consciousness, I'll just finish it up in half a minute. Understanding the self or the consciousness, understanding the body and what keeps the body in harmony, understanding this environment, and environment includes family, it includes society, it includes nature, it includes all of existence, because we are all, a member of a family, we are all somebody in society, and we are all embedded in this nature, and all of this has an impact on health. So if we look at holistic health, then we have to look at all of these parameters and what keeps them in harmony. And I think that is key to ultimately being able to serve our purpose as professionals in health also. That's what I wanted to say. Thank you.
Thank you, Dr. Sharmila. And really, for our last to close, I give Dr. Shanti a very difficult task to close this discussion, but you have such a rich experience. Dr. Shanti is the Director of Health and Social Development at the Asian Development Bank and has a long experience in education policies in particular. So over to you to close our session.
Thank you. Thank you so much for inviting me. I'm a bit of an outlier. Everyone else in this discussion comes from the health and medical and health field, whereas I come at it from the education and training field. It's been a fascinating discussion, hearing everyone here. To keep it brief, I would like pick up on 3 points, from what I heard, and what I really feel is important for health and education to work together. Everyone talked about quality, and many people mentioned the inequality and the variability in the quality of care. So the first thing to think about is massifying quality, or quality at scale. How do we do this? And it really cannot be done unless we look at the massification of quality in the education institutions themselves. So if the quality of learning and education in the institutions are varying, the quality of the professionals that come out of them is also going to vary. So, sort of in terms of accreditation of standards, learning levels, learning outcomes, we really need much more robust accreditation and quality assurance mechanisms of education and training institutions. The second is about, when we think about all the things that we heard today, it's not just about technical knowledge. So which also means that we really need to think about how education and training is delivered. We have to go beyond the classrooms. We need to look at methodologies that are more experiential, bring real life, approximation to real life settings to the people under training and under education. I'm so glad that you mentioned mentorship. I think we really need to have much more emphasis on apprenticeships, internships, and students being able to shadow experienced people. And, empathy and compassion is very difficult to teach through textbooks, but you can really learn, be inspired by people who practice them in real life, and by being able to shadow, experienced people. And also for mentors to take under their wing and really nurture talent, nurture the talent pools of the future. So that's really the second point I wanted to make. And of course, STEM and STEAM is now like a common topic that we should take on board. And the third point that I wanted to make is about having a more agile and more responsive education and training systems that moves with the times. We heard a lot about digital. So I think we need to think about short cycle courses supported by digital credentials that complement degree and long range programs, a more diverse set of offerings for the future professionals in the sector. Thank you so much.
I think we will close the session, but we can follow individually. We are in tea break. But thank you to our colleagues, for all the respected panelists who are here in person, those who are virtual. This is really a snapshot. You are most welcome. But and after the tea break, we will also have the Novo Nordisk Tropical Foundation of India session on nursing and midwifery. So please come back. But please, you can make your session.
Absolutely right. What I've written is very small. Compassion, according to me, is a fellow feeling. It's a basic instinct. It's more of one's concerns for the other person. Health is important, but look at Buddha. During his illness, he was also compassionate towards others.
Powerful message from yes.
Oh, Satyendra, how are you?
Cardiometabolic diseases are increasing in prevalence, and also it requires, I think it is crucial.
Good afternoon, everyone. The next session on empowering nurses, transforming healthcare, and building a resilient workforce for the future will start in a few minutes' time. We request all the participants to be seated. Thank you.
that
A very good afternoon to all colleagues and friends. I want to take this opportunity to welcome every one of you for this very important session around human resources for health in India. This session is titled Empowered Nursing, Transforming Healthcare, Building a Resilient Workforce for the Future. We all recognize that the nursing workforce is integral to a lot of the aspirations that we have in India around building a universal health coverage and a very important mechanism for assuring the health of citizens in our work towards a healthy Bharat. In this session, we have several esteemed speakers and panelists, and it is my personal privilege first to take the opportunity to invite on stage Professor Sanjay Zodpe, President Public Health Foundation of India, for his opening remarks and the overview of the session. Over to you, Professor Zodpe.
Thank you, Dr. Himanshu. Good afternoon, everyone. It is my great pleasure to welcome you all to this important session at the World Health Summit Regional Meeting 2025, which is being jointly organized by Public Health Foundation of India and No Nordisk Foundation. The theme of this session is Empowering Nurses, Transforming Healthcare, Building a Resilient Workforce for the Future. India, a country of over 1.4 billion people, has made a commendable progress in improving various health indicators over the years. And this progress could not have been achieved and possible without the backbone of our health systems, which is its health workforce, doctors, nurses, allied health professionals, community, and frontline health workers. Improving the performance of the health system starts with creating a robust and skilled health workforce. Therefore, investing in health workforce is crucial to continue making progress towards the universal health coverage and advancing the larger agenda of sustainable development goals. The National Health Policy and the Ayushman Bharat initiative led down by the Government of India has a strong foundation for reforms. The introduction of the health and wellness centers, a focus on digital health, and steps to strengthen the public health management cadre are significant strides looking forward. We need to continue investing even human resource capacity building, attract and retain talent in public sector and particularly in the rural areas. There has been a tremendous expansion of country's capacity to train the medical doctor and specialist, particularly in the last 1 decade or so. Urban centers remain relatively well staffed, but rural health centers in some states struggle with the vacancies. And therefore, we'll have to continue to invest in the quality of training, distribution of health staff, and continuous professional development, which is so critical in advancing the larger agenda of health workforce development. Alongside continuing to improve the quality of healthcare training, we are not only enhancing our health system, but also creating opportunities to support other nations facing the critical shortage of the health workforce and even support them through the knowledge sharing. India's surplus and high-skilled health workforce can serve as a vital resource for the countries where global demand for the healthcare professionals continue to rise, as well as the aging population of the high-income countries. To discuss more on this, especially in the context of the nursing profession, we are proud to partner with the No Nordisk Foundation in convening today's dialogue. This platform today has brought together the voices from the government systems, health policy, nursing practice, and academia. We will deliberate on strengthening nursing education and health workforce development and need for institutional and instructional reforms in this context. Hence, moving forward, I would like to welcome you all for this esteemed panelist amongst us whose thoughts will kindle some enriching dialogue, and we will have a path ahead of advancing the larger agenda of health workforce, but today's focus on nursing education and nursing as a profession, how it can be developed further forward. I welcome you all for this discourse and dialogue today around the nursing profession. Thank you so much.
Thank you very much, Professor Zodpe, for the opening remarks. Taking the session forward, I would now like to request Dr. Ibadat Dhillon, the Regional Advisor for Primary Healthcare and HRH at WHO CRO, to come in for his special address and opening remarks. Ibadat is not just a regional advisor, but also a very strong advocate of what we do within HRH He's been a pillar of support for several activities that we've undertaken within the country and in the region over the years. I'm really privileged, Ibadat, if you could come in for your session.
Thank you. It's an honor to be here today. I want to thank especially Professor Zodpe, Novo Nordisk Foundation, PHFI. You know, we were at the address a day and a half ago. Was it 2 days ago? But it's amazing that the vision you crafted in 2006, when I walk around the World Health Summit and see how many people are linked to the Public Health Foundation of India in different organizations, I think it is something to be very, very proud of. And we are happy to be present at this meeting. So I think many of the issues we discussed today, Shivangani asked me, Himanshu asked me to say, can you say a few words about a future-ready health workforce? So a few very quick slides, then my colleague Ai Tanemizu, who's our advisor on nursing and midwifery, will speak a few words. But in general, I think as we look at the future, we have to look at the past. Please take a moment to read this. It's very important. And we had a meeting with Access Health, I think a month and a half ago, where the CEO of Tata Trust said there are 1.4 billion people in India. About 100 million of them live at the average GDP of Mexico. About 300 million of them would live at the average GDP of Indonesia. And 1 billion of them are living in the context of what would be a GDP of an African country, sub-Saharan African country. So this question, this complexity of human resource for health, fundamentally the question in front of is, are the needs of the people who are the bottom billion in this country being met through our human resource for health? So I think this is a very important point. It's a very difficult, challenging area, human resource for health. Forward-looking health systems, I think this one is really, I think we all know these slides, many challenges and changes that are coming upon us. Even how we define health in the future cannot be how we defined health in the MDG era. Much of the workforce was to deliver on the MDGs. We have different challenges ahead of us today. But in all of this, probably the most important statistic that has hit me since I came to India in 2021 is this report in Niti Aayog, which shows that the health sector is growing at a compound annual growth rate of 16% per year, which means that fundamentally every 4 years, the health sector is doubling. Which means that when I came in 2021, it has doubled since then, which means that in 2029, we will have whatever we have plus another one. And I say this for a reason, because we talked about values in the session before this. I won't go through these numbers, they're there. Production capacity has gone through the roof. The numbers, as Kavita knows better than all of us, this is from her work. You know, the numbers have increased very significantly. This is already probably outdated. This was end of last year. But really, it is this growth, especially in the health sector, that is driving this number. But the question is, how much of this number is oriented to that first billion that we were talking about? And I think that is what Professor Zodpe was also talking about, and in the values that we are addressing. Here's another graph across our countries on where the different professions reside. Again, showing where, despite the growth, for certain areas we have gaps, especially in some of the major health professions. So I think we discussed quality before. I won't go into it. Professor Dishnu did this in much more detail. But really, as Kavita and others, Dr. Oscar, very significant reforms took place. So why did these reforms take place? They were very difficult reforms to put in place. It really was trying to focus on how do we really get better outcomes? And it's happening all across our region. So this is important. And finally, I love this graph from Dr. Sundar, is that it's very important to speak about nursing and midwifery, but in the context of teams. And this little graph, this picture that Dr. Sundar had put together for the National Health Mission of how the teams are meant to work together. This is probably the most difficult challenge we have in front of us, but also our biggest opportunity is really we can maximize through team organization. Finally, just to say that the numbers are increasing significantly. These were the evaluation done on our 0 decade for human resource for health strengthening. But how do we transform these resources into accessible and quality and people-centered health services and systems. And that's really, I think, that what the vision we want to move towards. And so that is when you asked for what the forward-looking agenda on human resource for health. This probably is my short summary of it, but passing over to Ai to speak on our specific work on nursing and midwifery. Over to you, Ai.
Thanks, Bharat, and thank you very much to the organizers for putting this important session on nursing in this World Health Summit. We're talking about the profession that makes up more than half of the health workers in the region. So I don't have any slides, I'm just gonna talk. But I really want to reflect. If you have been working in nursing in this region, you probably understand the shift that's taking place. The shift that I see is, first of all, nursing is a profession of the art and science. Yet, I really feel when I look at the curriculums, when I speak to students, when I go to the nursing institutions, that we're missing the art component more and more. And there is so much more emphasis on the science component of nursing. And then if you listen to what the medical profession is saying, if some of you were here in the session before, they're looking at arts, right? They're starting to look at arts. So what is this shift that I'm seeing? So in nursing, we're focusing more on this medical-based education. You know, if you listen to nursing students, if you ask them a question, they usually have a response that's medically based. And yet when I talk to them, I say, what is your nursing diagnosis? Nursing has its own philosophy. We have our own profession, our own autonomy. Why are you trying to be your colleague? Because you leave that up to the physicians. We have our nursing process that we follow, and why are we not talking about that? So I see this shift definitely between nursing and the medical profession of the art and science, and how we are becoming more and more disease-oriented and less patient-centered. Our profession is clinically based. Yet, I see a lot of clinical instructors and faculty who have no experience in clinical. So do we have to revise our policies? Do we have to look at policies to see, do we want our faculties, do we want our clinical instructors to have at least a few years of clinical experience? Because if our profession is based on clinical, we want them to focus on that. That is what makes us nurses. How about the policies on recruitment of faculty and instructors, like I was saying? When we think about competent nurse, what is a competent nurse? Is it a nurse that can provide care with compassion? Or is it who can listen to the doctor's orders and will carry out those orders? So when we look at the curriculum, what is the hidden message that we are trying to put into the nursing curriculum? I feel, again, that when I look at the curriculums, I talk to the students, more and more we're becoming medical-based. And we're really missing what makes us nursing. So again, what is a competent nurse? Going back to what Ibadat was saying, it really should be nurses that can provide that care for our population. What do our patients want? You know, what kind of care is it that they're looking for? So I know that I don't have too much time and I just want to wrap up, but are we using reflection in practice for nursing? You know, this is what makes us nurses. But yet, are we bringing in reflection, or again, are we basing all the questions on science and medicine? At WHO, we do have the strategic directions of nursing and midwifery 2021 to 2025, and nursing education was definitely one of the pillars of the strategic directions. Now, most of you will probably know that it's expiring this year, but it will be discussed at the World Health Assembly next month. And so hopefully it can get extended, because we do know that nursing education, we still need to focus on nursing education and prioritize this area. At the regional office, we have developed a tool to assess the competencies for nurse educators. This has been utilized by some of our member states, and this has been helping to assess where are the gaps when we compare them to the nurse educator competencies that we have. The State of the World's Nursing Report will be released later on on May 12th, on International Nurses Day, and we do have more evidence now on what the region is doing for in terms of policies for education. So I'm not allowed to share it yet, but I hope that I can give you another presentation next month, and I'll see you, some of you, for the International Nurses Day. So that's about it for now. Thank you very much.
Thank you very much, Ibadat. And I couldn't agree with you more, Ibadat, when you say that the global context is changing. The demand for services within the healthcare is also evolving within the country. And you talked about both the art and the science component in the delivery of care by doctors or by nurses. And these are very important considerations that should be there in our mind before we make any of our decisions. Moving forward, I would now like to take the privilege of inviting Dr. Lata Venkatesan. She's the professor, the principal at the College of Nursing at AIIMS Delhi. She's had a very long and illustrious career that has spanned over 3 decades and has significantly contributed to nursing education at AIIMS and within the country with several initiatives that have been taken at her behest. I would like to request you, ma'am, for giving us an overview of the Partnership for Education of Health Professionals, the PEP program in India, and the plans to strengthen nursing education as part of PEP. Thank you, ma'am.
Namaste everyone, and thanks to PHFI and NNF for including a session of how to prepare future ready nursing professionals. So I'm here to talk about how we are going to prepare the nursing graduates. They will be prepared to meet the changes which are expected by the community as well as the employers. So, you know, there is an increasing need for strengthening human resources for health. And of course, nurses are the largest healthcare providers. They form 70% of the healthcare workforce. And still we require more nurses to be prepared. And the role of nurses are also getting expanded. And you know, in India, the health and wellness centers were introduced and they are managed by community health officers, and they play a range of functions from preventive to that of promotive and rehabilitative services required for 5,000 population allotted to one community health center. And there are also epidemiological transitions which are happening. So we need to prepare the nurses to work along with these epidemiological transitions, because especially there is a movement from NCDs to CMDs. So whereas if you look at the nursing curriculum, we did a curriculum gap analysis, the CMDs are not really dealt in depth, you know. So it is essential to strengthen the education in the field of CMD. And definitely there will be a lot of career opportunities and leadership opportunities in the given field if we recognize the gap and patch up the gaps in nursing education. And so the key is we have to prepare future resilient nurses. And so we have to prepare them to migrate from NCDs to CMDs. So it is essential to strengthen the educational institutions and especially the faculty. If the faculty are prepared, they will be able to impart the education which is competency based, especially in the field of CMD management. And you know, it is also required to incorporate technology into education. So blended education is gaining the momentum, whereas our faculty, whether they are trained or whether they are competent enough to implement blended learning is the question. So it is essential to develop the faculty competencies in the field of blended learning. So these are the key focus to prepare the future resilient nursing workforce we are aiming at. And we are thankful to NNF for engaging us in the project which is known as Partnership for Education of Health Professionals. And this project is initiated with the vision of reaching out to the people living in vulnerable positions, especially in India and East Africa, and promoting equitable access to quality prevention of cardiometabolic diseases is the vision. And our mission is that health professionals are equipped to provide quality prevention of the cardiometabolic diseases as well as to care for the people living with CMDs. And if they have to care for people living with CMDs, they should know how to prevent it as well as how to diagnose and manage the CMDs. So we have to match the competencies related to prevention as well as diagnosing and managing the people living with CMDs. So within a PEP, nurses are recognized as direct target group. AIMS also had PEP phase 1, in which we were integral part of the medical education. Whereas in phase 2, we are expanding to recognize nurses as a distinct target group. And we are empowered to take up this project along with our key partners. Within India, there are three key partners, and of course, we are also collaborating with 3 university colleges from Denmark. So within India, AIMS, CMC Vellore, and the Regional Nursing College, which is part of Government of Assam, are the Indian partners, and we are also partnering with University of Copenhagen, Absalon, and Via University. We had the opportunity to visit them and plan the project with the better understanding between the partners. And by 2030, we are aiming to develop the faculty competency. We have identified 4 major verticals, that is clinical decision making and leadership, simulation didactics and pedagogy, online and blended learning strategies, and strengthening education research. So once we develop the faculty competencies in these 4 major verticals, and they are expected to incorporate these methodologies into developing evidence-based CMD educational modules, and these modules will be developed partnering with our other overseas partners as well as the Indian partners. We have identified areas of CMD, and when we develop the modules, we will be exchanging among ourselves, and we will be mutually strengthening each other, and a lot of activities are planned for the next 5 years. And of course, research is an integral component. We are going to strengthen educational research, especially in the field of CMD, and we also have the opportunity to enroll PhD students who will be working on CMD care models. So in general, this is what is being planned to develop the competency of the faculty in the methodology and technology, which will be incorporated into developing CMD education. And the CMD education will be done in partnership with all the institutions in India and Denmark and Kenya, and we will be mutually benefiting with each other. And ultimately, this is for your further information, we are planning to reach out to the numbers. We are planning to reach out to 200 educational institutions in India and East Africa. And of course, we will be training 10,000 faculty members in these 200 educational institutions. And those trainers will be training the future and current healthcare professionals. So ultimately, we are aiming to reach out to 2 lakh health professionals who will be future ready to meet the challenges associated with CMDs. And once again, thanks to PHFI and NNF. Any questions? Yeah, thank you.
Thank you very much, Dr. Lata, for giving us an overview of what the PEP partnership is doing in strengthening nursing education, particularly with a focus on promoting equity and access to quality services for those who need it the most. So taking the session forward, it is now my pleasure to invite my colleague and co-host for the day, Dr. Shivangini Kardave, to be the moderator for the panel discussion on strengthening nursing education for workforce development. Shivangini works with the NNF India office and is a partner in crime for all the activities that we're doing here. Thank you.
Thanks, Himanshu. Thank you, Ibadat, and thank you, I, for giving a regional perspective, but also setting the context for our discussion today with the panel. And also thank you, Dr. Lata, for sharing an overview of the PEP. It's very relevant, and we'll also hear from Mete after the panel discussion a little bit more about PEP. It is my pleasure to now call upon our panelists who come from a very strong background, especially our nursing leaders who are there in the system today, and also some health experts who have been closely focusing on nursing from different organizations, especially the development sector as well. I would like to call upon Dr. Deepika Khaka, who is the nursing advisor at Ministry of Health and Family Welfare. Dr. Khaka has her career spanning for more than 3 decades and has played a pivotal role in advancing nursing leadership at the national level. She has also contributed a lot in all the nursing policy reforms that we see today across the country. Dr. Khaka has also trained more than 0.3 million nurses across the country and continues to be a strong advocate for nursing standards. Thank you so much for joining us, Dr. Khaka. We also have Colonel Sarabjit Kaur. She is the Secretary of the Indian Nursing Council. Colonel Kaur brings with her, again, more than 3 decades of experience in nursing leadership, and she's also the facilitator for Global Nursing Leadership Program of the International Council of Nurses for the CRO region. Thank you for joining us, Colonel Sarabjit. Next, we have our very own PEP partner, Dr. Vinita Ravindran. She is the Dean of the College of Nursing from CMC Vellore. Dr. Vinita also brings with her decades of experience from nursing education space. She's also leading continuous nursing education and is also leading research in nursing a lot. College of Nursing is also designated as Institute of Excellence by the Ministry of Health and Family Welfare and is also a WHO collaborating center for building nurses and midwifery in the country. Welcome. Next, we have Lakshmi Sripada, who is representing World Bank. She is a health specialist with World Bank and has expertise in human resources for health. She has been an advocate for strengthening nurses across the country and has been working very closely with the state governments as well as the national government, very closely with the nursing team as well. Thank you for joining us, Lakshmi. Next, we have, last but not the least, we have Dr. Hilde, who is the team lead at WHO India office. She leads the health systems department and she plays a pivotal role in advancing UHC and strengthening health programs, closely working with the government of India at the state as well as federal level. Thank you for joining us, all of you. And to begin with, and I would like to pose this question to, of course, Dr. Khaka, as we navigate the complexities of the health systems in India. One thing which remains absolutely clear is that the quality of nursing education is directly impacting the kind of care that is being provided on ground. We know there has been a lot of reforms that have been done by the government itself, and representing today and having that vantage point today, being a representative of the government, could you share some of these reforms which have been introduced by the Ministry of Health, but also reflect upon some of the critical steps that can be taken to enhance the quality and standardization of the nursing education and practice in the country, given the evolving nature of the health needs in the country?
Well, in the onset, I would like to thank NNF and PHFI for giving us this opportunity at this very important forum to talk about a very pertinent issue. And I'd like to thank Shivangni for asking such a small question. It'll take, it has a lot of volume in it. Now, as you're aware, the government is very committed to invest in nursing, and they understand the importance of how nursing plays a very pivotal role in the healthcare delivery system. And as mentioned before, that we comprise of more than 50% of the healthcare workforce. So it is very important to invest in nursing, which the government of India has a lot of commitment towards that. Recent reforms, which we all know have happened, are coming up of NNMC, the National Nursing and Midwifery Commission, which is a central regulatory body which is helping in in streamlining the accreditation, the regulation, the curriculum development, and licensing of the nursing education. Another important reform which has happened in nursing is the INC has rolled out in 2021 a competency-based curriculum, which is based on the skill component is highlighted in it, and in that we are able to produce nurses who are clinically competent, who are having the necessary requisite skills which are required for them to be taking up their emerging roles as nurses once they graduate, and which is rolling now. Then the government, understanding the importance of nursing in cabinet declaration had in 2023, declared of 157 nursing colleges to be co-located with medical colleges, so that we are able to provide equitable, affordable, quality care, quality nursing education to our students. We also have now Center of Excellence, who are like more than 30 Center of Excellence we have in our country, and the reason why we have these Center of Excellence is that we are able to provide clinical skills which are required, and the infrastructure of these Center of Excellence is very well laid. So we are expecting, and the Center of Excellence are delivering the quality of nursing education in the respective Center of Excellence. Then we have also launched some like mandating of continuing education credit hours. That means the nurses, once they graduate and once they have a license, they have to have mandatory credit hours for renewing their license. So that kind of is a mandate saying that ongoing education is very important, because once we are dealing with human lives, nothing is more precious than human lives, and ongoing learning should not be just, it should be mandatory and it should be a moral imperative. Apart from that, we are expanding our training of trainers program for building a nationwide strong network of master trainers. And we also now, after the students graduate, we have a NORCET exam. Mandating or institutionalizing of NORCET exam is we have a common entrance exam for most of the all AIIMS and our central government hospitals. This is a merit-based exam in which we take our new recruits as nurses. Then we also enhancing the labs so that the students are having their job ready, and before they go to the real life situation, they are able to have those necessary skills in a simulated environment. Then, as Dr. Lata was saying, endorsing that again, that we are strengthening the faculty development, because if the faculty is competent and robust, quality audit systems can be in place, and only once the faculty is competent enough, we can expect that to percolate to the students. Then again, as mentioned by Dr. Dhillon, fostering the public-private partnership also leverages expertise in technology in nursing education, and aligning nursing education, another important component, is with the national skill qualifications framework to promote outcome-based learning. So these are some of the initiatives and some of the support which has been given by the Government of India in understanding that how important it is to invest in nursing education. Not only so, here we understanding that the quality is a norm, it is central and pivotal, it is not optional, understanding that the government has taken these initiatives.
Thank you, Dr. Kaka. Thank you for the insights, and we know the reforms that are happening in the country. I know that INC is also very closely working with the government on all of those reforms. Colonel Kaur, my question to you is, could you elaborate on the extent of the reforms that INC is contributing to, and also highlight some of the critical gaps that exist currently when it comes to competencies of the expected nurses and the trained workforce which we have right now in the system?
Thank you. Thank you so much, Shivangni, for that question. I thank PHFI and NNF for this opportunity to be here in this hall. Some of the reforms Ma'am Kaka has already touched upon, so I'll not go through that. But one of the biggest challenges that is there in India regarding nursing is the huge numbers. We've all heard the numbers since morning. So we are having, vis-a-vis the 730 plus medical colleges, we have around 5,000 nursing institutions in the country. And we are having around 1.3 BSc nurses, 1.3 lakh BSc nurses, 1.2 lakh GNM students, like almost 2.5 lakh That is the capacity per year that is being, passed out. And with this huge numbers, to maintain quality is a challenge in front of this regulatory body. But what we are trying to do is to have more transparency. We have made this entire process digitalized online mode, try to have more transparencies in the ways of giving the recognitions or the suitabilities, as we call it. Also, now we are absolutely paper-free, 100% online. We have also tried to reach out to the student community by having online portals like the online verifications, wherein we can rectify their issues. That is another one very important thing that has happened. For the institutions that wish to change from a diploma program into a degree program, we have allowed voluntary upgradations with some relaxations, keeping the quality indicators definitely in mind. We advocate that at least there should be a ratio of 1:3. That is, every student should have at least 3 beds. And now the parent hospital has been made mandatory since 2013. Because the clinical facilities are in a dearth in the country, we are now placing more emphasis on simulation. So we are emphasizing at least 5 simulation labs per institution where the nursing students will get adequate exposures. Ma'am has already mentioned the revised BSc Nursing syllabus that has taken place since 2021. We have also incorporated the competencies required for community health officers into the basic BSc Nursing syllabus, so that the BSc nurses, when they pass out, they are absolutely ready, they are competent to take over their role in the public health as community health officers. A lot of new specialized programs have been launched by INC under the Chintan Shivar mandate of the Ministry of Health. So 10 new nurse practitioner programs to improve the competency in the clinical areas has been introduced. Traditionally, the master's students used to move to colleges to teach, to take up the role as lecturers. But for this nurse practitioner programs, they are going to take the senior positions within the clinical areas. Like the nurse practitioner critical care will be an ICU in charge nurse. Similarly, we have looked into nurse practitioner trauma and emergency, nephrology, anesthesia. There's also a component of family nursing that's just been introduced. So we'll be taking the sensitization sessions for the states very soon on how to roll out these specialized roles for the nurses. We are also going in for Doctorate of Nursing Practice. It's a pilot project with the University of Houston, now just introduced in Maharashtra. So once it takes off and we are able to analyze the results, this can be rolled out as the highest level of clinical expertise in the clinical areas for the nurses. All our post-basic diploma programs, we are making it into an earn and learn model so that the nurses do not have to take a structured leave for this, but they can do it at the bedside itself. We also have given a lot of emphasis to leadership programs in our country, because that's one of the component of the State of World Nursing report also, that nurses should step up to take up leadership positions and to work for various issues that plague us instead of always being on the complaining mode. So we have introduced with ICN the Leadership for Change program. We have now a cohort of 42 nurse trainers who will be able to, roll it out in the different states. So this is just to give a small summary of so many changes that are happening in the nursing field right now. Thank you.
Thank you, Colonel Gaur. I know that we can keep on talking about the several reforms that the government and the regulators have introduced. But now I'll jump into Dr. Ravindran, and I know that CMC has long set a benchmark on nursing education by combining the academic rigor with the clinical practice. My question is could you share some of the insights of the CMC model of how do you do it, and then the approach of improving and making more competent workforce, and especially the nurses, focusing on nurses. Also, can you give within PEP and also down the line, how are you kind of expanding your work, and how are you going to support some of the newer institutions that the government is already setting up, or reaching to the more low resource setting institutions across India? Thank you.
Okay, thank you, Shivangani, for that question. And thank you, PEP and NNF partners, for this opportunity. Talking about CMC model, I just would like to start with the importance that we give not only to the academic part of it or the classroom part of it, but also putting everything or taking the students to the clinicals and making sure that the training and the practice happens at the bedside also. And the simulation labs and their efforts and the mandatory simulation practices have really helped us to prepare our students to go to the clinical area and practice. So the simulation is an augmentation of the clinical practice, and students' feedback in the past 2 years after their simulation practices have really given us the input of and the effect of simulation in making sure that their clinical practice is effectively done. And one of the importance that CMC gives and CMC mandates is implementing the curriculum as suggested by the statutory bodies. There is no way that we can go back or go less on the expectations of the statutory bodies. You know, even sometimes in our meetings, we just discuss on how can we do this? How can we make our BSc students complete this competence? Can we modify? When questions such as that comes up, the faculty always will go back and say, no ma'am, this is what is given in INC book, this is what is given in the log book, and this is what we need to do, and we have to post them in these areas. So that a mandate and an expectation, not only from the leadership position, but from every faculty is one thing that makes the education a success, I feel. The other thing that has been practiced for a very long time and we talk about a lot is the blending of education and service as far as nursing is concerned. We call it the integration model, where the faculty also are in the clinical area and they are in charge of specific clinical areas, and we hold another role in the clinical side. We have the primary academic responsibility, and we have the role as professor or associate and assistant, but we also have a nurse manager role on the clinical side. The number of hours that we spend in the clinical area varies based on the extra or additional responsibilities that we have either in the college or in the nursing services area. Actually, very simply put, I've been sharing this to all our visiting people, that the faculty actually run the nursing services as nurse managers. So it is an additional responsibility, but it really brings such rich, updated clinical knowledge into the classroom. And when students go to the clinical area, they see most of the teachers who are teaching in their clinical area also participating in patient care issues. And that has been a big success. And another thing, I was so happy to participate in the previous session because so many things that I had written down were shared. One of the important things is role modeling, mentoring. And we as teachers and faculty can be only mentors if we are experts in our clinical area. I've been working in pediatric surgical ward, then I have to know and I have to be an expert pediatric surgical nurse to teach pediatrics in my area. And because I go to the area, I know what is updated information, so I bring that, and so bring that to the clinical classroom as well. This role modeling and this integration has been a very successful model in CMC to make sure that our students get quality education. So I know that there are different models of integration that we can think of. Maybe later I will share that if there is time. one more point that I would like to say as success is the value-based education that we hold on to in CMC Vellore. The competencies is expected, yes, but the values such as the ones that we talked about in the previous sessions are very, very much emphasized in all the classes and all the time. Going back to the historical roots of nursing, how it developed, reminding our nursing students all the time of how humane-based care was what motivated nursing profession to be initiated. That reminder, frequent reminders are mandatorily done for our nursing students. And the values, our core values, we have core values which we have to inculcate and teach our students and role model it. We have to make sure integrity, commitment, shared decision making that we talked about, and leadership, but we talk a lot about servant leadership. How can you be leader and be a servant leader? And faith and what your beliefs, those values are very often included in the classes and in the practices, which makes the education value-based. Another highlight that I would like to say is the evaluation that we talk about in everything. Teachers and students continuously get evaluated and feedback on their performance. We call it the 360-degree evaluation, which is often done. One of the things that we keep doing to be experts and to role model and be excellent in, as a faculty, excellent in clinical practice also, is updating ourselves periodically. One example that I can give after partnering with PEP is the way that we teach has changed a lot. In the phase 1, we learnt a lot about online blended learning methods. Our faculty were trained in online blended learning methods. We learned to create modules based on what we learned, and we have rolled out modules for our community health nurses, and we have introduced online blended learning modules for our own students. So every time when something new happens, making sure that the faculty become expert and they develop expertise in any innovation is something that we are always looking at. And the organization, our institution also facilitates such improvement in our practice. For the nurse practitioner course in critical care, we want to start. We have MSc nurses, we have master's prepared nurses who have done critical care as specialty, but that is not enough was what we thought. So we have had higher education or better opportunity was given to some of the faculty to make sure that they are competent enough to teach the students if we come in. So these are some of the things that we have put in, which helps us to be holistic in looking at education. How do we help others? What is it that we are going to do? I just would like to say already we have certain practices in place. One of the things that the institution encourages is to give something called as mission sabbatical, a leave that is given to go and help others. The other thing is...
Dr. Ravindran, if you can keep it short because we
okay.
are running short of time,
Sure.
so sorry.
Other thing that we have now planned, especially with the NNF partners, is identifying spokes, we acting as hub, identifying institutions as spokes, and see once we are expert as faculty in CMD, like Dr. Lata mentioned, whether we can do that in the way of cascade model and teach the others so that they can teach multiple people. So that's another effort that we can put in.
Thank you.
Thank you.
Thank you for sharing the insights. And as you alluded to, that the quality of education actually is very much integrated with the clinical exposure that we are giving our, not only the students, but also the faculty, because it's really important how our faculty are bringing those practices into the education from time to time. And moving on to more at a health systems level, a strong workforce, of course, always needs backed up by evidence and data. And I know that World Bank has recently done a labor market analysis. And Lakshmi, if you can give insights on what were the findings of those labor market analysis when it comes to nursing, and how those have informed the recent reforms in some of the states in the country.
Thank you so much, Shivangni. I think one is definitely the health labor market analysis that we have done. I think along with that, we also at the World Bank had the opportunity of doing a demand side study also with nursing students, current aspiring and passed out in the states of Tamil Nadu and Assam. And also, I think in last definitely 8 to 10 years in India, we have been fortunate to have very deep state level investments in the area of nursing, especially to strengthen pre-service education. I think I'll quickly try and say a few things with a combination of some of these things. I think, Ibadat and others have put up the fact that, the numbers are really doubling, and there is that is what was needed. I mean, just like our facilities are increasing, the numbers are also increasing for the workforce. So what it then takes us to is the entire fact of the quality of these numbers, also the skill mix of these numbers. I think that is what we are really alluding. Our health labor market analysis strongly talks about improving qualities, cadre mix, task shifting, and also beyond doctors, bringing nurses to the forefront, bringing allied professionals to the forefront, and make it a more team-based approach. And that is what the numbers will then actually make the real difference to. I think I think even before we dwelled about the entire point of bringing an health labor market lens to the entire conversation, it's also something that at the World Bank we have been strongly advocating for. I think for long we have been the production, the education does not talk to the in-service part of it. And I think bringing both the pre-service, the in-service and the middle, I think having that more health labor market approach to the entire conversation is itself a first grade learning for us, and that I think we strongly advocate for. Or amongst this, we also talk about entire quality. I think more and more we're coming back to it, that how do we make both QA and QI a continuous and integrated process, but not a one-off event. I think that is where I know that the central government, the regulators are working a lot at it, but how do the states and at an institutional level, how do we further institutionalize this is a conversation, but strongly quality of training and practice is coming out strongly even in our labor market analysis. I think compensation policies have come out very strongly from the labor market. And when we say compensation policies, we are not talking just about higher wages, but appropriate wages, everyone having parity amongst payment, they're having more career progression opportunities, more cadres being created, a larger conversation. I think the health labor market strongly is throwing up that part of it. And then we see that often we have seen, and maybe many of us have also done, we talk about nursing in isolation. I think one of the larger conversations from our side is also to integrate nursing into the larger HRH conversation, right? I mean, most of the health HRH conversations, doctors somehow take the precedence and a lot happens there, but how do we bring nurses and the entire nursing conversation from a larger HRH landscape and other allied forces also into that conversation, and then positioning the reform agenda, I think makes a huge difference. Also, what we see from our analysis is that there is a complete mismatch in what the financial investments and policies are versus what the actual policy intervention is required. I think there has to be some alignment because there is a lot that already is known. I don't think we need to highlight what is the areas that need to be highlighted, but corresponding investment and prioritization is somehow not happening, especially at state level, health being a state subject. I think we would like to push for a lot of that to come through evidence-based approach, like doing HLMA evidence or other kind of studies, bringing that to the policymakers and pulling investments in that direction. I think bringing to that entire talk of from our demand side perspective, what we also see is when we asked, very interestingly, when we went to look at students, especially from the nursing context, nursing as an aspirational career has seen a huge change in the last decade. One of our WHO team, they also talked about the entire art and science of it. But what we saw in our study was also the fact that more and more art students who still aspire to be a nurse versus science students still looking at nursing as a second option and not a frontal option. So we are talking about quality right at that stage of your grade 11, 12 students aspiring to be nurses, and how do we actually make a dent at that thought process at that level, but not trying, but whereas lot of our investment is trying to solve for quality in service. And we're forgetting that entire path before and constantly pumping investments there. So I think fixing right from grade 11 and 12 who want to become a nurse, why should they become, promoting nursing as not just a noble profession, but a profession which has strong career and strong pathways and has potential migrations and everything. I think from that point, bringing that entire landscape together and investing at quality at grade 11 and 12 will only maybe a decade later or show that effect there. I think with some of these thoughts, I know we are on time, so I will not repeat but I will leave everyone with some of these thoughts. Yeah,
Thanks, Lakshmi. And I'll the last but the best one, I think, Dr. Hilde, you have been working a lot in the UHC space, and as India is undertaking so many major reforms when it comes to nursing, what lessons we can draw from India and also for the region, for the global level, but also from your experience, how it contributes in achieving UHC and building a resilient health system, because ultimately we know that nursing are at the forefront and how they are contributing is definitely impacting how we achieve UHC at a larger context.
Absolutely, and thank you. It's such a pleasure to be on a panel in a World Health Conference that is focusing entirely on nurses. Yes, I think so. That requires an applause. And I've been in India now for 8 years. It's also my first time to sit on a panel with only women, which is also, thank you. And when I look at this audience, it's a very diverse audience, so I will ask the question, who are the nurses in this audience? Can you please raise your hand? Okay, you are there, so we are not just talking about you, but to you, because this is your session. But it shouldn't be, like Lakshmi said as well, it shouldn't be in your own little silo. You need this entire audience to support your agenda. Now, the speakers before me, they have already set the tone. A lot is happening in the nursing profession, and it's an absolute joy to listen to that. You know, everyone is pushing that barrier to do more. So what I will do is just take a step back and further clarify how these developments connect back to bigger goals and bigger targets. And of course, then we start with the SDGs. India is one of many countries that has set targets to reach the Sustainable Development Goals. We are focusing on health. There is 5 more years to go. very little time left. We know progress is being made, but we also know a lot more needs to be done. Central to the health SDGs is universal health coverage, which basically means that there shouldn't be anyone anymore who does not have access to essential health services for whatever reason. That is really the bigger picture that should drive all of us. And you can only achieve UHC when you invest and strengthen your health system. And you do not have a health system without a workforce, and you do not have a workforce without the nursing. Now, the government of India is very committed to accelerating progress to SDGs and health SDGs. So a lot of initiatives have started, at least from the time that I have been here. It really has been one after the other in different domains. And it is about increasing access to healthcare for everyone, and comprehensive primary healthcare. It is about eliminating all diseases, TB, malaria, lymphatic filariasis. Very ambitious targets have been set. It is about dealing with that rapidly exploding crisis of chronic diseases, non-communicable diseases due to lifestyle changes, risk factors that are really affecting India from north to south. No one escapes that epidemic that is really with us. It is also taking measures to make sure that financial burden will not prevent someone to seek health care, right? And it is also making efforts to increase the resources that are available for improving health outcomes, whether it is financial, human resources, bringing in new technologies. So, how does that now connect with what is happening in the different institutions? Nurses do play a key role. I think I don't need to argue for that case. But what the government has done with the ambitious plans that they have of improving access is increasing access to essential healthcare services. You're all familiar with Ayushman Bharat program, health and wellness centers. That is really at the core of primary healthcare, bringing health services closer to people. It is your main agenda within universal health coverage and achieving health SDGs. To reach that objective, a new cadre has been not developed, has been formed to really function at that level, close to the community, making a bridge between what's happening with individuals and their communities and the healthcare that they need, essential healthcare services. But not only staying at that primary level, but making sure that connections are made with higher up levels, referral systems, continuum of care. So nurses are that first point of entry within that formal healthcare system. Focusing on education, when you need more nurses, you introduce more programs, you need to train more. Again, what we have seen in India is a lot more new training institutions, nursing colleges have been set up. But it's not just about the numbers. Nurses need to be fit for purpose. It's the topic of this panel. It's how you train your nurses that is getting a lot more attention now. It is introducing competency-based training programs. It is introducing modern teaching aids. It is clinical mentorship models that are being tested out. The bottom line is, if you want to serve the community of today, your focus needs to be people-centered, needs to be holistic. You need to bring empathy at the forefront of whatever you're doing, right? Nurses need to have cultural and social competencies. So it's a big shift from the knowledge and theory transfer. This is happening, and it's really fitting that global target. And it's also not only how you train them, but then how are you expanding that range, the scope of work that they are doing? It's from primary care, specialized nursing care, but also entering into the public health sphere. Nurses have been absent, but they have a particular role to play there as well. So, and one major step forward, because all these changes need a legal and administrative framework for you to function and work differently. And since 2023, the National Nursing and Midwifery Commission Bill is opening so many opportunities for everything you're trying to do. It has taken more time. We would have loved to see that right at the beginning of the reforms. But the bill is there, and now you have a framework that really allows you to push your agenda even further. And then lastly, with all the other reforms that are happening, the government is also making commitment, but also with the nursing sector, to focus on leadership. Nurses need to be part of that policy dialogue, improving working conditions. It is a female-dominated workforce. So creating job opportunities for women, but also making sure that they can stay in the job and that they can have career opportunities. It's not only important for women, but it's really contributing to one of the very important SDGs, gender equality. So in brief, I just want to summarize. India, the vast country that it is, a lot is happening. The nurses are very much part of these developments. We do know that there is still a challenge with the policy implementation gap and the bridge that needs to be crossed. So this is actually an invitation to all nurses and all those who work with nurses. You have such a critical role to play, and all of them should become their own advocates for change. Change that is not about one profession, but really making sure that healthcare is approached as a healthcare team, right? And that the people you serve, the patients you see, you help them to become partners in their own care process. And that we cannot do without the nurses as well. Thank you.
Thank you, Dr. Hilde. And I think you have beautifully summarized everything. You have captured the patient-centeredness, the need for quality, looking at policy dialogues and how important nurses are on those dialogues. And because we are short of time and we have been rushed by the WH's closing ceremony, so I would like to call upon Mette to actually go through a little bit about PEP. And then it was really lovely to have you all, but we should continue the dialogue on how to make it more collaborative and a more concrete program altogether, and how different partners that are working also in the space, in the room, who are there, can contribute to something what the government needs. Thank you so much. Thank you, Mette.
Yeah, thanks a lot, Shivangini, and let me also take this opportunity to thank Professor Sotpe and PHFI for co-hosting this session. Thank you to Dr. Idabat and also IT Misu from WHO for your interventions, and a great thanks to our panel. It has been such an inspirational panel talk, and I have to try to summarize in a bit, but I think it was so rich, and I hope all of you enjoyed it and took notes, because I think I really enjoyed this panel. So yeah, maybe I think we should give them a hand. So, actually I would also like to take this opportunity to thank the World Health Summit Organizing Committee for organizing this event. It's the first time that the Novo Nordisk Foundation is actually present and a partner to this. And with that, just referring back to the title of this summit, Scaling Access to Ensure Health Equity. It's the perfect, it's always important, but I think timing of this and also relating our discussions here today to that. Because actually making the health workforce ready to also ensuring health equity. This is really key, and nurses play such a key role in this. And so actually, thanks to the organizing committee, and what a brilliant topic to choose. So. So just a few sort of overall comments. I think all of these topics were touched upon today by our keynote speakers and also by the panel. India is doing very well when it comes to increasing the overall production of nurses in the country. However, today we also really talked about quality of education, also leading to a high quality of nurses' competences. And then I think it was mentioned right at the beginning of the session, where are these nurses placed? How do we reach the underserved areas? How do we make sure that quality services are also available to vulnerable populations? So thanks also for attending to that in the panel discussion. This prioritization of continued nursing education and also then I think was mentioned in the panel, the need for working interdisciplinary. So we are focusing on nurses today, but I think the importance of working with doctors, working with other health professionals, and working as teams were also highlighted. So thanks again. Luckily, Dr. Latta already mentioned PEP, and why we are actually, one of the reasons why we are here. So I will not spend too much time on that. A partnership for education of health professionals, as was already mentioned, the vision is to reach people living in vulnerable positions in India and East Africa, and we have a focus on education of health professionals and a specific emphasis on pre-service education and increasing institutional capacity. So not bringing any strange ideas from Denmark or a ready-made model or parallel system, but working with Indian institutions. And I think what was also highlighted by you, Hilde, and which is actually also part of the mission, is empowering women in their profession. So that's also why gender mainstreaming constitutes a very important part of the program. And also, Dr. Vinita was already sharing about the hubs and spokes model we use, and I think this is key. We are so lucky to work with great partners in India, and I'm so happy to see both AIMS, PHFI, CMC, Vellore represented in this room, and also, of course, World Bank, you're also a partner, and WHO, I hope you will be a partner very soon. However, this is about your institutions, but it is also about how you reach other institutions. Now we have just brought the Regional College of Nursing in Assam on board. I hope many more will be partners of PEP, because this is really what is needed to reach the vulnerable population groups. So again, I think I have to rush a bit. Anyway, I was already referring to this. Of course, partnership for education of health professionals is about education, but it is also about what we're doing today. It is about convening people, and I think actually this panel and this event marks a milestone, and even what PEP is about. It's about bringing organizations together. It's about bringing professions together to have an impact, and hopefully a positive one. We are also trying to create a more international networks and knowledge sharing. I think it was already mentioned that Kenya and other East African countries are also partners of PEP, actually education institutions of these countries, and that we also have international partners and of course also a few Danish partners. Actually this slide, maybe that was what I should have put when I mentioned it. These are our Indian partners, our East African partners, and Danish partners. And then allow me just to announce, I know I did this yesterday, but I think actually it needs another round of applause also in this audience. We just had 3 new centers of excellence, project supporting centers of excellence in India approved by our board of directors. Please give them a hand. So this is basically who is represented in this room, PHFI, AIMS and CMC. Now with we are very proud to be able to, that you have accepted our support to further develop your institutions to constitute through centers of excellences also when it comes to education of nurses and other healthcare professionals. Thanks for being our partners, and we are very much looking forward to see the results of this. This slide was already shown, so I think actually now I'm at the final slide, but I think we have a short video to show. So yeah. Yes, and that's the... I have to do something?
Cardiometabolic diseases are increasing in prevalence, and also it requires a comprehensive management. I think it is crucial to acquire the skills and knowledge in cardiometabolic diseases, as we are the flag bearers and advocate for the patient.
Our hope is to have better equipped, better trained, better educated healthcare workers who can have access to evidence-based management strategies, so they could translate knowledge into practice better, whether by screening for cardiometabolic diseases, managing them better non-pharmacologically.
In the PEP project, actually, we have been able to bring together medical, nursing, allied health faculty and look at ways in which we can actually cross-learn.
There have been investments that have been made to help us, our teachers and faculty members, to develop robust methods to transfer some of these competencies. And at the same time, it has provided us support in bringing in on board some newer material to support recording and blended learning formats within our educational programs.
PEP program can really help the nurses, wherein they can gain what are the current practices. It will help them to advance their knowledge, and it will also be helpful for them to get themselves involved with a group of experts, wherein they can contribute their expertise in developing policies for our own country.
We have identified areas where there's need for continuing nursing education, and one of the major area that we have identified is the cardiometabolic diseases.
Much of the care which is dispensed by the doctor can be handled by nurse educators and other multi-purpose health workers.
Investing in women and their education is a short way of ensuring future success. Within PEP, what it has helped us individually, even within our own organization, is to move us along the spectrum from being just gender aware towards being gender transformative.
We've met partners not only in Copenhagen but here in India. So that has been a really good part of PEP. Meeting others, making colleagues and friends who are interested in the same area, and I hope that that is something that can really grow, and finally we have a community of people who are all invested in this idea of helping train health professionals.
People must be taken care so much, and being a nurse, it is important to teach them whatever learned regarding the disease and regarding the prevention of the disease. That is my responsibility to teach them and put my part in helping them to overcome or prevent these diseases.
Thank you very much. I would once again like to acknowledge your gracious presence for this session. We've had wonderful discussions, great keynotes and opening remarks, as well as a fantastic panel, which has really enlightened us. Now, to cut it very short, let me take the opportunity to please invite Mete, Professor Zodpe. Mete, starting with you, if you could please do the honors and present a simple token of appreciation for our panelists, Dr. Kaka and Dr. Kaur. Can I request Professor Zodpe to honor Professor Ravindran? Lakshmi. Hilda. Mette, can I request you also to acknowledge I? Mette, can you also be here to honor Dr. Lata as well? She's just seated next to you. Thank you. May I please request the speakers, panelists, Professor Zotpe, Mette, and the team to be here at the dais while we take your photographs, please. Thank you. Amrita, Shivangini, Riddhi.
Thank you so much. Thank you.
Thank you very much. Namaste. Thank you.
Thank you, everyone. Thank you.
Hello everyone. We have a panel discussion on women-led development for health equity starting at 5 p.m. If you all are interested, please stay back.
Hello? That I told them already. Here not me.
आ रही गिलास आ रही है
Hi, good evening, everyone. So thank you very much, first of all, coming in, to the fag end of the day, and that to a Sunday and the last session of the WHS. And thank you very much for attending. And we have a very interesting set of esteemed chair and moderator and speakers for today. So without further ado, we'll just start with the today's proceeding. So we have a very interesting session today on women-led development for healthy equity, a multi-stakeholder dialogue. So it will be an interesting deliberation for today. So as I said, we have a esteemed list of speakers today. First of all, I would like to take this opportunity to invite Dr. Joya Ali Rizvi to the stage, please. She is the chair for today. And thanks, ma'am, for making time, and thanks to the Ministry of Health and Family Welfare for deputing her for this role. Dr. Joya is a public health leader with over 2 decades of experience across district, state, and national levels in Indian government health sector. She is currently serving as the Deputy Commissioner in the Ministry of Health and Family Welfare for Adolescent and Nutrition. She leads the Rashtriya Kishore Swasthya Karyakram also, focusing on the promotive and preventive healthcare for adolescents in facilities, schools and communities. So thank you very much, Dr. Joya, for making time. Welcome to the panel. Next up, we have our moderator for today's session, Ms. Priya Nanda. Welcome to the stage, please. Priya is a global health research and evaluation specialist whose work focuses on gender, intersectionalities, right-based approaches with complex health systems. Her expertise lies in addressing structural inequalities and advancing gender equity in health. Previous to this role, she has served as also senior program manager and leadership position in Bill and Melinda Gates Foundation, and previously as a portfolio director at International Center for Research on Women. So thank you, Priya, for today's session. I'll hand over from here to Priya to invite the rest of the speakers and also introduce them. Thank you very much.
Good evening, everybody. All right. Are we good? Yes. Okay. So thanks for attending this interesting session. It's Sunday evening, 5 o'clock, but most of you who are here are motivated, I think, because either the speakers or the topic or both. So thank you for that. I think this session is really important because for a while now, in the last couple of years, or maybe even the last 5 years, we're hearing a lot about women's leadership. We're hearing about equal representation. We're hearing about parity. We are hearing that women's leadership is important. Women need a seat on the table. We need the 50-50 gap to be filled. But really, this session is about what about women's leadership? What is so unique about women's leadership? And it's not because we don't believe that's important, but we want to be able to articulate it from the perspective of the different work that organizations are doing. And it's really both about women-led models, where women themselves at the helm of leadership in their organizations and are leading models. It's about building women's leaderships in the communities that you work in. And it's also about larger ethos of organizations that may be working with vulnerable and marginal groups, but what is their perspective around leadership and representation and equity? So I think it's all of these things. The idea is to not represent this idea of women's leadership in a very linear way, but to really complicate it a little bit and then reinterrogate our own positionality and thinking, and then offer back to us a better or a stronger conceptualization, perhaps, around women's leadership. So I think that's really what we would hope to get out of this, and we are going to leave some time for Q&A in the end, so we do want your participation, so stay till the end. With that, I'm going to introduce the panel. I'm going to be brief. Firstly, my name is Priya Nanda, not Nandi, although I love the Nandi bull. I am a PhD, so I can be considered as Dr. Priya Nanda, and I only say that in this setting because people are very careful about titles and degrees. So with that, but I am not going to be introducing everybody with their accomplishments because the panel is very accomplished and you can really look them up. I have Nayana Chaudhary. She's the CEO of Breakthrough Trust. Congratulations, Nayana, and welcome. Naina has been with Breakthrough as Director of Programs since 2018. She's led some of the very important work that Breakthrough has done on adolescents. And she has also worked with Tata Trust and IKEA Foundation. We have Priya Agarwal. So like I said, I'm not doing any doctors. If you are, good for you. Priya, Priya Agarwal is the founder and director of Antarang Foundation and an Ashoka Fellow with over 30 years of experience spanning advertising, market research, and development sector. She's held leadership roles at the Acupuncture Foundation and Sneha and has advised organizations like the Angan Trust. She'll talk a little bit more about Antarang. We have Aparna Hegde. She's a Stanford and Cleveland Clinic trained urogynecologist and the founder of Arman, and a non-profit mobile technology firm to provide maternal and child health across 28 states of India. Arman also implements two of the largest M-health programs of the country, of the world actually, it seems, Kilkari and Mobile Academy. So welcome, Aparna. We have V. Samprasad. So he's the country director of AIDS Healthcare Foundation India Cares and a seasoned public health professional with decades of experience working with people living with HIV/AIDS. And under his leadership, AHF has launched some really interesting programs, the first ever national free condom store and an innovative Moonlight HIV testing initiative for high-risk groups. And there's much more. You can read up more about his work. And then lastly, sorry, my notes. So we have Jaya Padma, welcome. And you work with at the intersection of gender justice and social development, engaging closely with grassroots leaders and organizations to advance a more just and equitable society, with a strong interest in fostering ecosystems for resource justice and supporting communities in building climate resilience. You currently lead programs and partnerships at the South Asia Women's Fund, India. So very diverse panel, and welcome everybody. So to get started. Yes. Okay, before I sit down, I think what we have asked the panelists to do, and then Zoya, you can participate in any of the rounds that you wish to, or in the end with your thoughts. But we did share a few questions, and basically, we're going to start with the first question. We are asking each of you to reflect for 5 to 7 minutes in the first round and maybe 5 minutes in the second round. And you can broadly interpret it the way you wish to in terms of how you want to engage with this topic. But our question to you initially was, what about women's leadership? What's so unique about it? And how does women's leadership contribute to transforming systems to achieve health equity? And the systems could be health, governance, or advocacy, or anything that is kind of within the socio-economic determinant of health. And how can women's leadership and agency be effectively harnessed to address health equity? And also if you can talk about challenges and complexities. So we'll start. Okay, sure, Jacob.
All the health experts. Hardly.
We're going to start this way, the next round we're going to go.
Yeah.
Thank you, that's it. Yeah.
Okay, it's delightful to see a full house. I was texting Naina just before we came into this session that our session clashes with, the valedictory and all of that. She's like, oh, there'll be an empty room. I said, yeah, we'll have fun having our conversation, but it's so good having so many listening in, so good having so many men in the room also, keen to listen about, how women have been leading development See, I read the kind of work that we do. I am reminded every day about Article 21. That's where I start with every day. A right to life with dignity. And health is nothing if you do not have Article 21 in place, right? And if you have to have Article 21 in place, you have to have right to education, you have to have right to health, you have to have right to justice, equal opportunity, right to livelihood, all of that. So all of these core determinants are kind of playing together to ensure a healthy, purposeful life that all of us intend to lead and can lead. And if you look at WHO, that's exactly what they are saying when they are defining health, that health is not just the absence of illness, it is the ability to lead a physically, mentally, socially, the parameters of well-being, that plays out in all of that. And yet, India sits somewhere in happy hundreds when it comes to the Global Gender Gap Index. On the World Health Index also, we are somewhere around 86 out of 195 countries. We've done well. I'm saying in 75 years, there's a lot that a journey that we've traversed is quite dramatic, and yet a lot that needs to be done. There's a long way that still needs to be covered. We have fantastic work that's happened on the ground in terms of getting women into various spaces where they can live their full potential, really realize Article 21 on a daily basis, and yet we are all aware of all that's holding them back. So the kind of work my organization does is to create ecosystems of justice. So it's not just justice, it's not just systems change, it's really how do you craft these ecosystems where women in their everyday lives can be equal participants, right? So whether it is in their homes, whether it is in the communities that they are in, and whether it is in larger contexts also. So a brief into some of the work, some of the initiatives that we are part of is to support really proximate leadership, women leaders, and when I say women, it's this whole gamut of feminist thought where everybody who's denied opportunity to come to the seat really finds opportunity and space to claim resources, to make their voice heard, right? So we are supporting organizations, individuals at that who are denied that space to kind of find their own pathways, and that's about what we do. As a funder, we provide some resourcing, but together with that, we also enable a lot of connections so that that ecosystem can be galvanized. And I'll give you some examples of how we do it. We work at the intersection of economic justice and economic resilience and access to justice. So here again, there's no formula that we are placing. We're just saying, find your own pathways. So we have Varli, the tribe in Maharashtra. So they've kind of gone back to their cultures and they figured that widowed women in our culture had actually a very important role in the society. So they've crafted a new way where they've got this system called the Dhavleri, where women are priests officiating ceremonies, right? So they've now revived some of these cultural practices whereby widowed women who were sidelined, and that's one category of women who you will not find in the mainframe anywhere. So these women are suddenly finding purpose in their lives. Marriages are becoming simpler and not the Bollywood style. So there's a whole savings that's happening in parallel. But these women are suddenly claiming their space in society. So there is a sort of a cultural revival. Together with that, younger women are getting kind of involved in the whole process, again, through their own tribal cultures, rediscovering foods, practices, etc., which kind of contribute to their nutrition and all those aspects. They're kind of getting interested in and when it's food, they're also looking at how is our land being used, how are the forests being affected. So there is, of course, they're very interested in the metro project that's happening in the RA area. So they're questioning all of that. So there is this space that got created, and I'm deliberating on this example that this is just one instance, and in every instance that we are working with, the solution or the problem is crafted entirely by the local community. It's just, for us, it's not just writing out a check, but it's also creating that ecosystem where you find support where you can. We also run a very strong legal fellowship program where we are connecting women with women lawyers, both at the primary courts and at higher courts. We are creating environments where legal education happens for women, young girls, but also lawyers are sensitized and trained. So it's when you put all these pieces together that you start seeing some positive spirals of change coming about.
So I just want you to think about this and maybe address this. I think one of the things that you're saying is in creating, in your ethos, fundamentally you believe or you're observing that women are very redistributive in their approach. Yeah. And I want you to come back to this idea because I don't want to pit this against men but just to say...
The nurturing aspects, absolutely.
Yeah, so just if you can reflect on it further.
I will do that.
So, Aparna?
Yeah, so I'm going to talk about our context in the space of maternal child health. So I'm the founder of Arman, and we have tech-enabled solutions at scale to impact maternal child health in 28 states of the country. And I must tell you how we came to gender. I'm a clinician, right? And honestly, in medicine, gender doesn't play the role that it needs to play, even in the maternal child health space. So often, when I founded Arman, so what we do, I'll just give you one snapshot of one program. So when we created Arman, we had this program called M-Mitra, which is a voice-based survey. So what we do is we reach across to women with information through pregnancy and infancy, because lack of access to information is one of the biggest reasons for lack of access to care, right? I mean, if we're not informed, they're not going to access care. On the other hand, we train health workers at every level of the health system. The ASHAs, the ANMs, the medical officer specialists, to be able to give the kind of care required early enough, close a loop of care so that there are reduced, delayed, complicated, irrational referrals and reduction in maternal child mortality and morbidity, right? So that is our theory of change and how we do it clinically, right? But when we started the program, two things came into mind. I mean, and we really learned along the way, right? And how gender and developing leadership really leads to improvement in the programming, right? There are two aspects of gender I realized. One is gender within the organization, right? Because you might be dealing with mothers and children, but oftentimes within the organization, there is not enough gender transformative work at play to ensure that the programs actually achieve what they need to do. Secondly, also in the programs itself that we're going out to the women with, right? Are we actually gender transformative and how we, so this is a learning that we had over time. So I'm going to talk about the programs first, right? So, you know, when you talk about technology-enabled solutions, we had this one-size-fits-all, right? And when we talk about technology-enabled solution, talk about technology. You don't know what is actually conveyed to the technology. What is the content conveyed to the technology? Is it really reaching out to women in the way that it has to, right? So along the way, we realized this is that to really be gender transformative, what is even gender transformation? We need to understand that because we were actually creating gender-sensitive solutions. Right? So M-Mitra, when we first went across, we were sending voice-based services, right? Voice calls to women. So we were trying to tiptoe around her constraints. Okay, she didn't have a phone, we would give her a time slot choice so that she can ensure the husband's phone is with her. If she, we would have multiple tries for every message to ensure that she will get the information because she'll pick up at least one call. So we were being gender sensitive. But what we were doing was, we were not being equitable. We were not ensuring that the last mile of the last mile is reached in the sense that when you have a scheduled caste, scheduled tribe mother, if you're a Muslim mother, adolescent mother, migrant mother, your access to healthcare is severely limited because of gender intersectionality with all these equity parameters. And we had this one-size-fits-all, so we couldn't really go across to ensure that these subgroups did not suffer because of our programs. So we realized that we have to intentionally design for these subgroups. So our programs are actually going on to a fit-for-purpose approach, creating stratified programming so that we can actually develop lateral approaches to these subgroups so that we can really reach the last mile. And gender plays a really big role in this. Second bit is that we really became gender transformative. What we were doing is all our programs address the woman as if she's responsible end-to-end. So we send her information, say, okay, you do this, do that. But we didn't address the agency issue that she actually had. In the community, she didn't have the agency to actually put into place, put into work all the, information we were giving her. We were not involving the husbands at all. We were not involving the family members. We were making her feel guilty on top of giving information. Not only, tell her that, okay, if she's not able to achieve what we were hoping that she would achieve, she felt guilty at the end of it all. So we are actually now gender transformative. So we've gone on from a gender sensitive to gender transformative way. So what we're trying to do is develop leadership within the women, so ensure that she's informed in a manner that she can take charge of the situation and stand up to patriarchal dynamics, but also involve the husband. So normally in healthcare, what happens, the husband comes in only as a superman. Only when there's a problem, he will come in during emergency, but not be responsible day to day for the care of the mother and child. Pregnancy is the woman's concern, not the husband's concern. Right? So we are now completely gender transformative. We are ensuring that in our Kilkari program, so we have a whole program with the Government of India, which is in 27 states, where we send information, voice-based programming. Now it's going to go to multimedia, WhatsApp-based drama format content, but it's now the husband and wife together pregnant, husband equally responsible. They learn by introjection, right? So we have this family that we follow through. We have a male peer in the community involved, the male voice in realizing that they're equally responsible. And the woman's agency voice is equally important. And not that she's only informed, the husband also has to do all of these things. So we, being gender transformative. So similarly, when we approach the health workers, right, it is so important to understand the gender nuances that, that do not allow them to implement all that we are talking to them about, right? So the patriarchal norms within the community, the fact that she didn't have the agency to kind of rise up and speak to her subordinate, the seniors who are male, and actually ensure that she has the wherewithal to kind of stand up to what is not right happening in the community. So we're including a lot of gender workshops within in our programming with the health workers. We work with ASHAs, ANMs, medical officer specialists. At every level now, the content is nuanced to ensure that all of these patriarchal issues are addressed. Right? I'll give a small example, right? So we have a program called Swasth Kadam where we handhold mothers whose children are moderately underweight, right? So that we prevent progression of severe acute malnutrition. What we were realizing is that the women that we're reaching across could only speak to us in the evening times because of the fact that the husband's phone will be with them in the evening. And if we expect the women who are our health, counselors to reach out during the working hours, they won't be able to do that, right? But then if we give them flexible timings for their own work, that they can go back home in the evening, call these women because they can finish their daytime's work, and then you can ensure that both are matched, right? So we are looking into gender constraints of both the service provider and the women that we are serving, right? So similarly, the same thing we're doing with the ASHAs, ANMs, medical officers, gender transformative content now, right? That's where we are going. This is our work thing, right? So how are we including gender so that we develop leaders at every level? B was gender within the organization itself. We did a whole survey within the organization. We understood that though we have women leaders, so Arman, because it's a women and child organization, maternal child health, naturally we have a lot of women leaders in the organization. There are the whole field staff is female. But we were not really incorporating their voices within the programming, right? To understand how their feedback from the community can really help change our programming to ensure that we better serve the women on the ground and also serve the leadership within the organization. So we actually are now deliberately trying to put in, gender-sensitive norms for recruitment, for, pay scales, for...
Do you mind if we roll over some of those issues into the next
Yes. We will do that.
So
but
just finish this thought and then...
Yeah. So we are really working a lot on ensuring within the organization itself, we are looking at gender norms of all parameters of working itself, the management itself, and also ensuring that the gender-sensitive conversation. So when you talk about conversation within the organization itself, right? How leadership deals with the hierarchy, with the subordinates, how conversation happens within the organization, which can be considered discriminatory, right? Which can come in the way of leaders actually working well. We're looking into how to set right all of these systems. Yeah.
Thank you. And those are really important issues which I do want you to address later, because there's also this other construct around feminist leadership, right? Which is really how do you move organisms to be more really challenging the status quo and all the assumptions around patriarchy. So perhaps you can reflect that in the next round further. Over to you, Sam. And just for the next set of speakers, at around 7 minutes, I may interrupt you.
Yeah, I'll try to be short. But oh, okay, thank you so much. I think I should call myself the last man standing, or the last man sitting in a gender, a workshop. And I'm so happy that there are so many. The allyship is definitely visible with the our colleagues, the men who are around. So, but I also I'm very much aware of the panel that I'm sitting on. So I probably will take on what we do as AIDS Healthcare Foundation. AIDS Healthcare Foundation is a 47-country organization with around 35 years of our intervention. We are specifically an HIV organization with around 2.3 million people under care. All the services are free, and we are here in India for the last 15 years. So one of our focus populations, as everybody knows, in regards to HIV, is definitely the transgender population. So, and I don't think any of the community members are represented in this, in this August audience here. But again, I just wanted to, mention and, make visible Prince Manvendra Singh Gohil, the very first gay royal of India, who came out and then openly said, "I'm gay. I'm more a queen than a king," so that makes it a bold statement. And also, he has been a champion. He's been, thank you for your presence, Prince Manvendra Singh Gohil. If you may just stand up for a minute, please. Yeah, that is Prince Manvendra Singh Gohil, a global ambassador for MSM transgender activism across the world. But let me go to the points that I just wanted to kind of, talk on behalf of our trans women sisters, if I may call like that, and then say that, that India is leadership or transgender women-led India will definitely play a transformative role in health systems, governance, advocacy, especially in the context of equity and justice. However, this potential is definitely constrained, as usual, by socio-political, economic, and structural barriers. Let's break this down into the Indian context. I'm just trying to, kind of not educate anyone here, but then think together on the transformative role of transgender women leadership in India. With regards to the health system, that's the primary input area that one gets into. Is health interventions become more inclusive when it is trans-led? But then how many of that is happening in India? And then peer-led models, definitely community-based HIV testing or trans-led CBOs, community-based organizations, they have definitely proven effective in improving access and trust among the communities. We have been seeing that right from the phase 1 of the NACO program in the country. But then at that time, the transgender visibility was not as prominent as what we have right now. Stigma definitely is actively challenged. Trans leaders act as change agents, definitely as social change agents within the healthcare system. So especially training healthcare providers, as you rightly pointed out, the challenge that you realized when Arman came into being within the organization, as well as what the output that we are going to try to see in the general society. Then again, co-creating health communication strategies that will reflect lived experiences. So that is the most important. I think, I don't want to, talk about any gender in a gender panel about lived experience, but I don't want to do that because, we know what we are talking about. But then again, data becomes more inclusive when disaggregated data collection by gender identities happen. Essentially, definitely needed for policy response. So that way, the larger spectrum of trans communities gets represented. And then each of the issues come out, and then there is a possibility for policy response. With regards to the legal reforms, I'm glad that you are here, ma'am. And also, Indian trans leaders have been central to the landmark legal achievements. NALSA versus Union of India, 2014, Transgender Persons Protection of Rights Act in 19, but albeit with critique. Right? The discussions are still on. We don't have a final product. But again, participatory governance, trans women like Ganga Kumari, Rajasthan Police, or even Jyotilal Mondal from Lok Adalat Judge symbolize possibilities of institutional presence and voice. When it comes to health rights and advocacy, there are many groups. I think many of the organizations are also present here. Sangama, Humsafar Trust, Safa for Equity, KHPT-led interventions. Thanks, Maliga and the team from KHPT here, etc., etc. There have been pioneering efforts of health rights advocacy still happening. But again, social determinants of health. If you want to address that, housing, education, livelihood, they are working at the intersections of caste, as you rightly pointed out, class and gender to address root causes of health inequality. Community resilience and mutual aid. Of course, COVID was the best example when trans communities themselves came out and supported, food or rations or even, transporting people who needed oxygen. We saw that in Delhi very much, and there was a lot of people there. In the Indian and global context, I would say that Thailand, Nepal, Latin America, so many countries have been trans-inclusive and the visibility in public health programs, etc. In legal gender recognition efforts, they have gone much ahead and being leaders there. Again, the Transgender Act 2019 has been criticized by trans activists. Still, it is going on for medicalized definitions, a lot of definitions and all that. I'll stop there, ma'am, but I just wanted to kind of set the tone rolling that the work is just started. We need a lot of things going around, and maybe we can take up some of the models in the next round, please. Thank you so much.
Sure. Thank you so much. And just like also for bringing up issues of co-creation, inclusion, lived experiences, and as we go further, or maybe even in the next round, some of you would talk a little bit what that really means, and does it play out differently because we are talking about women-led or women's leadership. So I just want to still stick to that topic a little bit. Zoya ji, would you like to reflect this from a position of, in any case, positionality of power, being a woman in a complex structure and organization? If you can
my reflections will be quite different from what I've heard. I was thinking and I was rethinking in my mind. Actually, this is quite different from what we perceive. Okay, so let me just put it this way, that at the Ministry of Health, because whenever we are looking at any gender transformative intervention or planning, it takes a very different picture because we are looking at implementation through our states, through our UTs. So the final implementation is being done by our last mile ASHA. And that, I think, is something which we have, what I think Ministry has internalized and accepted, that if at the center of any program intervention, we have the ASHA leading, we have almost more than 10 lakh ASHAs now, we have 2.5, 3 lakh ANMs also. So this woman-led interventions for health is something which is sustainable, which will be sustainable, comprehensive, and ownership of the community is also very huge. So that, I think, that is one thing which is very strong point in favor of health interventions, which are centered around, carried out by, supported by it, and followed up by women in the field. So first is that. Second, also for health, for us working with women and child development, again in the sphere of women's health per se, we have our partners in Anganwadi workers. Those again are women. So what I think the experience has showed within the ministry is that if a program is led by women, I would say, frankly speaking, our Secretary of Health is a female right now. Our additional secretaries are females. A lot of our policy makers right now in the ministry are female. So that is kind of promising the fact that this intervention is going to be successful, is going to be sustained for a longer time, because there is, I would not say lived experience per se, but that understanding of how you can strengthen service delivery for the woman here, whether it is a pregnant woman who comes to ASHAs, whether it is a lactating woman who comes, whether a lactating woman comes for immunization for the child or for her IFA tablets or for follow-up of take-home rations for her child, for herself. So every intervention, if it is supported by a woman, that understanding is there that if she delivers, she's delivering for the entire community at her own level. So that, I think, is the strength of any intervention, whether for health or whether for ICDS. And that is where I think it's important. And just to deviate a bit from there, also within our own adolescent health program, we have peer educators who are women, we have counselors who are women, we have now school health and wellness ambassadors under health and wellness program who are women. So what we are realizing is that once you train the woman, it is not just the, I think all of us realize that, it's not just the fact that we are training her, we are training her entire family, her community, and through her, whether it's a school, then there's a sensitization within the school that yes, women's health is important. She needs to take IFA, weekly IFA she needs to take, she needs to have access to sanitary napkins, for her to continue coming to schools regularly, for her to continue talking about reproductive health in schools. So if we give that kind of service in schools, in communities, so I think that kind of gender sensitization for our health intervention is a very strong point on which we are, I think, very comfortable sitting now, because we have managed to decrease the IMR. We have come down to 80 per 100,000 live births. We have decreased the IMR to 28 per 1,000 live births. And that is all because of the comprehensive and sustained action of our field level workers. I think that understanding has to be there, and that is something which is accepted by us also.
Great, thank you. So over to you, Priya. If you want to just build from this, what does it take to get to that level of building women's leadership in the community level, if you want to reflect on that?
Sure, thank you. And firstly, if I also did wonder when Malika first sent me the invite for this panel, what is someone like me who has nothing to do with health really part of this panel? But I also want to sort of call out Malika and KHPT. Way back in 2018 or 19, they were the first to recognize that launching an adolescent girl's career journey is like, really launching the health and financial well-being of an entire community. And that we see happening very, very strongly. So that's what Antarang does in one line. We work with the secondary school ecosystem and make sure that young people in government schools, and they unfortunately become the most disadvantaged, they complete school and they move on to career pathways of their choice. That helps them earn well, not just decent minimum wages, but really get into careers that give them hope and dignity and breaks that intergenerational cycle of poverty. Zoyaji, you already spoke about the role of women in the system. And I'm actually going to go back to, women's and the power of women's leadership. I'm going to take the example of a woman sarpanch in a small village in rural Haryana. Okay, I'm talking about Haryana, and you can imagine what it is like over there. She could have been one of the 30% of women sarpanches who have to be there, and she probably was. That's how she got into that position. But what she did with that opportunity is really, really interesting. She ensured that the schools that were struggling the most with enrollment and dropouts, right, had women principals. And she ensured that those women principals were from castes and communities that were accepted by the villages, right? That's number one. Second, she actually started investing in things like street lights. She started investing in bus stops near the village so that the girls who completed school, they could actually go on to college or vocational education. Right? The third, she saw that if girls stayed in school till 12th standard, it meant they were not getting married till that time. Right? It kept them safe. It delayed the age of marriage. So there were a lot of these sort of, collateral impacts that started happening, and that the SMC heads, she made sure were women, right? The school management committee heads were women. So these were small things that she started doing. Closer to home, I'm going to take the example of a young girl called Yamini, who was from an urban community, poor community in the heart of Mumbai. But a community that was sort of marred by crime. It was one of those communities, if a crime happened, the cops would go there first to, try and arrest whoever came to their, first came to their this thing. And there, she again was from a family where there were 3 girls, single mother, right? The fact that she went on to start working meant, again, she, along with the local councillor who happened to be a woman over there, again ensured things like street lights, ensured things like, the bus stop was well lit over there, that the bus route did not end at 9 p.m. but went on till 11 p.m. Things that you and I would not think of. Again, she did not get married till the age of 26, made sure that other girls over there were also educated, normalized the fact that girls went out to work. Today it is a community where girls and boys go to work, so the community itself has become safer. Even closer to home, something that, Aparna, you also alluded to a little bit. Our senior leadership team is all women, right? And this is also a little bit going against just 5% of India's CEOs are women, but we're a completely women-led senior team. We do have a lot of men, and it's an equitable distribution otherwise. So what this has meant also is that things like paternal leave as well as maternal leave is normal. Flexible working is normal. Of course, you have caregiving responsibilities. It doesn't mean, like you said, it doesn't mean that we are, sort of, what do you say, like sort of slacking off work, but it just means that our work timings may differ, right? And it accounts for all of those things as well. Not that all of this has come without challenges. In the case of Damla, for example, it's a patriarchal society. So how does she, as the sarpanch of the panchayat, even justify that, no, I'm not going to spend budgets on water, on irrigation, but I'm going to spend it on streetlights and bus stops. Hard one, right? Especially when the mothers of boys sort of say that पहले लड़कों को तो नौकरी दिलाओ फिर लड़कियों की बात करते हैं. These are hard mindsets to change, but the conversations start off, right? In the case of Yamini as well, what she's done is that normalized single women-led homes and given respect to homes where there are no boys. Because the girls today, she was among the first in her community to buy a flat in Bombay. We all know how difficult that is, right? Almost close to impossible, but she actually did that for her parents. So, and even within Antarang, because we are women-led, right? The concept of this feminist leadership, Priya, that you spoke about, it is collaborative, right? It is leadership that takes and into account and not right? We're not saying that we are all about building relationships. Can we build relationships and be really data-led and impactful? The answer is yes, right? Can we build resilience and still be very, very efficient? The answer is yes. And I believe that this, feminist way of leading the organization has made all of this possible. So I'll end with that.
Thank you. That was great. And the best thing about speaking last is you have so many points already. And I'm Noina. I'm from Breakthrough. We work with all genders. We believe that a gender normative world is not good for anyone to reach their full potential. And a world in which gender-based discrimination and gender-based violence is acceptable, that world is not going to be a good world for anyone to try to go towards their aspirations, towards their achievements. So that's where I want to start this talk on. And like Priya, I also was wondering why Mallika asked me to speak on a health panel. But then I saw the questions around leadership. And leadership is something that Breakthrough really focuses on. And it believes that with social norm change, with gender norm change, it's not going to be possible without the leadership coming from the ground above, from the people who are working in their own villages, working in their own families, and working on themselves. So that's why the point that Priya was making about feminist leadership, and I want to bring that point in terms of self-awareness. If you are not a self-aware leader, if you are not looking at your own behavior, how you are actually rolling out the patriarchal agenda every day, you are not probably going to be a woman leader that KHPT is talking about here. Yeah, because otherwise we all know that women's leadership is actually a better leadership. There is an RCT to prove it. In around 2012, on Panchayati Raj, there has been an RCT which kind of shows that when women are panchayat leaders, it is better for village development. What makes me even more interested is it is better for adolescent girls' aspiration and being in schools. That gives me even more
hope. And that hope is also taken from the Anganwadi workers and the Ashas. When we work with Anganwadi workers and Ashas in the 566 villages wherein we work directly, including Haryana, Delhi NCR, Uttar Pradesh and Jharkhand, we see that these Anganwadi workers and Ashas are not only learning about how gender-based discrimination and violence is playing in their everyday lives, they are understanding how can they play the role of a bystander, and then they are also becoming role models for the girls in the community. So here is a woman who is willy-nilly into a job, is quickly getting into a position of a leader, which is held up by a group of adolescent girls who are going to her, who are also her support system, and who are also bringing her whenever there is an issue of domestic violence. We are seeing that Ashas and Anganwadi workers are actually helping our girls to negotiate with their parents to be able to be in school for a little longer, to push off their marriage to a later date. So these are some of the things that constantly keep us very interested in. One thing that Aparna brought in, and I want to underline that point, and I wanted to bring in another organization, and I'm from the development sector, and all my years I have worked here, so I always take examples from the sector. Pradhan is an organization which has worked with lakhs of women, and they have worked on economic empowerment. But Pradhan's experiment actually shows, and they woke up to it, that by only working with women and not working on gender, it's never going to make that shift. You are not going to be able to see, so the women who made economic gains, they bought lands in their husband's name, in their son's name, and never in their names. And also the nutritional betterment of those women did not happen. So the produce that was coming from the field was not landing into women's plates. Yeah, that's where gender plays a role, and that's where I really like when Priya asks us to make it messy. So gender is really messy, and unless you are keeping an eye on yourself and how you are playing it out in the field, it's not going to help you in, even if you have a body female leader. Yeah, thank you.
Great. So, I mean, I think really some very interesting comments have come up, and I mean, we did send you questions, but you can deviate and just pick up this discussion from where it is. We're hearing about these different ideas around building women's leadership early in their life stages, giving them the opportunities to have the right career pathways, getting to the point where there may be actually women leaders in community, and how they actually start shifting the ecosystem and landscape. And you talked about bringing others along, lived experiences, being more collaborative, and yet being evidence-driven, performance-oriented. So we heard that. We also heard that models that were run by women were also, maybe they initially were not very gendered in their thinking, but have also evolved over time to become much more gender transformative. And the idea was always that you were really designing your programs more effectively to really think about gender issues. I think that's what we've heard throughout so far. So now back to you. Is everything so great? So could you tell us a little bit about why things are not so great and what else really needs to be done?
So I'll just start off by, I was part of a collation of experiences in, social initiatives over the last 75 years that have made a difference. And we started with Pradhan, Mairada, all of them. We started with Mairada in the 60s, Seva Mandir, Pradhan, and then came up to Gunj, and even covered from CHRP Jamkhed to the Mitanins, and of course the Jivikas, Kudumbashri, all of them. One common thread across all of these, even Selco and others, that they may not have started with women at the center, but willy-nilly the success of all these initiatives, and mind you, most of these initiatives which started in the civil society space have gone on to influence many national programs. So whether it's CHRP Jamkhed or the Mitanins, the ASHA program have gone from that, whether it's work on water sanitation with Gram Vikas, that's gone on to inform. So, but you look at all the programs, they've built on the shoulders of communities, local solutions, but pare that down, it's women who are carrying many of these. And not that they went with the formula that we are going to work with women. It just so happened that change was being driven. And that is sort of reflecting on what you said at the early instance, that do they become door openers? Do they become this and not or? And which is why they take on innovations. They want to learn. They want to change things. They want to be those shifters of norms, you know, of really break boundaries and kind of go beyond. And so when you work with women, there is certainly these intergenerational things happening also. I think we become reductionist when we say, it's like NRH, the NRLM, which built on all of the experiences in civil society. Unfortunately, it's again become such a technocratic, dashboard-based kind of, that it's kind of killing the local level ingenuity that's possible. So since we're talking about challenges, I would see when these civil society kind of embedded initiatives move into government kind of dashboardized techno-managerial programs, it starts affecting that elbow room and doing things contextually, which gets affected. 60 days that the Kerala ASHA workers have been sitting on strike is also because you're really valuing these frontline workers. I've seen Mitanins firsthand and the kind of work they do, taking women out of their houses when they're facing gender-based violence, helping them with their abortions, sitting with them in the clinics. That's the kind of work they do. They're not given, they're not salaried. They're given an honorarium and incentives. I know the government works with all its limitations, and yet these are troublesome areas that women should not become a default key, that informal space mein theek hai, that kind of a thing. There has to be the elephant in the room which has to be addressed. Right. Land rights, that's another space because, women, so again, in Maharashtra, we work with women who come from these sugarcane, the suicide families. And when the land's being transferred, it's given to the 10-year-old son or some other male member. The woman's taken on the mantle of carrying on the agriculture. She's gone into organic farming because she's seen the problems with cotton farming. But she's not given ownership of the land. And majority of farmers today, continue to be men, though most of the farming work is being done by women.
No, you mean majority of the farmers are recognized to be men, but all the women
the land rights. Yeah. I'm talking about land rights.
Women are on the entire
women are doing all the work, right. Yet they don't have the rights and authority. So these are elephant in the room. Right. One more point on climate and so since that's another area where climate finance, the way it's being done, and how the role of GPDP and all of that, there's just, I think we need to, again, when we talk about women as sarpanchas, having influence, women coming into spaces where they can, influence plans. Climate finance, there's hardly any role for local communities to make local adaptation plans. And that's where you're undermining, because women, children, minorities are the people and informal workers are the worst affected by climate effects.
True. So I think that's really important. Also which level of women should be part of the... Firstly, women should be part of the discussions when we are having policy reforms or finance reforms.
Absolutely.
And it should be women who are in the community. So thanks for bringing that up. Back to you, Aparna. I had at that time interrupted you, but you can also just build from here a little bit more on, you talked a lot about the achievements, but like a little bit maybe about some of the complexities of the work that you're doing and what might be some things that you look forward to changing in the work that you're doing through more emphasis on some of the feminist leadership that you were beginning to talk about.
Yeah. Hello? You have to switch it on. Yeah, sorry. Yeah, so, we didn't come to this work from a feminist viewpoint, I must admit, despite being a woman, right? Because I'm a clinician and it's often not a part of our training. And I woefully say this, right? Because technical work does not involve gender as a part of the, training and, management of organizations. And so we've come to this over time, and we realize that over time, we do have women leaders in the organization, but maybe we do not have policies in place that really made it easy for them to implement their work in the best, most conducive environment to get our, the impact, improve the impact on the field, right? So we've really ensured that within the organization now we have gender-sensitive policies in terms of flexibility of work. So all our leadership at every level have flexible, not just timings, it's also policies that ensure that they're able to kind of, work with the teams at every level to ensure that that hierarchy understands, right, that this has to reflect at the ground level also. So it's happening at every level. So we have a system in place where even our Arogya Sakhis on the field are able to kind of come in with a viewpoint on how we are going to manage our programs and modify it to suit what is needed for the field. I'll give an example, right? So we have this whole program called Arogya Sakhi Home-Based Care. It is a program that runs in the most underserved parts of the country where, the maternal deprivation is so much because of all the gender things that we talked about, right? And what we've done is that we've actually taken ASHAs to the next level. They are the ones who are actually taking care to the home front daily, week to week. I mean, they actually take home-based care to the field. Now, because we've done that, their position in the community has really improved. Now, they have actually become like food doctors. So now their voice is heard. They're able to kind of ensure that they can take the community along in the direction that the community needs to go in from the health care aspect, right? So we are ensuring that at every level, we get their voice in and ensuring that they're able to kind of, improve gender policies within the organization. Yeah.
Are we going for a third round of? No, I don't think so. Then let me open my shop. Yeah, I have some things here, which probably again I'll talk. The name doesn't matter, so let it be here, right? When you talk about interventions without models, probably I think we are allowed props. Anyway, so the complexities, let me from the, as somebody said, our co-panelist said it's a health panel, but then I think it is beyond health. But health is it's just a gateway into the society. So even when I talked about our trans women communities, but again, AHF is also working with adolescent girls, especially those who are born out of sex work, and also in the realm of affected and infected with HIV. And in Delhi itself, from the GB Road and other home-based sex work areas, Rala Kanpur, where a 11-year-old or 9-year-old child is even now, as we speak today, sold on the day when she is attaining puberty. So, and that's a tradition. So, we are working in those kind of communities. And when we said about transformative leadership, we definitely believe in making change not by the, if I may call it as a theories that we call, or but by practically being there and then taking these children and educating the environment and the ecosystem that they are in, including parents, including the key opinion leaders, including the guardians of the whole ecosystem inside. And many times what we feel is that I was asking my team members, where is our bucket sitting here? Where's our bucket? you would be wondering what is a bucket doing in a session like this. So when we analyzed about, losing school days on these young children who are menstruating for the very first time, and then we wanted to introduce period panties. So that's a buzz now these days. So we did a community many community consultations, but then in one of the community consultations, the children came up and said, "Sir, unless until you give us a bucket, a balti, as we call it in Hindi, a pail, we are not allowed to kind of, wash the period panties. We are giving them multiple pieces, but then again, to wash that and then reuse, we are not allowed this in our... so what are we talking about? When we look at models of intervention, that's why I wanted to say that the center of the adaptation of a new strategy or an intervention has to be that child or the children. And that is, we've never thought about a bucket. We never thought about a balti to be in a part of our product, which can actually create change in the community. And that became a huge thing. These children are having all this blue labeled Girls Act, we call it that program as Girls Act. And that baltis are now very famous, And then there is no stigma. So immediately that stigma went away. Because everybody knew it was a balti for young women to kind of, wash their period panties. What a reformative change, with one balti. And the idea came from where? Not from this panel, not from esteemed panels of, gender experts or me, who are supposed to be the health experts, but from the children themselves, So I'll stop there with the children part. But again, when you look at the trans women communities and when you're looking at from the angle of HIV, we need prevention. Basically, these are sexual minorities themselves, right? So this is up for anyone here who would like to put this in your offices, in your spaces, wherever. And this is free, and we call it as a love condom. So we have to love condoms. Definitely, and the branding is called condoms. Why I put it here is, just a minute. Why I put this here is because, this is a non-stigmatized representation of a condom. When I ask young ladies or children, adolescents from schools and colleges to, pick up a condom and then dance on music, they are, but this is okay. So what are we trying to say? The last point is that, we also did something called the very first time, free online condom store. What is the problem with a condom? Or getting a condom? Have people ever tried it? Yeah. So that is also available. Free online condom store. Just look us up and then we can send it to you. We are not the condom angels though, but maybe just to do a model advocacy, we can do that. Sorry.
No. Thank you so much. Very interesting. Zoya, would you like to come now or just close in the end? Or you want to come now? Please go ahead.
No, because you talked about challenges, right? So challenges within the health system from the ministry's point of view is actually to continue, because you mentioned about ASHAs, right? So ASHAs are incentivized people, they're not salaried people, but some states, in fact, a lot of the states have gone ahead and incentivized them, especially they are being given maternity benefits, they have a 6-month leave, they have been given extra money. On retirement, they're given lump sum, it's not like a GPF, but a lump sum cash, 2 to 3 lakh rupees by the governments when they performed. Besides that, they also have some kind of felicitation of ASHAs who have kind of prevented early child marriage, delayed pregnancy, supported any kind of teen from abuse. So they have, a lot of states have innovated to support women more and more and support them in continuing doing the work. First is that. Second, I would say I think problem which you face also is for us within our adolescent health program, we're looking at peer educators who are girls, but then how do you get them for a training, right? We do a training that's supposed to be a sub-block level. So we do manage to get the boy peer educators, but that one of the challenges which we face is to get the girl peer educators, because that training is supposed to be held on weekends over 3 weeks, 6 days. It's a 6-day training. So then we have to ensure that the A&M knows the parent of the girl, the parent is comfortable sending the girl for a whole day training where boys are also going to be there. So that is the challenge which we keep facing when you're training young girls. Third is the challenge of ownership of menstrual hygiene scheme, in which we support states to procure and distribute napkins through schools or through community platform. But despite the fact that we know that NFHS shows that there's a 20-point increase in availability of menstrual hygiene products, A lot of girls are using it. Despite that, there still remain gaps. And that is something for us to really worry, that if we have reached this state and still girls are not getting access. So there are actually 23% girls who don't have access. So if you look at it from that way. So that is something for us to worry in a country in which we are spending so much of money and there's so much of awareness. And these girls, in fact, there was a very good discussion which we had with peer educators. So they still don't perceive access to sanitary napkin as something which is a right. They feel that there's something which is special being given to them. And that is not something which should be for our young growing girls. There should be something which is given to them as a normal thing. So, and then to convince them that, okay, if you have extra pocket money, you do not spend that money on topping up your mobile, you rather spend it on your own reproductive health, is not something which is understandable by them. They rather go back to using that old cloth, something and then spend the 50 rupees on topping up the mobile. So that whole perception for a girl that your health is as important as the other male member in your family, or as your brother, or as anybody else, has to be something which has to be ingrained and right from school. And that's why the importance of school health and wellness program. Your health is as important as anybody else.
True. I'll keep it really short because I think a lot of it has already been said. But I'll sort of maybe focus a little more on not just focusing on what we believe is the problem, as you know, both Dr. Rizvi as well as Sam did talk about a little bit, right? So the focus for us, while it is to ensure that more and more women enter the workforce and formal workforce with benefits, what we realized is that then we need to remove the impediments around that. And what is not necessarily impediments alone, but also prepare men for that eventuality of having to share space. Today, that's the most difficult, right? How do you get boys and young men to say that, okay, this too is somebody who has equal rights to enter the workforce as I have. So I think really now, how do you, instead of just saying Beti Padhao, how do you sort of move that to say that, okay, girls need to start working as well and it's normal? Or how do you prepare men, especially fathers of daughters, when the daughters are born, they're the most vulnerable, from that point itself to start talking about how do I now make sure that my daughter is going to not just have an education, she's going to get married late, she's going to start working, she's going to be financially independent and break the cycle of dependency. So I feel those are some of the larger challenges, and they're structural, they're difficult. Do we have the answers? No, but we know we need to start working on them.
Yeah. Pick up nicely from there. Yeah? Absolutely. So, you know, Priya and Zoya ji, they have really made my job very easy, because gender norm is one barrier that kind of stays in the people's minds. I think it is not about women not being able to take leadership. It is about the society's reaction to that leadership. So it is not about that women cannot be mobile. It is people's reaction to that mobility. So women's mobility is a very big challenge even now that we are facing. Intergenerational dialogue is a very big thing. This is something which in India we often say that our families are our basic structures. But you know, when we did a study in 4 states, we found that not even a single family, all the members sit together even once during the day. Yeah? When I say this, you know this is true. Because in a village home, they don't eat together. It's a very urban phenomena that you eat together. So the intergenerational dialogue becomes extremely important. The intergender dialogue, it is so segregated. Boys do not know how to handle a female boss. Yeah, that's a very big question that is coming. They actually will like to give a resignation than to ask for an extra day of leave. Yeah, and those are some of the things that we are handling. However, working with boys, we know that gender attitudes change. It's actually changed much faster in boys if you work with adolescent boys, and they stick. Yes. We are seeing that if you work with them regularly for about 2 years, it can stick for up to 5 years. We are now going to have a study report in which we want to see whether those boys become better
partners in marriage because their attitudes around women working outside home, men working at home, and women continuing education have stayed the same. Yeah, so that's a big hope, and I'm getting goosebumps actually. I hope that those women's lives are going to be much better than the women who are now doing 6 times more housework than any man that is spending at home today. And that's all of you. Yeah, thank you.
I mean, and what's nice is that you have a cohort that you've worked with, you can go back and you can actually have evidence and data from before. So that would be really, because that's the kind of evidence we do need. So I think we're going to open it up to the audience. And just before that, I just want to kind of summarize some key things that have come up from here, which are important. I think what we've really, obviously, we've heard that some of the organizations that you're representing have really tried to make the workplace much more gender sensitive. You've really taken the cues from women and what women need and brought it back to design policies and accommodate women's needs in a much more substantial, transformative way in the organizations and the communities. But of course, there's much more that needs to be done. And one of the things that one is hearing is the need to really change societal and community perceptions of the value women bring in the sectors that they're working at every level, because a lot of that work is still invisible, underpaid, underappreciated, and always is considered as low value, low productivity, while we know that's probably the most productive work at least in the health sector we've kind of talked about. So I think that's really important. And also, I think one thing that hasn't been discussed, but I also want to put on the table, is wage parity. And I think we really need to be thinking about the amount of work women are doing and are they getting compensated even in the jobs that they are assigned, especially when we talk about health workers. Some of you did bring that up, but it's really important that there is no career progression for health workers in the health system, and there is no wage parity. And in fact, they're hardly paid, or they're not paid at all. So I think that's a really important thing. On one hand, we can't be talking about women-led models and women's leadership and make it very, very positive, because this is a way we're going to have major transformation, and not really put the money where it should be. So with that, I'd like to open it up if people have questions. I've been getting so many messages from behind, open it up. I've not been to any panel today which had Q&A, so yes, let's open it up. And one request, please be succinct and really address a question, or even if your comment is there, please be short. Yeah, please.
Hi, good evening, everyone. My question is to Zoya ji. I come from a media and entertainment background, and while I led the company, which was 200 people, and we expanded to 20 countries and all of that, I didn't realize what I was doing as the woman CEO. But I was inspired by my 16-year-old niece, who 2 years ago started a program of distributing sanitary napkins in schools. And she saw that attendance in schools went up by 3% in 1 year alone. And this is in an urban setting in Mumbai. So to your point where, giving adolescent girls the confidence to say that, hey, that 50 rupees should be spent on my health as opposed to my mobile top-up, I actually believe that a comment that she made, which is, hey, if soap, water, and tissue paper is free, why are sanitary napkins charged? Because at that point of time, what we're doing is when a girl stops topping up her mobile, she falls out of a system of information. And she falls out of a system where she's able to keep up with her peers. And I think enough has been said about the period tax, but I'd love to get your thoughts on that.
Great. Maybe we take around 3-4 questions, and then we bounce it back to the panel. Both of you, sorry, I don't know your names. So. Okay, one person there and there are 2 here. Okay, go ahead, please. why don't you go ahead, Oh.
Okay, this is much better. I have a question for Jai Padma ma'am. When it comes to justice, can you speak a little bit about, in practice, are women prisoners' health being looked after, and what about rehabilitation for them? Is that on the table, and is there funding for that?
There are two people on this side. Can you just quickly pass them the mic? Yeah. Just a second, yeah, please. Yeah.
My question was more coming from, women in leadership perspective. So for women in workforce, unfortunately, the times where we are expected to, where men and women are expected to, give themselves fully, commit to the work, give themselves fully, work overtime, and sort of achieve their career progression is also the time that sort of collides with that, peak reproductive period.
So what's the question?
So the question is how, probably if you can maybe share either your personal reflections, being leaders in this sector, or how do you see what can be the future workplace policies that can support women better, exceed in their careers with their, as like as their male equivalents. Thank you.
Sure. Do you want to ask your question now, and then we'll give it back to the back?
I think a lot of people are going to resonate with what I'm going to say now. So I come from a community health background, wherein we talk of individual level, family level, and community level interventions. So since there are such esteemed panelists from the gender equity background, ma'am, I want to ask that, women for the longest time, we've been kept away from employment, that हम लोग एम्प्लॉयमेंट को ही अपनी आज़ादी समझ कर बैठे हुए हैं. हमारी आज़ादी का दरिया इतना छोटा कर दिया गया है. तो now women are going out, we are being employed, all socioeconomic strata, but we still continue to follow the gender specific roles in the house. So from all the generation of women, this current generation, my generation, we are having the maximum amount of, workload when it comes to physical labor as well as mental labor. So I want to ask that, is there any family level intervention that you've come up with? Because we live with 3 generations of families, 3 generations of people, and the generation to come, which has worked out or will probably work out, because this is quite a debate. Thank you.
This is the last question.
I'll keep my question short. I interview a lot of people. We have a gender-based focus in our work. I always ask a question, are you a feminist? And I'm very surprised by how many people get allergic to that word.
Okay, but is that your question to the panel?
What would the panelists say to people working in the healthcare sector about the word feminism, and how should people come to a mind space of being able to say unabashedly that, yes, I'm a feminist?
Good evening. Myself Shahid Amal Laskar. So just a small reflection from the field. When I see our ASHA workforce, distributing, home delivery of contraceptives, supporting the other women to make their healthy choices, and on the other side of the spectrum, when I also see like the ASHAs, those who are coming for the meeting, or maybe taking the woman to the hospitals, all the male folk in the family, they are supporting her up. So you all people are working in the field of space of gender and addressing, engaging with the woman. I just want to say, are the males too busy in their workforce, or where is the fine line in which we are all together bringing them on board to make a collective process towards that? Thank you.
All right, so there were a lot of questions. I'm going to just ask you all to go in this order and respond to whichever one that you want to. Yeah.
On the prisons one, I mean, honestly, I wish you all know the data. There's just such a backlog of cases that there's huge. Prison reform is another piece. But on the specific one, honestly, very little. I think, yeah, whatever is possible, but these are very cramped spaces, unhygienic, just with the number of women prisoners that are put there with their children often. See, there's two things that our organization tries to do is to kind of have the best lawyers at all levels possible. Feminist lawyers who can deal empathetically with them. But the social rehab part is the toughest. You know, once you've got that stigma of having served in jail, how do you reintegrate back into your community and society? There's not enough happening. Funding is a challenge. I mean, gender funding as such, don't get me started on that. Read AVID reports and everything else. I mean, it's just, yeah. Honestly, it's just kind of going down further and further. I hear European countries have whittled down gender funding. Yeah, US is seeing its own manifestation. So unfortunately, we have a big fight to go, but I'm glad you're raising these questions. And I think the more we question, the more we'll arrive at some ways of working through. I also wanted to, I think Nayana spoke about men and boys really, but you know, how we need to have these collaborative spaces. I mean, in my experience has been that it's important to create safe spaces, separate spaces initially, because that's the only way to get young girls out, women out, to really talk about what's affecting them the most. But eventually, don't keep these as exclusive mythical clubs, because that does create much bigger backlash. There's much higher resistance if you're not going to integrate. On your point, there's this program called Punk, where young brides who are actually child brides, 15, 16-year-olds getting married, and they came to this organization that we were working with, and they said, "हम लोग को सिलाई सीखना है." And of course, this organization initially was, "नहीं, हम feminist है, हम सिलाई नहीं सीखेंगे, तुम लोग को computer सिखा देंगे." These girls said, "नहीं, हम लोग को सिलाई सीखना है, हमारे गांव में टेलर नहीं है, हम लोग को अच्छे-अच्छे कपड़े बनाने हैं, पहनने हैं, तो हमको सिलाई सिखाओ." They ran these 4-month-long Silai programs. Every Saturday, the organization inserted this whole session where they would be taken to the police station or talk to a lawyer or talk to a healthcare professional, talk about their reproductive health. One Saturday, they will also, or a couple of Saturdays, they'll call their young husbands who are in their early 20s or whatever. They'll have these couple session, and that changes things. I mean, again, it's part of this inclusive dialogues that we are creating. But when young boys like the ones Nayana spoke about, who are already oriented to it, and maybe they'll make better husbands, but these young men who get to appreciate their, what the burden she's carrying in a different light, things start changing from there. So yes, there is yet hope, but we need to create more of these inclusive spaces. Yeah.
I have to apologize. I was distracted in the previous question because somebody from my family is very ill and I have to rush out immediately after this. Admitted, I'm sorry about that. I was getting calls when I was answering. But a couple of points I just want to make, right? A woman's development is only possible, or a cognitive ability can only be developed for the future if malnutrition is looked into. There's a huge silent epidemic going on. If you look at, so in our own programming, we realized that we never stratified child data to understand how children were doing. It's years that we're not doing that. And we realized later on that if we don't do that, we're realizing that the girl children always did worse as compared to male children. And that's why we included programming that actually ensured that the nutrition parameters of girl children were actually improved over time, right? So this is one thing I really want to bring out to the whole audience here. The gender has to be married to health in various ways apart from all the spaces that we're talking about. Secondly, very important point I want to talk about is that gender has to be part of all conversations of livelihoods, etc. I'll just give you the migrant collectives, right? You have these migrant collectives all through the country that work on livelihoods of migrant men. They have this whole collective, huge task force working. But the women and children who are migrating along with the men, no one looks into. And their health parameters so poor. And if you look at even urban populations, migrant population form the major chunk of women and children that we serve. And so that's, you really need to marry gender to all aspects of livelihood, irrespective of, not just spaces where women form a majority of the workforce, right? Then the feminist, this reproductive thing about the fact that, I find this in our leadership, the fact that you have a lot of women who are very good at their work, but then they're at the stage of the life where they also have to fulfill the reproductive function, right? And the senior leadership. So within Arman, you will find a lot of very senior leaders have been given extremely flexible, work, circumstances, so that they can actually bring in their best selves, right? So we have leaders who are working 3 days a week instead of 5 days a week, because they are till the child is particular age, and then they come on full time. And because they know Arman has given them the conducive environment to be able to bring their best selves despite their family roles to be played. And no matter what, we may talk about men being involved, men doing all that is required, equal roles at home. It doesn't work out. It doesn't work out. Women do play a bigger role. And I find this with, so because Arman does tech-enabled solutions, so we have a lot of women from technology world. You might think that IITians, women who are IIT, engineers, and IIM grads would have absolute, agency at home. It doesn't work. It is not like that at all, right? So then you have to, if you keep, talking about, and you also give them a lot of guilt then, right? So it's so important that and they, 3 days of their work is comparable or better than 5 days of, yes. So we really are, and about feminism, right? We are unabashed feminists. And we actually have in Arman, right, we've done a whole, I must say this, right, we went through a whole review process in Arman on what gender means to every cadre of our workforce, from the lowest, healthcare providers in the field, health workers, and to the senior most leadership. And we were astounded by the results, right? For the same program, we had one view which said that we are too gender transformative. And then there was another opinion at the extreme end which said that we didn't consider gender at all. So within the organization itself, the viewpoints of what gender actually means, what gender transformation means, and what, how does a program serve women and children better, the viewpoints can differ so much that we are doing a lot of work within the organization to ensure that we bring everybody up to speed about not just the understanding of what feminism means, what feminist led workspaces mean, but also how men can then come into the conversation. We're doing a lot of work within our programs also and within the organization itself. Yeah. So I'm going to leave, right? So sorry, I just cannot. I was very distracted. I didn't even realize what I was saying because my mom is.
I would like to thank Dr. Aparna today for her contribution. Could you just hold up for a second? We have just a token of appreciation.
Sorry about that.
I would request our trustee, Taskin ma'am, to hand over token of appreciation to Dr. Aparna. Please, thank you.
Yeah, 30 seconds. So I was not a feminist. First point. I became a feminist or a newer feminist with 2 daughters born and a 98-year-old mother-in-law at home for me to take care of, and then my bums getting sore by the kicks of my daughters. Every session, this is one thing that you said about family discussions. What we do is like in our table topics in a family discussion with my teenage daughters is always about condoms, sex work, gender-based violence, how you have to survive, right? Second point, 30 seconds, right? Catch them young. We have been, misusing these words for many things. So if you want to have transformative, leadership, then catch the men, the boys young. So under the Girls Act program, we also have the Boys Act program, wherein the collective of the boys around the society in those areas are, brought in, and they become ambassadors, and they say, my sister here is menstruating, she needs rest. That is a kind of transformative leadership that men can come in. For the, I don't see the question. It's okay.
Fantastic. Thank you. Now, quickly, I'll just reply to what you said. I think you just missed the context. The context is that it's not the 50 rupees which is going for the internet, it's the fact that she has to value her health also. And that is and because a lot of schemes in government give sanitary napkins free, some of them actually cost also. So for us to say that, and it's about beginning about a behavior change, not just giving napkin, but also to put her health above everything else. So that is the main context. And okay, then she's gone. She said, yeah, how do you manage? I thought I'll give her something, but let it be. Okay, something. Like he mentioned, it's in all our programs we involve the men also, because you don't, and this change of men accepting so-called responsibility within a family structure will come only when an entire generation passes off and the next generation comes. So if we expect that we have a classroom and we tell them, "Tumhe bhi ghar pe khana banana hai, kapda dhona," it's not going to happen. No, unless the boy sees his father, his chacha, somebody else also do, and do it happily, and his mother also helping out both ways. So it's a lot of time, it's what the children see at home. They will learn something in one place, but what they see is a live reality, something which they bring a change. Hence, this change, you have to be patient. This whole ownership of men, women working as partners in a family will take time, but then I would say it does work out a lot of times. I mean, it does work.
Textbooks have changed. Yeah. Finally,
Yes.
images are different.
Yeah, it's not the woman washing and the man going out for work.
Yeah. Nothing more to add except to say that, you know, the question on, well, it's also peak reproductive age when we're all climbing up the ladder. I think ask for what you need with objectivity and clarity. I think we don't ask enough. But if we ask, and if we ask with clarity and objectivity, I think we will eventually win that battle as well.
Yeah, great. I'll take yours. Yeah. So, I thought that, you know, when you asked that question about like, this is a feminist panel and we must bring our personal experiences. That's what you were looking for. So I have been a mother and been a single mother for most part of it. And I have raised a child working all through the years, right? He's in MPH. He's going to be one of your colleagues, not mine. So, what happens is that we also learn from our experiences. I have faced a insurmountable challenge in carrying a 2-year-old to Koraput and Venkatgiri and other parts of the country. So I now make sure that my colleague is going to get another support to carry her child to various different areas. If she's coming for a training, there is going to be another person who is going to be paid for with that person to be there. All our colleagues are welcome to bring their children to our workshops. And I just want to say this, that many of our men colleagues also bring their children to our workshops. And that's like the whole place enjoys it. This is how we are going to change, and I am a bit impatient. I really did not expect that to happen with her. I thought that was my life experience, and 20 years have passed, and she's going to have a better life. Yeah, and I really want to make it better for all the girls who are coming along with us. All my colleagues should have a better life than I had. That's my feminist promise. Yeah.
Okay, all right. Well, I mean, I'm not, well, thank you. I think the audience has been really kind and good and patient and given all of you some time. And I'm sorry I've had to rush people. But just to say, I mean, like, a lot of ideas have come up and a lot of concepts have come up. It's really been actually a conversation around gender and power and how do you start shifting that. And I think we've heard that it starts at home, it starts in very discrete, small, incremental ways, but obviously organizations and larger ecosystems that employ women are very important. I mean, organizational and workplace policies are really important. I think while societal conversations and family conversations are important, but what happens in institutions, what policies are provided for, what processes, and for institutions that are informal, like for women in the community, how do they feel safeguarded and protected? So we can't only talk about formal organizations. So I think there's a lot to be done, but also there is a lot being done. Yes. So why don't we take from what's being done and really say that this becomes a template of what should be the norm, informal and informal institutions. So that, and I do think that there's, you know, there's lots and lots of conversation around engaging men, men as allies, men as supporters. I mean, we have all of that, but men need to give up space so that women can enter into spaces that have always been dominated by men in leadership. And if it means that sometimes it may be uncomfortable, that's all right, because women were never there and they were very uncomfortable for centuries before. So I think, like, I'd like to say that yes, men are allies and they are important, but men also should be allies in terms of actually giving space up so that women can actually enter. And I do think we've heard very important models and examples of women-led development and how that can be transformative for health equities, which was really the point of this panel, that there are very important aspects of women's leadership, which are actually how one would define feminist leadership, about being collaborative, about being inclusive, about really being thinking bottom up and grounded ways in which you design programs to achieve better outcomes. And we have good models. So I think we want to leave this panel with the idea that there are very strong approaches that are being done, and we should take them to wherever we are and the kind of work we are doing. So thank you for that, and thank you.
Thank you, Priya. And first of all, thank you to the esteemed panel for such a wide and rich deliberation. And thanks to all of you for making time to the last session. I mean, it is really wonderful to see all of you and contributing to the session. And last but not the least, thank you Wipro Foundation for supporting us, organizing this. I would request to the panelists to stay back a bit. So we'll just hand over token of appreciation. So yeah. So I request Taskin ma'am to hand over token of appreciation to Jaya Padma. Next. I would request ma'am to hand over to Sam. Thanks, ma'am. I would request our another trustee, Rasekar sir, to please come forward, please. And hand over the appreciation to Dr. Joya. Next up, can I request to hand over to Priya? Thank you. Next up, to Nayana, please. Last but not the least, Priya Nanda, which is our excellent moderator for today. So thank you, Rasekar sir. Thank you, Taskin ma'am. So I would request Priya and all the panelists to just hold on. We'll take a photo session with along with.